Good morning, everyone, and welcome to the fourth day of the Legislative Commission's Budget Subcommittee budget briefings, and our first day back here in Carson City. You'll notice members on the dais will be using their electronic devices, their computers, as they follow along with the meeting, but I will remind everyone, both the members and those that are joining us in the audience, to silence your electronic devices, put them on vibrate. We will have the following budget briefings, and they will be high-level budget briefings today. The Department of Health and Human Services, the Division of Healthcare Financing and Policy, the Division of Welfare and Supportive Services, the Division of Public and Behavioral Health, the Division of Child and Family Services, Aging and Disability Services. We will try to take a break for lunch at approximately noon today. It will be an hour-long break for lunch, and then we will return. We will have two opportunities for public comment, one at the beginning of the meeting and one at the end. If you'd like to call in for public comment, that number is 888-475-4499. Today's meeting ID is 835-3765-6197, and then please press pound. We ask that you limit your comments to just 2 minutes. I am Assemblywoman Danielle Monroe Moreno, and I welcome you to today's meeting. And we will get started with the first item on our agenda, and that would be our roll call. Committee Secretary, will you please call the roll?
Senators Buck, Canizaro, Dondero Loop,
Here.
Neal, Wen,
Here.
Stone, Taylor, Titus,
Here.
Assembly Members Anderson, Backus, Brown May,
Here.
Dickman, Hafen,
Here.
Hibbets, Howdigi,
Here.
Koenig, Mosca,
Here.
O'Neill, Torres Fawcett,
Here.
Watts, Yeager,
Here.
and Chair Monroe Moreno.
And I am here. Will you please mark Senator Canizaro present when she arrives? Again, welcome, and as stated, we will start with the first item on our agenda, or second item, which will be public comment. If you would like to make public comment and you're here in Carson City, I invite you to the table. If you're joining us on the phone line, and if you happen to be,
You are in the meeting now.
we are all in the meeting now, if you didn't know that. Yes, we are. And we will start with public comment here in Carson City. Good morning. Remember to state your name for the record, and we're ready whenever you are.
Okay, can you hear me okay? My name is Shauna Ross. Do I need to spell that? Yes. S-H-A-W-N-A, last name Ross, R-O-S-S.
You are in the meeting now.
And we continue to be in the meeting.
Thank you for taking my public comment this morning. As I mentioned, my name is Shauna. I am a speech-language pathologist and a pediatric private practice owner in Reno. I've had my practice for 19 years. I also serve as a state advocate on reimbursement for Medicaid and private insurance with the Nevada Speech-Language Hearing Association. I act as a liaison between our state association and our national organization. So I am here to ask for pay parity between provider type 34 and provider type 60. Provider type 34 is therapy, and provider type 60 is school-based services. Right now, there is a discrepancy with the CPT codes between the two provider types, and school-based services on average are about 8 to 10% higher reimbursement rate. Our training, education, and licensure are all the same regardless of practice setting. And so increasing those rates, even though it is a small amount to match provider type 60 would be a benefit to provider type 34. And I also want to mention that in my entire time of doing this, our rates have not increased, our Medicaid rates. And in fact, we've weathered a couple decreases. So a rate increase would be wonderful. And then the second request that I have on behalf of NISHA is there are 3 codes, CPT codes, that are not reimbursed for provider type 34. They are 92612, which is flexible fiber optic endoscopic evaluation of swallowing, 92511, which is nasopharyngoscopy with endoscope, and 31579, which is diagnostic laryngoscopy with stroboscopy. And it's our understanding that these codes are in the Medicaid fee schedule and that physicians can be reimbursed for them. However, it's not reported in Southern or Northern Nevada that physicians are completing these procedures. So it's difficult to recruit and employ a robust workforce when receiving payments of 0 for this highly skilled work. There are providers in Reno and Las Vegas that are doing these procedures. So those are our 2 requests. So pay parity with provider type 60 and provider type 34, and including reimbursement for those codes in the fee schedule. So thank you.
Thank you. You can go ahead.
Hi, my name is Melissa Chantel Harry. Do I need to spell that?
If you
Yes,
can,
so
that'd be great.
first name Melissa, Melissa. Last name Chantel Harry, Chan as in Nancy, S as in Sam, ELLE-HARY. I'm here today, good morning, thank you for taking my public comment. I am a death doula in the Reno, Sparks, and Northern Nevada area. I'm a member of the Doula Co-op of Nevada, and I serve on their board of directors. I am not here officially as a representative of the co-op, but I do have their full support. As a death doula, I support and empower my clients through one of life's most important transitions and experiences. My job as a death doula is to make sure that they have all of the information they need, know that they have different options, to empower them through educating as far as what those options are, and then to also advocate for them. So I provide social and emotional wraparound services that I can tell you from my personal experience are lacking in the systems of care that we have right now. So based on my work specifically, I can tell you that there's an acute need for more robust care at the end of life. I have been in conversations with hospice organizations, community health workers, insurance brokers, and others, and there's a general consensus that more is needed. Nevada's senior population is growing rapidly. The trend is expected to continue, and the percentage of seniors in this state will increase significantly, and specifically in 2027 and beyond. We're going to have the largest amount of senior citizens without children to care for them at the end of life. I have clients now who don't have children to care for them, and then some of the systems that exist, they're falling through the cracks. They have no one to turn to. They don't have support when it comes to managing basic paperwork. And I work with clients in a number of ways. So I work with people that you might call young and healthy, so that they're fine, but we're talking about the end of life. What does a good death look like? What will it take for you to walk away and leave or transition in peace? And what are the things that need to be attended to, both logistically, legally, emotionally, and spiritually? I sit with people in an acute diagnosis. So when they're actually ill, I help by supporting with light housework, errands, food prep. I am not a medical provider. I am not a therapist. And I'm not a legal advisor. But my job is to support in the social emotional wraparound services that are missing. And one of the things that I also do is then sit vigil and teach people how to hold space when people are dying. Some of us have spiritual support for that, and some of us do not. And a lot of our culture doesn't hold space for this really awkward and deeply intimate time. So that is something that I offer to people. Over the last 200 years, death has become really medicalized, and this is what death doulas have in common with birth doulas. The work itself has been really medicalized, and there's room to approach the care and offer different things that both save costs and improve outcomes. I'm here today, really, to plant seeds for the future. So I believe and dream of a future where death care is supported and reimbursed by Medicaid, Medicare, and private insurances. There is a business case for providing basic end-of-life support. I don't know if you know this, but none of us are getting out of here alive. So I really think that we can do this a different way that's more supportive to the soul, the spirit, and the people. There's a lot of people out there, and we have a higher percentage of people who are in their older decades here in Nevada, and I think we can do a better job taking care of them. And the way that we die sets the table for how others die, and I think that we can do something really important with this work. So I thank you so much for your time. I sadly won't be able to stay for the whole meeting because I do have to, my CASA kiddo is getting adopted soon, and so we have a very important hearing. So I look forward to hearing and learning more about all of you, and I think you're going to see my face around here a little bit more. So have a great day, and thank you very much.
Thank you, and congratulations on the adoption. Seeing no one else here at the table in Carson City, we'll go to Las Vegas for public comment. Remember to state and spell your name for the record, and you have 2 minutes.
Hello, good morning. My name is Denise Robinson. I am the mother and the guardian of my son, Ryan Robinson, who currently resides at the Intermediate Care Facility at DRC here in the Las Vegas campus. This past summer, Ryan had a situation regarding chrysalis at his job training program and came home with unexplained bruises, scrapes, and scratches from his knees down to his feet. Since this was not the first incident of unexplained bruises and marks, my husband and I filed a report with the North Las Vegas PD, Adult Protective Services, Notified Chrysalis, DRC, and finally the Department of Aging and Disability Services. All of these protective agencies could not tell me what happened to Ryan while he was in the quiet room, and I quote that. There were no cameras at the JDT to review. Staff was not sufficiently trained, and I believe the investigation into this issue was less than adequate. I will never know what happened to my son in that quiet room, but I can say that all of these agencies have failed my son and myself. Budget cuts for these programs would be absolutely futile at this time, since there isn't enough money in their budgets to support these individuals appropriately. There's not enough pay for the staff. There's not enough safety measures in the job training places. And frankly, no one even seems to care about what actually happened to my son, but more than that, they care about how they can improve their JDT's programs. And even though that makes sense, it's important for me and you to know that these are not just social services that you're providing for my son. All of these residents pay you their Social Security, pay you through their Medicaid, and you people who are serving them are just that. You are their employee. You work for them. And when we are not able to find out what happened in a quiet room to find out why my son was in the situation that he was in, it's absolutely horrific. I will never know what happened to him in the quiet room, and I will have that with me my entire life. But I want to make sure that this never happens again, and that you are aware that there are bad things happening to our residents out there in your programs. Thank you.
Thank you. Next person.
Hi, good morning. My name is Chrissy Costanza, CHRISSY, last name COSTANZA, and I am the sister and guardian of a developmentally and intellectually disabled brother, as well as some physical disabilities. And we both currently reside at Betty's Village, which, for those of you who are unaware, it's a community that was created for individuals like my brother in mind, so that when us caregivers pass on, we have the peace of mind of knowing that our loved one is in a safe environment where they will continue living and excelling. Unfortunately, this is no longer the case. Desert Regional Center's current budget crisis is affecting not only my brother, but the tight-knit community of Betty's Village, and also nearly 100 other individuals statewide. Because those in the 1 and 2 bedroom ISLAs have more profound disability, and require a higher level of care, they are now being discriminated against and told they can no longer continue living in the place they call home and will instead need to move to a 3 or 4 bedroom group home, many of which, my brother included, have previously come from these unsafe and unhealthy environments where they were scarred both mentally and physically from their time there. We're now going backwards and would like them to relive these horrific experiences where many of their health and well-beings were being jeopardized. The impact this news is having and will continue to have on the individuals being forced out of their homes, as well as the rest of our community, is just absolutely heartbreaking. They finally have a place of their own and a community of their peers that without Betty's Village, they would never have gotten. They are striving, have stability, and living their best lives, many for the first time. Being a resident in this community is the opportunity of a lifetime. It's an answer to many prayers and a dream come true. This is all being destroyed by the budget crisis. Watching our loved ones and community crumble is something I never thought I'd see. No one feels safe anymore. Everyone is on edge, just waiting for their number to be called and life as they know it to change. I urge you to please consider funding the 1 and 2 bedroom ISLAs. Thank you.
Thank you. Next person.
Good morning, Madam Chair. As members of the subcommittee, Stephen Cohen for the record. Stephen with a V. Cohen is in the now former Assemblywoman. Ditto as to form. My written comments will follow as we wait for the presentations, both as to today and Wednesday's IFC. Thank you.
Thank you. Is there anyone else at the table there in Las Vegas that would like to make public comment?
Hello.
Go ahead.
Sorry, can you hear me?
We can hear you.
Good morning. My name is Marcus Browers, Brouwers. I'm an attorney with the Legal Aid Center of Southern Nevada, and I have the privilege of representing children in minor guardianship cases. And what I want to tell you is when an aunt or grandma or adult sibling asks the court to become a guardian over a child, I go to that child's home to meet with them. I go where they're most comfortable, because obviously talking to a lawyer can be intimidating or awkward or boring. All lawyers, not just me. And I want to make this an easier experience for this kid because we have to discuss some unpleasant things. And I can tell you that in going to hundreds of different homes and meeting with hundreds of different children, that the difference between a child who ends up in a minor guardianship case and a child who ends up in a dependency case is initially nothing. They have the exact same initial experience. These children have parents who are addicted to opioids, meth, parents who are homeless, absent, deceased. These children experience domestic violence firsthand. They go hungry, they miss school, they miss doctors, they're sexually exploited. But in a dependency case, the state steps up. They provide support to that parent to try and stabilize them, provide support to that child and that caregiver. But in a minor guardianship case, it's whatever granny can scrape by with. Apologies. Because the physical, emotional, and financial burden of supporting a child, often unexpectedly, falls on this caregiver, but you can do something about it. I humbly ask that you support E-254 and E-255. Help keep these kids in their homes, provide a bit of stability, help give them a bit of normalcy, and give these kids a chance to be a kid. Thank you.
Good morning. For the record, my name is Leah Dodds, Leahdods, and I'm a director at Foster Kinship, Nevada's statewide evidence-based kinship support nonprofit. Foster Kinship's mission is to support the 30,000 children in Nevada who are in kinship care, living with a relative without their parents in the home, most of whom are not in the foster care system. Our focus is to ensure that these children experience stability, safety, and long-term well-being. Foster Kinship strongly supports the following budget enhancements, E-254 and E-255, Thrive, which are aimed at strengthening foster care prevention and improving TANF services for kinship families. Kinship caregivers play a vital role in providing stability for children who might otherwise enter the foster care system, and we must allocate resources to support these families effectively. We urge full approval of the proposed funds to support initiatives that will expand financial assistance for kinship caregivers, reflecting the demographics and financial realities of these families, improve access to essential benefits like nutrition assistance for children in kinship care, remove barriers in accessing support, such as unnecessary requirements that hinder families' ability to receive timely assistance, and lastly, increase outreach to ensure every child in kinship care is receiving the support needed to thrive. By investing in these preventative measures and TANF program enhancements, Nevada can better address the unique needs of kinship families, many of whom are directly impacted by the opioid epidemic. Supporting these families reduces the likelihood of children entering traditional foster care and ensuring more safe, stable, and nurturing homes for them. Foster Kinship remains committed to partnering with DHHS and other stakeholders to advocate for and implement these much-needed changes. Together, we can ensure that kinship families have the resources to thrive and that children can remain connected to their families and communities. Thank you.
Good morning. My name is,
Go ahead.
okay, thanks. Good morning. My name is Tara Raines, T-A-R-A-R-A-I-N-E-S, and I'm here on behalf of the Children's Advocacy Alliance to express our support for items E254 and E255, expanding temporary assistance for needy families, for kinship caregivers, and preventing foster care. The Children's Advocacy Alliance is an independent voice for Nevada's children, advancing systemic change in areas of early childhood education, children's health, and child welfare. We achieve public policy wins through collaboration and collective impact within the community to ensure every child in Nevada thrives. This policy change will have a profound impact on the thousands of children in Nevada who rely on the care of grandparents, aunts, uncles, cousins, and other relatives when their parents are unable to care for them. Kinship caregivers provide safe, stable, and loving homes for children in crisis, often stepping up with little notice and without the financial resources necessary to meet the children's needs. Unlike foster parents who receive state support, many kinship caregivers take on these responsibilities with no financial assistance. Despite facing the same challenges of raising a child, providing food, clothing, school supplies, and medical care, by extending these benefits to families, you are ensuring that children can remain with trusted relatives rather than being placed in the foster care system simply because of financial hardship. This saves the state millions over the years in care for these youth. This decision not only strengthens families, but helps children maintain the important cultural and community connections, reducing trauma, instability, and adverse childhood experiences. And for caregivers, particularly those on fixed incomes like grandparents, these funds will provide essential relief, allowing them to meet their child's basic needs without being forced to choose between rent, groceries, and medical care. The expansion of these benefits is a critical step in supporting Nevada's most vulnerable children, and we thank you for recognizing the value of kinship care. Your commitment to keeping families together and ensuring financial stability for caregivers will make a lasting difference on the lives of Nevada's children. Thank you.
Thank you. Is there anyone else there at the table in Las Vegas? I unfortunately don't have a view of it. There you go. Good morning.
Good morning. For the record, my name is Carol Matrone, and I live here in Las Vegas. My daughter as well, Maria Matrone, is 33 years old, physically challenged, and has been a Desert Regional Center recipient of services since her birth in 1991. Maria lives a big, full life. She's a rider athlete. She participates fully in her activities, but she's physically challenged, so she needs the 24/7 support of an intensive supported living arrangement, or what everybody's throwing out there today as an ISLA. Maria started her career of independent living in 2 group homes here in Las Vegas under the guise of Desert Regional Center with 4 individuals in each of those group homes. Super excited about them, looked forward to a future in them. And the first home because there's no avenue to kind of find compatibility when individuals are placed together through the system. It's kind of like, here's an opening, your child goes there. It had two women that were prone to violent behaviors, so much so that on day 3 of my daughter moving in, one punched another in the face, unsolicited and unprompted, and was arrested and jailed for domestic violence. That continued for 3 months till we couldn't take it anymore, and we brought Maria back home. The second group home, which was again with 4 women that had little compatibility to Maria, had created so much stress for her that we thought she got a stress ulcer in her mouth. It ended up being 14. Maria had to be hospitalized because she had lost 20 pounds, could no longer eat by mouth, got a G-tube, couldn't sit in her wheelchair anymore, had to go on anti-anxiety and stress meds, and then had a baclofen pump placed, and is still to this day on a cocktail of psychological medications that keeps her kind of from having these stress experiences again. So fast forward to after those experiences, DRC then said maybe she'd be better in a single placement for an ISLA. I'm aware that this is a very costly situation to provide 24/7 care. However, some individuals do much better at it. 3 years ago, and she'll be going on her 4th year this October 1st, Maria was moved to Betty's Village. Now, I know you've heard all about Betty's Village. It's an innovative, inclusive community where disabled and non-disabled peers live together. It's a place where Maria has not only been happiest she's ever been, but she is thriving. She has a community of peers. She has a community of activities. Everybody looks out for each other. She has arrived. So in hearing the news that DRC is no longer going to support this, living alone, and kind of evict her from Betty's come March, it's been rather earth-shattering. Okay, Maria's not here with me today because I don't dare let her even hear this or get a breath of this information till I know it's a reality or not. So I implore today that if Desert Regional Center does not have it in their budget to support not only my daughter remaining in her 1-bedroom ISLA, the other 6 or 8 individuals that live at Betty and reside at Betty's in their 1-bedroom ISLA. But that, and then from what we understand, 90 more individuals under their umbrella, that they look to put that into the budget and support it. Not all individuals can kind of make it in those 4-bedroom situations. Thank you for your time and your.
Thank you. You can go ahead.
Good morning. My name is Jody Collins, JODICOLLINS. Thank you for taking my public comment today. I'm the parent and guardian of my son, Andre Collins. He has cerebral palsy, is profoundly deaf, has a liver autoimmune, and has a feeding tube for nutrition. He also uses an electric wheelchair for mobility. He's 29 years old. My husband and I never imagined that he would live anywhere other than at home with us. But nearly 3 years ago, we visited Betty's Village that you've heard about many times this morning. And when I suggested that one day perhaps Mom, Dad, and Andre could move in there, he signed, "No, me alone," which was a little shocking. So I said again, "No, me, you, Dad, maybe move in here one day." He said, "No, me alone." So we put his name on the waiting list, and 2 years later, we finally got the call. Andre was so excited. He helped to pick out his furnishings, he decorated his apartment, moved in on April 30th of last year. It's been a huge adjustment for all of us, but Andre is enjoying walking to work or driving his chair, seeing friends on a daily basis, joining in all the activities and things that Betty's Village provides. He loves the independence. The idea that we could lose all of that is upsetting for all of us. We feel that all people with disabilities should have the right to live alone if they choose. We've heard that some DRC clients have been told that their lease will not be renewed and that they have to move into a 3 or 4 bedroom group home. This is not an option at Betty's Village. It doesn't seem fair that those who need less supports are allowed to live on their own, but those with more challenges who need more supports and the full-time ISLA must be in a group home. It feels as if my son would be discriminated against because he has medical and physical challenges that require more assistance. I'm asking that you please fund DRC to continue the independent living homes that have especially already been established. I feel my son and the others who have already been living there should be grandfathered in, because to pull back the independence for my son and the other individuals who are already enjoying their life right now would be very devastating. It would affect his mental and physical well-being. Thank you for listening.
Thank you.
Chair, members of the committee, Jonathan Norman, Jonathan Norman. Excuse me. My colleagues at Children's Advocacy Alliance, Legal Aid, and Foster Kinship testified in support of E254 and E255, which the coalition also supports. I just wanted to point out that that is budget account 3230. So it's budget account 3230. Thank you, in support.
Thank you.
Good morning. My name's Anita Wagner, ANITA WAGNER. I just found out about this meeting, so I'm not fully prepared, but I am going to give you a little overview of what we've dealt with in the last year and a half. So my daughter was born with a rare genetic disorder. She has several disabilities that she deals with on a daily basis. She's hearing impaired, visually impaired. She has low muscle tone, Crohn's disease, which has led to an ostomy. She has iron deficiencies, low immunities. She struggles on a daily basis just to get up, move around, and be her. When she was born, we were told she wouldn't make it to 5. So as far as I'm concerned, she's in her golden years because she's 25 years old. So we must be doing something right as a family. A couple of years ago, we decided that we aren't going to be here forever, and it was time to make sure that she had a place established that we could overview, that we could be there to support while we're still here, to make sure that when we are gone, her brother isn't put into the chaos that we've had to deal with for the last year and a half. There's been multiple times that she's come home or been at home and received injuries, yet nobody knows what happened. We've had investigations. She's been left on buses, alone, locked in to her chair, locked in to the bus, with the bus running, and nobody supervising. We have had multiple issues with staff at the place that she currently lives and had to fight to get this person to no longer be available to employ at her house. She lives with another individual. They are very compatible, and we're very fortunate that we were able to put them together. But what scares me is it is a 3-bedroom home. That 3rd bedroom is extremely small, and they were told that that would be their activities sensory room, which they both require. The thought that they could move another individual in there and totally put chaos, which has finally somewhat settled down, is unnerving. We realize that all of these young adults, young students, young children, they all have a purpose in this life. And I really feel that we as human beings are not looking at it in the greater scope. We all get up every day, we get ready for work, we go to work. Why don't they get that capability as well? We all go home, relax, get on our iPads, chill. Why aren't they given those abilities as well? I think it's very sad that the providers that we have in this state, in this city, are so inadequate. I am constantly fighting with these people. I can't even work because it takes twice as much work for me at home to make sure that she's being cared for and that they know I'm watching. That's not acceptable. Quality assurance will come in. They're notified well in advance that they're coming. And so they make sure and spend 2 weeks to get all of their ducks in a row so that they pass with the grade that is acceptable to keep their program going. So frustrates me. It saddens me. I was born and raised here, and we have the least adequate care, not only for the elderly, but for young adults with disabilities. I implore you to really think about it. These children are someone's daughter, granddaughter, cousin, sibling. Where would you be if yours was put in this situation? Would you be fighting? I sure hope so. Thank you.
Thank you. Next person. Is there anyone else at the table in Las Vegas that would like to make public comment? Great, not seeing any. BPS, do we have anyone joining us on the phones that would like to make public comment at this time?
Thank you, Chair. To provide public comment, please press star 9 now to take your place in the queue.
Good morning, Madam Chair and members of the very hardworking committee. Good morning. My name is Dora Martinez, DORA-MARTINEZ. I am a member of the Nevada Disability Action Coalition. And Madam Chair, I couldn't access the PDF documents from all of the presenters today. We are working with your LCB to make sure that accessibility is built in. We've been talking about this since I've been active, voicing out people with disabilities voices. So I'm just going to let you know, based on my blind experience, I just want to thank Director or Administrator Whitley for his staff at the welfare office on Virginia Street here in Reno. They are very accommodating when they see my dog and me as a blind person going in. The security guard approach us, show us where to go, and let us wait for our name or color to go. And I told them I'm colorblind, I can't tell, so they got to come and get us. So they have a good sense of humor, and they accommodate us when we enter the building. And I just wish and hope that beginning of this year, moving forward, that all online services from ADSB and all the welfare and all the people that are there providing care for people who do not have a car or can't make it to the office, make sure that their online services are accessible to all. Sorry, that's my granddaughter, who are visually impaired, especially ASL and other languages that we talked about like last session. So I appreciate everyone, and thank you so much for being there. And I ditto all the people who commented before me. Thank you, Madam Chair. Stay warm. Bye-bye.
Thank you. Next caller.
Once again, we are in public comment. If you'd like to participate, please press star 9 on your phone now to take your place in the queue. Caller, you're unmuted. Please proceed.
Hi, my name is Casey Melvin. I am an occupational therapist and business leader in Nevada. I've had the pleasure of working closely with the state associations for occupational, physical, and speech therapy services. We are committed to addressing the critical gaps in access to care for Nevadans, particularly in PT, OT, and speech services. Our advocacy is focused on ensuring equitable access by proposing Medicaid rate increases aligned with the cost of delivering quality care. Specifically, we advocate for rate parity for provider type 34 therapy with provider type 60 and provider type 20, as these services are delivered by the same qualified clinicians. These adjustments are vital to maintaining a robust provider network, addressing the critical workforce shortages in outpatient care, and tackling Nevada's ongoing healthcare and mental health crisis. We're not short of passionate ideas for profound programs to support individuals with disabilities and severe mental illness. However, the sustainability of these interventions and the development of new impactful programs hinge on addressing the current shortage of licensed clinicians working in outpatient settings. By increasing reimbursement rates, we can enhance care in our communities and ensure that these life-changing services are both accessible and sustainable. Improved access to outpatient care will reduce the long-term strain on emergency and institutionalized services, while also playing a critical role in supporting mental health. These services empower individuals to recover, regain independence, and achieve better overall well-being, aligning with Nevada's broader goals of improving healthcare outcomes and fostering healthier communities. By reducing readmission rates, long-term care placements, and recidivism, these measures will provide a strong return on investment for Nevada's healthcare system. We actively engage with stakeholders, including Medicaid representatives, to emphasize the importance of network adequacy, fiscal sustainability, and improving care for underserviced populations. By working collaboratively with policymakers, we aim to implement solutions that prioritize patient outcomes, expand care availability, and strengthen Nevada's healthcare workforce. We urge legislators to champion positive change by enhancing access to care, ensuring fair and sustainable reimbursement, and investing in the health and well-being of our communities. Together, we can address Nevada's healthcare challenges, fight the mental health crisis, and build a healthier, more sustainable future for all Nevadans. Thank you.
Thank you.
Chair, there are no additional callers at this time.
Thank you so much. And again, we will have a second opportunity for public comment at the end of today's meeting. So with that, we'll move on to the third item on our agenda for today. It will be an overview of the budget from the Department of Health and Human Services, and we invite Director Whitley to the table, him and his team. Good morning.
Good morning. Good morning, Chairperson Monroe Marino and members of the committee. My name is Richard Whitley. I serve as the Director for the Department of Health and Human Services. And with me today on my right is Shannon Litz. She is the Deputy Director over Programming. And on my left is Acting Director of Finance, Christina Hardwick, who this is her first day back to work after being on maternity leave. And she after my previous deputy got a promotion, she graciously came back to work today and is here to help me with our budget presentation. And so, again, high-level presentation. And I just, if it's okay, I was just going to plow through this presentation and then pause for questions.
That's perfect.
Thank you. Then turning to page 2. Page 2 and 3 of our presentation shows the department's mission, vision, organizational structure, and statutory authority. As you know, the department is divided into 5 divisions, and you'll be hearing from each of the divisions today. The department provides a variety of services from eligibility for services to the paying and regulating of healthcare, to then the direct service provision of clinical services. Turning to page 4. Slide 4 shows the department's budgeted funding sources. The federal funds requested is 52% of the total in the governor's recommended budget. The general funds requested is 20% of the total governor's recommended budget. The other makes up 28% of the total. Moving to slide 5. This chart shows the general fund by division. The general fund requested for the upcoming biennium is $4.6 billion, the largest being in Medicaid, which is $2.7 billion. As outlined, the general fund distribution has not changed significantly from 24-25. 59% of the general fund is distributed to the Division of Healthcare Finance and Policy, which is down slightly of 4% from last biennium. The next largest share is Aging and Disability Services, up 3% from the last biennium. Overall, the growth of $610 million or 15% from the previous biennium. The primary reason for the increase is due to the Federal Medical Assistance Percentage, or FMAP, but also caseload growth, inflation, rate increases, and mandates. In the upcoming biennium, the FMAP is around 60%, and as the decline in the FMAP increases the state general fund need, and it's generally reflective of how our economy's doing. So we have to pay a larger percent to programs that, like Medicaid, that are reliant on a match from the Fed. So as our economy does better, our contribution increases. So you'll see that and hear more about it from Medicaid. Turning to slide 6. Slides 6 and 7 provide information on the department's FTEs. As I said, our department administers programs, but we also deliver direct clinical services, often facility-based. And so although our overall, slide 6 shows the denominator of how many employees we have, but I think you'll hear more from each division. An overall vacancy rate is not reflective of some of the unique challenges we have in the clinical areas. Slide 7 shows that vacancy rate, although overall has improved, and certainly for generalists in state service, I think that we've had an amazing impact that we've had on being able to fill positions. Sort of a call out particularly to the Division of Welfare and Supportive Services with eligibility workers. They've really been able to actively recruit and fill, but our vacancy rates, the disparity is, so all things not being equal, the disparity really is in the clinical area, and I would highlight specifically with social workers and nurses. There, as you know, a national shortage, and certainly we feel that impact in state service. Moving to slide 8. Slide 8 is an overview of the budgeted funding sources for my office. We administer programs directly from this office. General fund make up 2% of the revenues, and federal funds make up 11%. So, it actually sort of begs the question, why did we make a chart that the largest percent is others, but it is primarily tax funding and settlement funds. And within the settlement funds, largely opioid settlement and tobacco settlement funds. Turning to page 9. This slide shows the additional programs that are administered in the director's office. And then on slide 10, 10 and 11 provide information on the Fund for Healthy Nevada, the tobacco settlement, and then Fund for Resilient Nevada, which is opioid funding. And I think as I go forward, I'll probably just refer to as tobacco settlement and opioid settlement. But these two programs are distinct in so much as the tobacco settlement funds are in perpetuity. So as long as people are purchasing cigarettes, we receive a percent of that revenue. it had been stable for about 10 years, but I think you've heard in the economic forum that taxation on tobacco is down. That also is reflected in the revenues that we receive from those settlements. But again, this funding is in perpetuity in contrast with the opioid settlement funds, which was a one-time settlement, or continues to be a one-time settlement, but lasting for approximately 20 years included in the settlement. So just, I think, important to distinguish between those two sources of funding. Moving to slide 11. Slide 11 breaks down the Fund for Resilient Nevada, or the opioid funds. 43% of the opioid litigation recoveries are managed through this program. Local governments who are part of the One Nevada Agreement through the Attorney General's office receive funding directly. The funds were established in our department in 2021. So there's a statutory framework for how we administer. Local governments have to have a needs assessment if they make a request for these dollars, so that it's deliberate to do it in a coordinated way. I would also identify and had a thought that probably it would be useful. I listened to Department of Corrections presentation, and I think some things were attributed to opioid settlement that were an opioid grant. And I think that we do not invest any of the opioid settlement funds that are received at the state level into Medicaid. So Medicaid is a payer for many of the services, and then we get categorical grants for opioid. And I think that it's not purposeful, but I think that sometimes it's just referred to as opioid settlement as a payer source. And it really is a service model that is made up of categorical funding. But I think the primary funding for healthcare that is important to identify, maybe going forward, is, should things change at a federal level, it's important to know that we're not using any of the settlement fund to pay for healthcare, and therefore not matching those dollars with Medicaid, just as a safety net. Certainly, the opportunities that those of you that sit on IFC have been a part of is that we've been able to really address some of the upstream challenges, particularly when it comes to prenatal care and substance use, and then early childhood, and the impacts of substances on developmental issues. And so that has been wonderful for us to be able to invest in that way. On our website, we have a really thoughtful perinatal gestational exposure to substance report, and show an increase in babies that are born in our state substance exposed. And that also includes alcohol, an increase in alcohol impact on children. And so I think the report is it's a benefit of actually being supported to also having medical epidemiologists that are able to really dig into the data and not just simply identify a problem, but identify where we can intervene. And so although not fully implemented at this time, I think the approvals that we've received in the interim at IFC, and then in this budget, you'll see building on that request to support those families. I think in public comment, you heard remarks about the family or the kinship programs that most people know someone who's raising a grandchild or a child because the parent is using substances. Many of those people we know don't access they don't access what have been traditionally welfare services. They may have received additional kids in their family, which changes the federal poverty level of the family. And so they and then the stigma of welfare. There are a lot of reasons why people have not accessed those services. You'll see in the Division of Welfare and Supportive Services an enhancement to that budget using opioid settlement funds to support those families. We definitely know the work ahead of us, though, is to remove the stigma piece and do outreach. It's unknown, like what the volume is. Probably the schools are the only ones that actually know, because the grandparent, has to be identified to pick up the child, but they're not in our welfare system, child welfare system. And so we're very excited about this program, very excited about the leadership of Robert Thompson, who used the pitch to use the existing infrastructure of TANF, not costing, additional infrastructure to disperse these funds. But we definitely need to promote it in a way and partner with some of the nonprofits to get the word out so that we can really support these families who are raising children and maybe prevent a second trauma if they're not able to care for them. I sort of got off script on that one with I'm sorry about that, but you'll see that throughout our budget. I think more efforts when it comes to children at different points. We definitely have to make improvements in the prenatal care, but the efforts on what happens next in terms of identifying or diagnosing kids with developmental issues. You'll see one of the projects you'll hear in DCFS is in the juvenile justice system, and it's an assessment center at Summit View where we have an empty facility. And just to highlight, we originally had this funded with general fund and opioid funds, and we have submitted an amendment to make this 100% opioid settlement funds. I also heard the question about if we were submitting amendments, and so I just to get ahead on that one. Moving to slide 12. So slide 12 really shows our overarching priority in our department, which is restructuring. And just to hit on this in a high level way, our department, as I went over, large in terms of number of staff, large in terms of amount of funding that we oversee. But I think the complexity of paying for services and administering services and then directly delivering them is a challenge that really makes it hard. I mean, we tend to always lean on the side of the direct services. So if there's something inadequate, but we haven't adequately spent the time on the payer and the regulatory side of healthcare. Just fortunate in our state to have Stacy Weeks, who has really brought a refreshing view of Medicaid, and to the point that you'll see in a proposal, and I think it actually is built into her budget, some support to enhance the administration of adding the public employee benefit, another big payer of healthcare, and the health exchange, which really is an entry point for eligibility. When I mentioned before about stigma, many states are moving towards having eligibility determined online, much like the exchange is already doing. And so there's some synergy in there that she's identified as a huge opportunity for Nevada. But the payer side of things, in terms of purchasing power, I really can't say enough. We in the interim, rarely do we have time to pause and contemplate restructuring. Usually, as you heard in public comment, unmet need, responding to changes that occur, the workforce shortages in healthcare. But I do think that thoughtful time was spent looking at this, at the purchasing of healthcare, to the point where some of you may recall Bess Slamowitz, a pharmacist who helped with some of the other pharmacy reforms we did. But we actually looked at purchasing across the whole department when it comes to pharmaceuticals, and engaged purchasing in the beginning, thinking maybe we should put a pharmacist in purchasing, that didn't really take. It is hard in government, to effectuate change, but I think the momentum that Stacy has had on that purchasing side is really too rich for us not to consider. So that is in the governor's proposed budget. What gets less attention, though, is probably then what remains. So the proposal is the Department of Human Services and the Department Health Authority. On the Department of Human Services, many of these social service activities, the common goal is really to help families either move out of poverty or to break the cycle with young people generationally. And I think there is more that we can do in that space, more that we have categorical grants for. But the focus on that, just the department is too big. Just being someone who's been here for 10 years, it's 24 hours a day, 7 days a week with health facilities. And so hopefully we'll have some forums where we can talk more about this. I just want to say that equally on the human service side, lots of opportunities, largely, just to sort of mitigate any fears or anything. The other divisions are left intact, and so we're not proposing eliminating anything. It really is just making it more manageable and allowing us to then, as a safety net provider, this was the other point I wanted to make, and hopefully we could make our case to get some support for some greater flexibility in this area. But corporate hospitals or systems of care can work amongst the entire system. So when there's a shortage of nurses, they can move between facility types. We can do that with adults, and we can do that with children, but I would respectfully request that there be some consideration with our 24-hour facilities. Lessons learned out of the pandemic, we really struggled. I probably endorsed breaking rules in HR by just covering the hospital. They're all licensed and CMS certified, and we would never take a patient that we couldn't care for, and so government's not built to do that in a very responsive way, in the same way that private sector is. And so I'm hopeful that this could be considered for this Department of Human Service side and that direct service safety net. The other part on the safety net you hear a lot with our Department of Justice settlement, and that largely has relied on Medicaid as a payer. That's going to take some time to get it stood up, get the workforce in our state providing services. But the state's role for both adult and children's behavioral health as a safety net really needs to be defined. You'll hear from DCFS today that they have a Desert Willow Hospital. It's a 54-bed hospital. If you haven't toured it, it's I would hold it up to any private sector hospital, but there are only 29 children there. It is underutilized for a locked facility, so it's licensed as both an acute psychiatric hospital and a psychiatric residential treatment facility. But it is locked, and for children, we need a continuum of care. We need to be able to place them also in unlocked facilities. And I would hopefully, again, if we have opportunity in in a committee hearing to show that continuum of facilities, but more precisely the role the state plays, where we're at, and then what the variables are that we consider if we are serving as a safety net in that way. How do we define that? And what are the resources need? When there's unmet need, I think, again, you heard it in the public comment, it's experienced individually. And so in direct services, sometimes you just hear the individual challenge, but I think that there is systemic things that we could be looking ahead and forecasting, and the state could be providing that role better. And so that's my pitch for trying to garner some support in this reorganization. And then I'd like to have Stacy say a little bit more about the Health Authority.
Thank you, Director Whitley. Stacy Weeks for the record, Nevada Medicaid. I just keep it brief because hopefully we will have a future hearing on some of these matters. I know today we're doing a high-level deep dive, but something I think that's important to note that the state in Nevada is the largest payer and purchaser of health care. When you combine all these programs, we will be covering and paying for 1 in 3 Nevadans. It's potential that it could grow to 1 in 2. That gives us a collective bargaining power with carriers that we do not have today to get a better deal, to control our costs, and hopefully get better options for even our state employees. I think maybe all of you know we struggle in that space. I currently sit on that board, and it is hard to listen to the stories of our state employees. And so I feel very passionate about this and really appreciate the governor bringing it forward. I will say that leveraging state purchasing at the state level is not a new concept. We would be joining a group of leading states in this area. Washington, Oregon, and New Mexico all have health authorities where they're looking at new purchasing strategies and contracting with health plans. Medicaid currently covers 1 in 4, and we have contracts with health carriers that are worth billions. So it does give us a certain leverage that our state employees, for example, don't have. So that is something we want to hopefully walk through more in detail with you all. But, the goal here is to really break down some of those silos that Director Whitley mentioned in purchasing healthcare, and to really unify this effort in a way where we can get a better deal, but also, really be thoughtful about how we're spending our money on healthcare. I think we all know that the costs are growing. You saw the pie. Every year we sit here and we never can say that it's going down. Even though we spend a lot of our time trying to control costs, the needs are still there. You heard from public comment earlier. There's also the unknowns at the federal level and some of the changes coming. And so I think this just gives us a leg up in Nevada to be ready to deal with some of those costs and make sure if this is the money that we have in the system, that we're getting the best deal for Nevadans. So I'll stop there. And if Director Whitley, I don't know if you want to keep going. Thank you.
That really was, for the record, Richard Whitley, the high-level overview of our major priority. I think I mentioned some of the population focuses that we have utilizing opioid funds, and I won't do those programs justice. You'll hear about them in each division's presentation, but I would stop here, and I'm happy to answer questions.
Thank you so much. We do have a few questions, and we're going to start with Assemblywoman Brown-May.
Thank you, Chair. Thank you very much for the presentation, Director Whitley. It's great to see you and your team and all of the information. Starting with public comment this morning, obviously we're going to get into many other specific divisions within a DHHS. My question this morning, though, is really relative to the last part of your presentation, right, and the reorganization that's proposed with the Health Authority. I have two different sort of delineated bullet point lists of what goes where. And it looks like it's changed a little bit from one to the PowerPoint presentation today. And so I'm just curious to know, and I look forward to getting into the detail later. High level, was there a SWOT analysis done? Like, what is the strategic plan? Ms. Weeks, I heard you talk about, right, purchasing power and health authority. It looks like developmental disabilities is in one health authority, but it's not in, like, the other. So I'm confused as to what goes where, and how did we decide what went where?
Madam Chair, Committee, Stacy Weeks, Nevada Medicaid. Thank you for the question. There was a lot of conversation about better oversight of developmental disabilities and our disability coverage system. Medicaid funds primarily most of the services for this population. A couple moves were made to really create an Office of Compliance that's really focused on not just ensuring that there's oversight and reducing fraud, waste, and abuse, but also developing our providers. So that's what you'll see with some of the Developmental Disability Council is coming over, IDD Council, to allow us to have insights into what is happening in the system in a way that we can take action. The healthcare HCQC, our licensing division, that's part of the Division of Public and Behavioral Health, that is coming over and is going to be more coordinated with our Medicaid Provider Enrollment Office. I don't know how many of you, I think some of you have reached out to me about providers in your district that struggle to get licensed and then enrolled and all of the credentialing. This is going to be a one-stop shop for them in a way that we haven't had, and we're trying to streamline that work. It's also an effort that we want to, really look at some of our facilities and ensuring that they're safe, and also on the Medicaid side, we often see issues, and that helps us really improve that coordination. We are coordinating today, but having them under the same house in a compliance matter gives us that ability.
Follow up, Madam Chair.
Go ahead.
Thank you. Thank you for that. At the surface makes great sense, right? So I heard you say that healthcare compliance and quality is going to go over. So all of our quality assurance checks, our licensure is all part of what will go into this health authority, while human services will. So I'm curious to know, like, there are aspects that are both human services and quality compliance and payer in multiple waivers that we have. I'm just curious to know, are we going to have some representation relative to the service delivery of, say, senior services in both, right? We're going to purchase insurance and yet we're going to deliver the service.
Madam Chair, Stacey Weeks for the record. Yes, so Medicaid purchases health care all the time for seniors. I think we could do it better. I think that would something that we would like to bring back to this table, but obviously those services are provided in the new human service structure. Director Whitley, would you like to follow up?
Thank you. For the record, Richard Whitley. I mean, I think I can't really talk about senior services without even putting it in the context of Medicare. As you likely know, Medicare years ago reduced. It used to be the major payer for skilled nursing facilities, but it is now it's short term. That burden then on facility-based care falls on Medicaid, which is costly. Consumers basically have to spend out of pocket until they get to the point that they can qualify financially for Medicaid. So helping seniors to live as independently as possible, much like disabilities, as independently as possible with those sort of supports are not only cost effective, but also, support the dignity of the individual. Last session, there was a pay increase for personal care workers to go in the home. So that combination of services from personal care, home health, hospice, those really are supports that work in an organized way. And I would say that unlike child welfare, which is operationalized in Clark and Washoe at the county level in collaboration with the state, and in contrast to public health, which is operationalized at a district level, with the exception of some rural counties where the state plays the role. There isn't really, other than when I look at it, when we did do some analysis, is in the space of food, Meals on Wheels, which is really a welfare check because there isn't a financial eligibility. It is really to deliver home meals, and we know this through the pandemic. Catholic Charities in Southern Nevada wrapped around services for the people living in their homes. So this all needs a focus area by population for seniors. Not to say that we've completed the work with children, that we've completed the work with the criminal justice involved. All of those have a unique focus, I think, that really when in an agency as large as ours, it does make it hard to keep those priorities up. And some of them are longer term strategies. And so that's a long-winded way of answering your questions.
Thank you. I appreciate the clarification around the muddy water, if you will. And I echo your comments about additional forums and look forward to really getting into the details. The early intervention services, right, IDEA Part C, and how are we maintaining our maintenance of effort, right? All of those pieces that are so complicated with regard to the funding that we're receiving. I just would like to thank you and this very complex idea, Madam Chair. I'll leave it there. Thank you.
Thank you. Senator Nguyen?
Thank you, Chair. I have some questions for some of the other agencies, but I'll wait until they give their presentations for some of those more like high-level detailed questions. But I do have a question just about the establishment of the Nevada Health Authority. Obviously I know that it's something that I've been interested in working on and trying to figure out how we can modernize those things to deliver services better. I do recognize that it's included currently in the executive budget, and the governor's recommending an additional $6.4 million over the biennium to reorganize kind of these two agencies. I think it's about 2.4 from general fund. What kind of, in addition to anticipating, having a better product, I guess, for consumers and providers to be reimbursed, to get signed up, to have all of those things in one consolidated location, do you anticipate any other additional cost savings, or will this be an ongoing increase to our budget moving forward to provide this?
Madam Chair, Stacey Weeks for the record. Over time, I do think we will see some savings. I think right now, because Nevada budget's only for 2 years and not 4 years, that's not showing up in the tails here, but I do think there are some anticipated savings. One thing that we were very mindful of in designing the Nevada Health Authority side was ensuring that we could better capture federal funding. Right now, all of the divisions are distinct entities, and we have to do cost allocation plans, which does not allow us to draw down often the full 50-50 that we can draw down, or 75-25 if they're clinical staff, so 75% matching funds. That was what I'm referring to. The way we've designed it is to better maximize those federal resources. That was the goal. We can still provide federal funds to these other entities, just like we do today. We'll just be updating our cost allocation plans. But to answer your question, we do anticipate savings. It's just hard at this time until we get everything stood up to be able to put that on the books for you next session.
Chair, may I follow up? As far as that, do you anticipate that we would not have to wait until a legislative session for legislators to bring additional, like, Medicaid billing? We would be able to capture that sooner, I guess, rather than having to wait every 2 years?
Madam Chair, Stacey Weeks for the record. I love that question because I don't want to wait every 2 years either. I think what would be really nice to talk about is a way for us to have the option to address rates and maybe some formula in state law if there is sufficient funding, like additional funding in our account. I think I would be more than happy to sit down with you and others to talk about what that could look like. So we aren't waiting until every 2 years, because it really has become an issue. Providers, as you heard today, some sitting at this table, it gives us more flexibility if we could do that together.
And I'm sorry, Chair, may I ask one last question? We've initially been presented with the idea that this budget was a flat budget, that there weren't any decreases, there weren't any increases to existing Medicaid reimbursement rates or any other programs. But obviously we've heard in public comment, and I think a lot of the members have probably received emails about how some of these funding mechanisms are changing or being changed. Is there any other, are there other things, or is that something that these individual agencies may be able to address and answer some of those questions? I know that's really vague.
For the record, Richard Whitley, I would say just with the public comment, that's primarily, I think we heard from people with, or family members of people with disabilities. And you might recall that Aging and Disability came to IFC for contingency funds for their services. One of the things that happened across all of our programs, I think, but primarily in those that are residential based, is during the pandemic, a lot of families continue to care for their adult children. And when we did a rate increase, we have seen an increase. It made it a bit of a challenge for forecasting because of the unusualness of, I think, the pent-up demand and not accounting for additional caseload growth, but you will hear more about that. And I believe the intention to come forward to request funding when the session starts for the agency to address that, and then it's built into their caseload. Same thing happened in child welfare. Kids not in school didn't mean that abuse and neglect wasn't occurring, but there was a reduction in reporting during that time. And then, as you know, on our forensic side, same thing with courts, and then we ended up being behind in the 7-day timeline and are currently paying penalties for being late in getting the competency evaluation and competency restoration. And so you'll hear from each of the divisions on those sort of impacts and what the plan is going forward. Back to your original question, though, on savings, I think we can provide this to the committee if interested. What started the conversation on the savings part was really pharmaceuticals, and Beth Slamowitz did an assessment of how much categorical pharmacy is being purchased in the state, and over 50 different purchases. And I think one of the things that we'll see is just the knowledge of rebates. Some programs thought it was just funding that was being given back to them. The understanding of and what to expect with rebates so that it can be budgeted and accounted for is I think one of the immediate things that we would see, let alone the purchasing power and that sort of, but the knowledge of purchasing of healthcare. That is what Stacey Weeks has brought to Nevada, really, is the understanding of it's not just because she's a lawyer and an MPH, but it really is the purchasing of healthcare and the sort of science of that, as well as how to look at it. And so we've had a lot of the tools, but each leader has sort of brought things to where we are today. I'm not in any way disparaging anyone that came. It wouldn't have been ready at an earlier time. When Governor Sandoval expanded Medicaid in 2012, then it was all, up for tearing it down and not expanding it. And, then we fought for it, and we incrementally have made certain to reduce our uninsured rate. But having insurance, I mean, that isn't health care by itself. It's coverage. And so we have to do both. And I think that we have some specific examples of pharmacy being one, and that really is what drove us. And happy to provide that. And just think that if we could have a forum to provide, I think, that additional information, I think we've done the work behind it. It's, I don't want you to take my word for it just sitting here, but it has been a challenge, and the opportunity is in front of us, especially with the unknown at a federal level.
Thank you, and thank you, Chair.
Thank you, Senator Neal.
Thank you, Madam Chair. So I'm going to start with the Health Authority. So I have two questions. The first is, how will you be managing, or using this Health Authority to deal with or try to lower prescription costs? Is that somewhere in the plan? And I might as well ask the second question too. How will the agency, the new Health Authority, manage minority health discrepancies that may come through that agency? So those are the two questions I have for you, and then I have one for Director Whitley.
Madam Chair, Stacey Weeks for the record. Thank you for that question. The first thing I would note is that we have some items in our budget that are starting on that track. The first one, and I will talk about it here soon during our presentation, and we'll describe it more, but it's called single PDL. So it's really establishing, this is the first phase of getting to where we need to be as a state. It's really ensuring all of our drug lists are aligned across our products. It allows us to get a better deal on rebates. We have a pharmacist on our team now, Dr. Duncan, who has been working on that. We are seeing increased amount of drug rebates today, but we think we can get even more, which is some savings we have brought forward for the legislature and the governor this year for the next biennium. Ongoing, we would be looking at other strategies that other states have used and seeing which ones are most successful. We have funding in there for a vendor to come on board to help support a purchasing strategy. The first one of those elements would be pharmacy. We could do a single PBM. That is a big lift for the state, so I'm very mindful of our administrative needs. There are other ways that states have done this. There's more of those co-ops that they've joined and other strategies. So what we would want to do is get an expert vendor in to model different ways of purchasing pharmacy. So that second phase, we would be bringing back for you all, hopefully in the next year or two, the track that we see that's most viable, but also what we would need to do that. On your second question for health and minority health, we have part of what Director Whitley, we probably should have mentioned earlier, was the Office of Analytics would be coming over with the new health authority to help us monitor and track our programs, our human services, as well as our coverage programs. One of the things I want to see as part of our strategic plan that we're going to be putting together is evaluation. I think often we have all these ideas, but we never evaluate the return on investment, but also just the outcomes. And one of those elements should be on health equity and looking at the impact on different populations, people of color, as well as people in our rural communities. So I think those are elements that we would be putting together and reporting back to the lawmakers. I think there's some future, hopefully, BDR drafts, budget BDR drafts coming that you guys can look at what we've designed to bring back to the legislature in 2027.
Thank you for that. So, Director Whitley, these are just more, this is high-level, general. Based on like the executive orders that have come down, do you feel like there's gonna be an impact to Medicaid-related services that relate to sexual orientation?
For the record, Richard Whitley, I can't say. The Medicaid covers what is medically necessary. I think all insurers, including the public employees, benefit. And so when there are challenges, there's processes to follow. But I don't think anything so far has changed related to medical necessity. But definitely, I mean, these changes are occurring at a federal level while we're reviewing our budgets, and so it may not be in sync at the same time. But we have not heard any change in that. I think executive orders don't always translate to changes in programming. So unless Medicaid changes the CFRs around medical necessity, I wouldn't. I don't see a change in that. It may be more like, I mean, now it's more of an issue of where to go to get the care. And like we've described, you can have a payer source, you can have insurance, but if there aren't providers, specialty providers included, that becomes a challenge, and the healthcare coverage rings somewhat hollow for a person who has that unique medical need.
Thank you for that. And then just the final question, Chair, is you mentioned like the DOJ. Are there any DOJ rulings or final rule or decrees that could be impacted or that we should be looking out for, being that there was another executive order that rolled back DOJ decrees?
For the record, Richard Whitley, I mean, Nevada signed that consent agreement for children and mental health. And so we also, as you know, unique from any other state, had the funding as we worked on the plan, the system of care. And so those funds for those services are well on their way. So no, I don't believe in terms of that, of the DOJ settlement, that we will see any impact in terms of what happens at a federal level. We've already signed the consent agreement and we've already operationalized the services.
Thank you, Madam Chair.
Thank you. Senator Stone?
Thank you, Madam Chair, and thank you for the presentation, Mr. Whitley and staff. I'd like to look at the Fund for Resilient Nevada. You were saying that this is 100% for the opioid settlement funds, is that correct? And you said that this is a 20-year fund, so it has a finite life associated with it. Just a couple of questions. How far are we into that 20 years? Do we have a couple more bienniums left to fund this program? And after the funding is exhausted, do we have some kind of a transition plan, number one? And number two, I'm noticing that in fiscal year 24-25 versus 26-27, there's a significant difference in the spending in those 2 years. And you talk about these seven goals. I don't see anywhere where the 7 goals are described. If you could just briefly tell us what the 7 goals are and why there's such a disparity between the 2 different fiscal years.
For the record, Richard Whitley. Hopefully I can, on our website, we actually have a really dedicated dashboard to where we're at with spending. I would say that the delay really was, as I said, 2021, the statute put this framework in place. Slow to start. I mean, all these the funds don't get reverted to general fund. They stay in reserve. We've done some heavy lifts in the past year with spending, but that accounts for what might appear like underspending, and then the awards come in at different times. So in addition to the AG settlement overall, each pharmaceutical company or pharmacy has their own individual settlement too. So all the initiatives that we do have to comply with both. So it has been slow. And then I think I mentioned that the way the statute lays this out, that if a county or a local government has a need, they have to have a formal needs assessment first to show how they're investing in locally in the resources. And so it's been slow to start, I'll say. In regards to the 20 years, I think ahead of us, I'm struggling with ARPA funding coming to an end, and really how some social service cliffs that people will experience because we have enhanced. And so we are mindful of that, though. The fortunate thing in the legislation is it allows us to use these funds for match. As I said before, we're not investing in Medicaid, but we could. And we also have used them, the speaker had a bill last session on Medicaid for people who are criminal justice involved, for jails and prison, both adult and children. We actually used opioid funding and leveraged it with federal match to write that waiver to provide 90 days of service in the jail before people are discharged to the community. It's gonna, big savings to the counties, but also to the state. But we can leverage it with a federal match when there's possibilities. So there's a lot of possibilities in those resources, and including then the populations that have been identified. So on our website, sorry.
Shannon Litz for the record. The website is dhhs.nv.gov/FRN.
Thank you for that. And just finally for Ms. Weeks, I think it's a brilliant idea to have a pharmacist involved in purchasing, whether you're forming a co-op or a PBM. We know there's a lot of different competing pharmacological classes of medications, including some new ones that have come on the market for diabetes, weight control, and leveraging that competition for the benefit of our taxpayers, I think is a brilliant idea, and I applaud your efforts. Thank you, Madam Chair.
You're welcome. Assemblymember Anderson.
Thank you, Chair, and thank you for this presentation.
I was happy. I'm not sure exactly which way to describe it. Thank you for the explanation about the opioid settlements and versus the grants, because somebody had reached out to me about that, who actually serves on one of those boards. And so I think when we do a little bit more of a deeper dive, it'll be nice to have that division as to where the money's come from. My question has a little bit more to do with, though, the individuals who are working in some of these facilities that might be let go. Is there a plan for those individuals as we continue to look at more and more facilities, especially with what we heard with the comments earlier today of possibility of some facilities closing? Or what is the plan to make sure that the individuals who are working in those areas will continue to have a job and be helped?
For the record, Richard Whitley, are you referring to state-operated facilities?
That's correct, yes.
I don't, again, for the record, Richard Whitley, the problem is actually not having adequate services. I think I gave as an example for children in Las Vegas, Desert Willow, really state-of-the-art psychiatric hospital, licensed as an acute psychiatric and also as a psychiatric residential treatment facility, but underutilized. Part of it is the staffing and so, I mean, the reality is we do a hybrid now of contracting. When we can't hire nurses, I think those of you that sit on IFC know that we frequently come to IFC and move funding from our vacancy savings in personnel to contract. And, you know, it's not one for one, I would say. That's one of the, just to give another sort of a plug for this reorganization, it'd be nice to have, you know, to be working in consort for facility-based services, but there's no intention of eliminating state employees. It's really supplementing that's needed currently. If you talk to Clark County, Social Services, Legal Aid of Southern Nevada, I mean, their desperation is placement, appropriate placement of a child in a level of care. We have empty beds, but we don't have we can't admit somebody. It's probably too much, but for the record, Richard Whitley, one more time. Acute hospitals with emergency rooms are the only facility type that can't refuse a patient. Then they're required to either provide the specialty services or have transfer agreements. So frequently the need is identified, like at Child Haven in Clark County. But facilities say we can't take that client safely, including the state agency. So a lot of that has to do with staffing. And so it's a complex issue, but it's in the context of all facility types. It'd be nice for me probably to provide, maybe it's more on the health policy side, but to show that continuum of care. The DOJ settlement focused on home and community services, trying to prevent children from needing to be, in fact, the complaint was we were over-institutionalizing children. But what's needed in that is step-down services appropriate. So when a child leaves an acute facility, maybe they need to be in a residential treatment facility, which is a lower level, locked or unlocked. Those are all descriptions of, I think, that continuum, and it's important to put that in context. And then where are we at as a state? Some of its rates, Stacey Weeks has negotiated higher rates in some of the private sector facilities, but that's a lot. It's complex, but there is no intention of eliminating state facility clinical workers. It's really subsidizing them so we can maximize the facilities. It's harder to find a facility, really, to actually provide the services in than or equal to the staffing side of it. And then the state is also, you know, we're not designed necessarily for direct services.
Follow up, if I may. Thank you. So thank you for that, because that's what I was under the impression as well. And and I'm not sure, is Campus of Hope a state facility, a private partnership type public partnership? And so in particular, the Campus of Hope employees is kind of what I'm looking at in particular at this time. And that might be part of what you were talking about, or if Stacy wanted to bring that up, whoever would like to mention about what's happening with the Campus of Hope individuals.
For the record, Richard Whitley. Well, I'd like to rely on Marla McDade Williams to talk about it related to children, but
Yes, but Marla does not want to come up here, so.
All right. It is a partnership. It's state land, that, and the proposal would have impact. I think we have an informational item coming to IFC about that. But even in the face of that, I still would hold up that Desert Willow, our psychiatric hospital, is underutilized. It is a locked facility, and that piece of having currently the land that is on the campus has some facilities for, off the top of my head, one for, I know, 6 adolescent boys that, are able to go to school during the day. It's not locked. I would also contend probably not ideal to have children. We did have an event where a young girl that was in an unlocked facility tried to climb the fence to Stein Hospital, our forensic hospital. And so an unlocked facility, the location does matter. And, we do the best we can, probably to a fault. In terms of there's a need during the pandemic, and we worked with Clark County trying to actually stand up these facilities that if you've toured that campus, they've been residential, then they were offices, and then we, Cody Finney, I think, did a nice job with the regulatory side, with the facility we leased to the county, who then leased to Silver State to be a provider of care. They needed fire suppression, and the fire suppression equipment could not arrive in time, and we had to, in order to have compliance, a compliance agreement with the provider, and to be able to serve the kids, we had to have 24 hours a day, 7 days a week, a person who just monitored for fire. And so these facilities were not, that we're doing the best we can with what's available, but they aren't ideal for children. I think the commitment was also made, and we've certainly held this stance as the partners have explored Campus for Hope, is that we can't have less than what we have right now. The idea would be to have more and have it more robust in a safe environment, but that's Marla has maintained that throughout the discussion about services, is that we have to stand something up before we shut something down, even to make way for something else that's needed.
Thank you. Speaker Yeager.
Thank you so much, Madam Chair. Good morning. It's nice to be here with you in Carson City. It's a little colder and snowier than I would like, but that means legislative session is right around the corner. First, let me say thank you for all your department does. As you mentioned, a huge part of our budget, and I think by the public comment we heard, we know how important that is. I will tell you, I was having a pretty good morning this morning until I walked into my office and I saw 3 binders of the governor's proposed budget that were dropped off last Wednesday. And I think, as you know, and you alluded to, Director Whitley, we received a budget with a $355 million structural deficit. And so my question to you, I know you mentioned one item where there would be an amendment. I'd also heard, I haven't seen it, but I heard that there was perhaps a budget amendment that was submitted on Friday relative to Medicaid for $120 million. So I guess my question is, where are we in terms of, what are you able to share right now with how your proposed budget that we received in those 3 binders that are now largely inaccurate, how that might change in this budgeting process, and if you've had some further discussions or you can share any information about what we should be looking for receiving.
Sure. For the record, Richard Whitley. I watched the previous hearing, so I anticipated the question, but correct. We have a budget amendment, a pitcher and a catcher with opioid funds for that Juvenile Justice Assessment Center. And then the only other agency that we have with amendments being submitted is Medicaid, and I think Stacy was going to cover that maybe in her budget presentation on Medicaid, but no other divisions. So none of the other divisions you hear from today. You'll see an amendment from my office with opioid settlement to DCFS to fully fund the assessment center for juvenile justice with opioid funds, and then all remaining amendments are in Medicaid.
Great. If I could just follow up quickly, Madam Chair, I'll wait until the Medicaid budget to get to that portion. But Director Whitley, could you, I don't know if you stated in your testimony, but could you remind me what the dollar amount was for the budget amendment related to the opioid settlements and for the juvenile justice assessment?
The general fund savings, $5.76 million over the biennium.
Okay. Thank you. I think that's the only question I have on that topic. One other question, if I could, Madam Chair. This is just a global question, but when I heard about the proposed reorganization of the division, I think I certainly understand why that idea would be brought forward. One of the immediate concerns that I had was just the way that federal funding works with state funding, and you can't necessarily use federally funded employees to do state work. Sometimes you can, sometimes you can't. I mean, you guys are the budget experts, so I'm not going to offer an opinion on that, but I just wondered if, we haven't seen the bill yet from the governor's office. I think it's still being drafted, so we have high-level information about what might be in there, but have you been able to work through those issues about making sure that we are compliant as a state with how we are administering federal funds and federally funded positions?
Madam Chair, Stacy Weeks for the record. We recently submitted some answers to LCB, your analyst, about those issues. We have consulted with other states and CMS on this topic. I will say that I think we're able to maximize money in the way we haven't before, like I mentioned earlier. The way we've designed it, we do not anticipate any problems. I think we will continue to do cost allocation plans to the divisions as separate entities like they are today. So just generally speaking, yes, that was definitely part of our conversation. And if it didn't work on the federal side, it would not be possible.
Great, thank you. Thank you, Madam Chair.
Thank you. Members, any other questions? Not seeing any. I would just encourage you, as you've heard, the budget that we were originally presented with has a number of issues with it. So our staff will be reaching out with a number of questions as we start the session next week. So we have a lot of work as we're behind the 8 ball. As they reach out to you for that additional information, if you could get that back in the quickest manner possible, would be very much appreciated by myself and Senator Don Darrell Loop, so that the staff, our fiscal staff, can do the work that we need to do in this next 120 days to close out the session. So I appreciate that. So not seeing any other questions from any other members here, I'd say thank you so much for the presentation, and we will move on to the 4th item of today's agenda. And that is the Division of Healthcare Financing and Policy. And Ms. Weeks, you just get to change chairs.
Madam Chair, Stacy Weeks for the record, Division of Healthcare Financing and Policy. I have with me here today Deputy Jennifer Krupp, who's over our budget and fiscal team. Also have Lynette Aaron. She is our Chief Financial Officer. I'm trying to think of a better term than an ASO4, but she definitely knows our Medicaid budget, and we are glad she's back from maternity leave. So we're here today in front of you to walk through our proposed budget. We have a couple updates that I want to give at the beginning, but and at the end, I'm open for questions. I will also walk through the amendment. I apologize. I don't have a slide in this deck because we were still finalizing that on Friday. with our counterparts at GFO, and I want to thank everyone for all the work that's been done over the last few weeks to try to get things in place. But I will walk through that as best as I can, high level, and then I'll try not to keep it. I'm trying to keep it not too technical because it can get confusing. So just to start out, let me make sure I've got my deck going here. All right. Can you guys see that okay? Is it coming up? All right, good. All right. Just a reminder, our mission is set in statute. We are really here as a division to focus on the most efficient manner of providing Medicaid coverage to the state. This includes maximizing federal funds, promoting access to quality care, and restraining the growth of costs of health care in the state. As you all know, and we've talked about earlier, Medicaid expenditures in the state make up most of the spending in the state budget. At the division, our work is really focused on a vision of a healthier Nevada. I just want to say on that piece, even with all the recent work that my team has been doing, my team has been working very hard over the last 2 years, and all the recent investments from this body last session, we continue to rank as a state in the bottom 10 nationally. I just want to kind of level set in that space. This includes maternity and infant health. We have some of the poorest outcomes for moms and babies in the country. We have some of the highest rates of teen suicide in the country. We have the lowest rates of preventive screening and treatment in the country for chronic disease. We have some of the poorest access to quality health care. We have the highest rate of mental health disorders for both adults and children in the country, and the worst access. So when I stand here today and I say that we are trying to do our best, I think we all know that the lift in front of us is big, and I just kind of want to start with that because we have a lot of work to do in Nevada, and Medicaid plays an important role in that effort. Nevada Medicaid covers 1 in 4 Nevadans. It was 1 in 3 last session when I sat before you because we were in the middle of the public health emergency, but today it's 1 in 4. And nearly half of those we cover are children. And when we look at the child population, that's nearly half of the state's children population. We also cover a core set of benefits that's mandated by federal law, but we've also added our own state optional benefits to this benefit set. We offer this coverage in Nevada at no cost to those eligible. It's a state and federally funded taxpayer program. So when you think of Medicaid, it's not a grant program. We actually match and pay on the dollar to providers like health insurance pays. We also cover 1 in 2 births in Nevada, and we're the payer of last resort. So if someone does have coverage in another form, we do make sure that they're billed first, and then Medicaid can be billed. When you look at this table here, I wanted to give you the snapshot of just a sense of how big Medicaid is. So when you think of the ERISA plans, the ones the state really can't touch, right? The ones that we have no control over other than the employer market at the federal level, that's about half our market. But when we look at places where we can have an access point, we're looking at our individual market, which is what we think of as our exchange, which is about 3%, and Medicaid, which is about 24%. Look at that uninsured. It has gone down based on the data from DOI, so that's a big win, but we're still in the top 10 for some of the highest uninsured rates at 8%. And obviously there is military coverage making up 6%. So Medicaid is a big payer in our healthcare market. The nice thing about that is that as a state, we can drive reform through our payment policies and how we pay for health care. When you want to know what's wrong with the system, you have to follow the money and look at how are we paying for health care, because when you change how you pay for health care, your outcomes change as well. These right now, given all the things I mentioned earlier where we're ranking, these are our goals and our focus. We are really focused in on trying to get more providers. Workforce gaps is a big challenge for Medicaid. We have an access rule under federal law. There are regulations around it, but it is a federal statute. So even if regulations change, we still have to follow what we call our access rule. And it says that states have to pay enough to ensure that there's adequate access. I can only pay what I am funded. So sometimes when people call and they are upset with us, I have to remind them that, we are budgeted and we're trying to manage that budget. But one of the goals that we're looking at, besides looking at reimbursement rates, is how do we remove those administrative burdens on our providers? I think the most calls I get is around provider enrollment. That's a big challenge. So what are we doing? And my team's working really hard with our vendor Gainwell to create a new online program, an online platform to do that quicker and faster and less burdensome. But also for our recipients, right? How are they accessing care? How are they getting into the door through our eligibility system? We're really looking at those burdens and trying to remove them. The other goal we have is around what we talked about earlier, the Department of Justice, finding that Nevada lacks adequate community behavioral health care services. Because of this, as a state, when you fund something at the state level in the healthcare system and all your funding is institutional care, you're violating the ADA, the Americans with Disability Act. And so the DOJ came in, had a finding, we just signed that agreement. And so one of our big focuses is improving community health care for behavioral health needs. I mentioned maternal and child health. This is an area that our state is just shockingly bad and doing poorly in, and I think this is an area we are looking at more and more about how can we do different payment models with our hospitals and our providers and our managed care plans, because this is something we have to tackle together. The other piece here is transportation. I think a lot of times I'm hearing constantly is I can't get access because I can't get someone to pick me up for my non-medical emergency transportation. So we're looking at reforms in this area statewide. Also, like I mentioned, modernizing healthcare and how we pay for it, and then again, improving access to preventative and primary care. This is really going to drive down cost over time. Those aren't savings one-to-one right away, but if we do better in that last space, those last two, over time we can start to hopefully curb or bend a little bit or plateau the cost driver. I'm very excited to say today that as we sit here, we have a full leadership team. I think the last time I was in front of you, we were filling holes and gaps in our system, and I'm very proud of this team that we have built. Everyone is very focused and passionate about the work. As you can see, we have 4 deputies. We have Deputy Sandy Rubelid, who's over our IT, HR, and operations. Jennifer Krupp, as I mentioned earlier, is over our budget and fiscal. Teresa Karsten is over our benefit system and our delivery system. So when you think of managed care and that work, she is over that system. Melinda Southard is our deputy over community engagement and long-term care and supports. And then we have 3 new officers. Since I last sat here, we have a market integration officer, Todd Rich. He comes to us from the Division of Insurance. He has joined the dark side, is what I like to say. But it is very nice to have someone on our staff that has experience with health insurers and really trying to integrate our markets for individuals. And then we have a compliance officer, Cynthia Leach, and a new innovations officer, Ann Jensen, who is leading our Children's Behavioral Health Transformation Project. We have 3 clinical leaders, Dr. Benson. I think he's the best dental officer in the country. He does an amazing amount of work to improve access for our disabled population to dental services. Dr. Clemens, she is based in Vegas and is a pediatrician. She's our medical director. And Dr. Duncan is newest to our team in terms of the clinicians, and she's doing an amazing job bringing in more drug rebates and helping us look at ways to control costs in pharmacy. So what does Medicaid do? And what does our division do? So we work in partnership with CMS at the federal level, and they are essentially our regulators in ensuring we're following the rules so we can get federal funds. Our division is divided up into these little, the arrow boxes there, but really we are focused on provider payments and ensuring that if we need to recover funds, that's what we're doing, and fiscal management and fiscal payment to providers. We also focus on provider screening, enrollment, and program integrity, state and federal compliance with federal rules. We also do appeals for providers on decisions for payment, as well as recipients when they are denied certain things around coverage and benefits. We also run the Managed Care and Dental Benefits Administrator program and provide oversight to those contracts. Like I mentioned earlier, they are worth billions of dollars. This is a very big effort on our team's part. We also oversee and develop the benefits and rates for Medicaid, and we also do community outreach and education about the coverage and benefits, and really trying to work better and create partnerships with our providers. The other piece is our district offices. We do care coordination, case management. We have 2 offices, one in Reno and one in Vegas, and they assist various fee-for-service recipients with services. Our eligibility and enrollment system currently is conducted by Division of Welfare and Supportive Services, and I'll talk in a little bit in a minute about some of the proposals we have in that space. So before we dive into the budget, I want to just highlight some of the accomplishments that we've achieved since we last sat here over the last 2 years. I will say it's gone by fast, faster than I think we thought it would, but I'm very proud of the work that the team has done. I know there's more work, though, to do. Our private hospital tax program, since we sat here in front of you, it's up and running. We brought in, with the Nevada Hospital Association's help, $363 million in state fiscal year 24 in net gains to hospitals. So when you think of what that means, this is minus the tax they pay, and this is how much they got gained from the program. We are anticipating, because we'll have a full year under our belt and the way the managed care program works, there's going to be $830 million for state fiscal year 25 and net gain for hospitals in Nevada. We do, under state law, thank you very much for ensuring this was in the bill last session, we are able to capture up to 15% of that tax revenue to support behavioral health services funded by Medicaid. That funding, when it is matched, is over each year, at least over $100 million or more. In state fiscal year 24, we collected about $28 million for these efforts, and we are beginning to implement many of these services that IFC has already approved with our federal partners. And once we match that funding, it will be close to $100 million. In state fiscal year 25, we are estimating bringing in a lot more, about $59 million for children's behavioral health care through Medicaid. Again, once that's matched, it's over $100 million of new investments in the children's behavioral health care space. Another effort that we've been working on is school health services. One of the things that we know is that the one space that we can maybe connect with a child and a family is in the school setting. Nearly over half of our kids are in our public schools, and we know that if we can ensure that school health services are being provided, and if we can help in funding that, we can maybe make a difference in some of the behavioral health issues that we're seeing. As well as just some of the basic screenings and services. We recently got a $2.5 million federal grant from CMS to really enhance schools billing Medicaid. Right now, as you may recall, Nevada expanded billing of Medicaid for schools several years ago, but unfortunately, many schools, while they enrolled, nearly half were enrolled, our counties, many were not actually billing us. And we were like, why? They were not billing beyond mostly just coverage that they have to provide or services they have to provide for children with disabilities. So we went out and did a school tour with our school districts. Our team went out and met with every school district in the state and tried to figure out what can we do to get you to bill Medicaid? What can we do to help support your provider system in the school setting? We heard a lot of feedback, and we have taken that to heart, and so we are expanding coverage of certain school health providers in the school setting, as well as looking at our manual. One of the things that we noticed is that our manual was really complicated. For attorneys, that can be fun, but for the average person and provider in school, it's not, and it's really hard for them to figure out who's covered, what's covered, and how it's covered. So we worked with Milliman as a vendor to help put together a new school health services manual that we, I think, recently have released or getting ready to release. So we're very excited about that effort, and we're very hopeful that schools statewide are going to start billing for services, and not just for services that are being provided for children with disabilities, but any child who is Medicaid eligible in the school setting. Director Whitley mentioned earlier, but we have signed, the state did sign the U.S. DOJ settlement agreement. That was a 2-year negotiations with the DOJ. It was very intense at times, but I think we feel very confident and are very proud of the work in front of us, and that we are already starting to move forward with these efforts. Unlike other states, like Director Whitley mentioned, we have the funding. We have it from the private hospital tax, and we're not having to come in front of you right now to say we need 30, 40 million, which is really nice. So thank you to our private hospitals for agreeing to do that. And it's just been a big new revenue source for children's behavioral health. But we anticipate over the biennium about 200 million in investments in this space. Dental coverage. So I will say I think it might have been Senator Neal's bill for the federal waiver for new adult dental coverage for diabetes. That was approved. We're so excited. Dr. Benson and our team worked really hard on that with CMS, and so now we are working to implement that in the system. Nothing is easy. There's always a step, but we are closer and closer to that being realized. We also got a new CDC grant for oral health, thanks to Dr. Benson's leadership, of about $1.1 million, as well as we have our new dental coverage for the intellectual disability population. Earlier, you mentioned Medicare and Medicaid, and we were talking a little bit about seniors. We do have what we call a DSNP, and I apologize, I'm using acronyms. You can't get away from acronyms in Medicaid, but we have what we call our DSNP plans. It's our special needs population, and these plans are supposed to be there to integrate and support our dual eligibles and their benefits, and looking at how they buy down the out-of-pocket cost, as well as trying to ensure that they're accessing services. We also, one thing we found about a year ago coming out of session was we had over 10 plans, and I'll be honest, hardly anyone enrolled, and we couldn't tell you what these plans were doing. And yes, it's called a SMAC, it's a federal agreement where CMS agrees with us to have these plans, but what we realized is, what are we getting out of it as a state? And so we decided to do a procurement, which was apparently something no one else has done for the fee-for-service population, but we did it. And we got a lot of kudos, actually, from CMS for doing this, because we were the first fee-for-service state to really say, hey, we do care about what these plans are doing, and we want to know what they're doing. And so we have new contracts and new quality metrics and data that they have to share with us. So I think we're excited about this. It also added new services for our dual eligible seniors, including dental, personal emergency response system services, meals, fitness coverage, and more over-counter prescription drug cost coverage. So those are just recently coming out of the pipe. The other big thing we've been working on over the last 2 years is statewide managed care. This has been a very large lift for our division. We did a hospital tour. We went out and met with all the hospitals statewide, which was very helpful to our team to really see what is it like really to operate in this area, in these areas. We are currently in a procurement, so I can't tell you who the plans are yet, but we're expected to have awards before session ends. So by March or April, we should know who our managed care plans will be for the state. I will say, when working on this, we were trying to think about how do we ensure that our rural providers do no harm, right? Like, how can we ensure that they're at their best level and moving forward in this new statewide effort? So what we've done is we really limited the number of carriers in our rural areas to the top 2 plans. So whoever scores the highest amongst the plans gets both rural and our metro areas. And then for our Washoe County, there can be up to 4 plans, and for Clark, there can be up to 5, but no more across all the programs, no more than 5. But the goal is to really reduce the burden on the rural providers, so there would be no more than 2. If we just did 1, we always risk the situation where you have one plan who gets very eager and happy maybe and doesn't really give a good deal. So by having 2, there's a little bit of competition. This expansion adds about 75,000 rural Nevadans to managed care. These are adults, children, and parents. These are not our seniors. They're not our populations in our waiver programs, and they do not include our children in the welfare system. So just want to say it's the same folks that are in our urban areas. They're going to be also covered in our rural areas. Additionally, we got I will say, just as hot off the press a couple weeks ago, we got our 1332 waiver approval from CMS for the Senate Bill 420 for the Market Stabilization Program and the Public Option Program. This new effort will bring in about $300 million in new federal funds to fund a reinsurance program, premium subsidies to offset any increases in the market from the new public option plan, as well as hopefully over time we'll have enough fund to pay for a quality incentive program for our health plans and providers. Last but not least on this slide, we recently submitted an amendment to CMS that is pending. It amends our 1115 waiver, which allowed us for the first time to cover coverage of substance use treatment in an institution setting. It allows us to add, hopefully once this amendment's approved, we can start covering treatment for serious mental illness, which will help with our state facilities as well, and they can start billing Medicaid. So this also, I'm going to move on to the next thing. So coverage for justice involved population. So this was AB 389. Yep, and this is for our coverage pre-release 90 days and for any individual who is incarcerated. So we have recently got that waiver submitted to CMS for federal approval. We are waiting feedback. Obviously, things are kind of quiet right now at the federal level, but we anticipate in the next month or two getting started with CMS. We do have a vendor on board who's already working on our implementation plan. So when we get the approval, we don't have to take even a beat. We can just start running. So we have been coordinating with our different sister agencies involved, including corrections, as well as jails and counties and prisons. This is going to be a lift for that system because it's asking a system just like schools who are non-traditional healthcare providers to bill and act more like healthcare providers. So part of our effort has been how do we get them ready? So we applied for a competitive federal grant award to really support implementation, and we got $5 million. We're one of the few states that got this funding, so we're very excited and are excited to start rolling out various trainings as well as looking at an electronic health record system to support some of these smaller facilities so they can start billing us and support hiring providers. We are still, last time I sat here in front of you, we had a proposal for funding for centralized credentialing. I'm proud to say in March, we're rolling out centralized credentialing, finally. Our team has been working hard on this piece too, and this is going to be really great for providers. One thing we hear a lot about is when they come in the system, they have to be credentialed like 3 or 4 or 5 different ways, right? This allows us to have one simplified process consistent across all of our carriers. Housing supports and services, we are implementing these services through managed care this year, and we are also in that amendment I mentioned earlier for serious mental illness coverage, we added in housing and supports and services for the fee-for-service population who are at risk of homelessness and who have serious behavioral health conditions. Also, we are starting what we are calling our Hospital Quality Collaborative. It's part of our provider tax program. We just kicked that off earlier this year. We're meeting, I think, maybe next week with hospitals. We're talking about looking at new ways of payment and doing a quality collaborative around maternal health, as well as community transitions, and trying to get our managed care organizations and our hospitals to work together. So if they're meeting outcomes, they're sharing savings together. That's the goal of that effort. All right, I promise this is the last slide of brags, and then we'll dive into the meat. But I just want to note that we were trailing behind Kentucky for the most state plan amendments in the country, and I think we just beat them recently. We are now at 64 state plan amendments that have been submitted since our last session, and we are, many of these have been approved, but we are still waiting some from CMS. We have implemented about 34 bills that were passed last session fully. We still have 8 on track, and then there are a couple others that we are a little behind on and we're working on. If folks want to have any or have questions about their bills, feel free to reach out and we can provide more detail. Staffing, we are 90% fully staffed as of January. This is really great. I sat here last time and it was much higher. And so this has been a huge win for us and has helped us move forward. But with new staff comes training. And so some of the momentum, sometimes we have to stop and make sure that we're bringing our folks up so they understand and know the program and can keep up with the pace. Public health emergency unwind, we completed this, and for those of you who may not be familiar with this, during the PHE, which is during COVID, Medicaid was not renewing coverage or checking eligibility requirements for renewals for 3 years. That means our rolls grew and people stayed on. Some people made more money, got employer coverage, they just stayed on. Many of them didn't even use our coverage. We were seeing a huge amount of money coming back in our MLRs from MCOs, so that's our medical loss ratio payments and other risk adjustment, because we weren't sure what are our costs really. So now that we have really actually completed the unwind, which is renewed everyone thanks to DWIS's hard work as well as the exchange and our team together, we now look at our program and we have a different picture, and I'm going to walk through that here in a second with you, which impacts our budget. But nearly half of those disenrolled have re-enrolled in the program since then. The last thing I want to mention, it's part of one of our budget proposals. It's a mandate, but I think it's important to really note what's going on globally, really, in healthcare, and it's affecting Medicaid and it's affecting other states. Data security is a big problem. We successfully, I don't even say successfully, I'm just going to say we survived and navigated months of a national cyber attack where we couldn't pay a lot of our providers, and that we had to advance money. We had to do that not knowing, well, was these advances actually going to be correct? Or are we going to have to recoup a lot of money? But we did that so we wouldn't lose our healthcare system and those provider systems. But our team worked really hard on addressing this, worked with our vendors who had connections with the Change Healthcare as well. But we got through it. But I don't think this is going to be our last. I think it might have been our first, but I think there's more to come. So some of the proposals in front of you are related to IT security, because we have to really be mindful of all the health information that we hold, but also the money that we hold and the money that we need to get out the door, which we're spending, 30 to 40 million a month in provider payments. All right, so let's dive into the budget. Before we dive in, I want to give a snapshot of what's going on and what's really happening in the trends that we see in front of you. So the first thing I want to mention, let me find the right slide here, sorry. I was not using my notes, which is dangerous. Never know what I'm going to say. Okay, so by the end of the pandemic, we had seen about our caseload grow about 40%. Now we're looking at a caseload growth of only 22%. So that's because of the unwind I just mentioned. People were disenrolled, and then nearly half were re-enrolled. That was about 300,000 people, so assume maybe close to 150,000 came back. And we're slowly starting to see that trend, slowly increase over time. And we'll look at the caseload here in a second. But I just want to point out that what's interesting about this is the population costs have changed. So clearly, for a long time, we were looking at people who were low utilizers or non-utilizers because they probably had coverage somewhere else, or they were higher income and are healthier, and they are now no longer on the program. And what we're seeing is that our cost per member per month, or what some people call our cost per eligible, has gone up by 24%. So when you think of a risk pool in health insurance, especially in our managed care program, that has a big implications for our budget. So our managed care rates for this next year, the increase was 5% because of this. Some states were looking at 10 to 15% rate increases. I am very happy to sit here and tell you that is not what we had to do. But as the costs go up per member per month, this does impact our managed care program and impacts our entire budget. So just for example, our legislatively approved per member per month for state fiscal year 2024 was $490.89. Our new current PM per member per month is $608.57. And this is across all populations. Some populations are way more expensive, and some are way cheaper, so that's that average. But that's as of December. What's really challenging sitting in front of you here today is timing. So while we know those costs are going up, maybe they are going to level off. We've only really been able to see a full quarter of information, but the challenging thing about Medicaid is that we don't really understand the data and the claims until 6 months out. So if we just ended the unwind in September, that's the new population that we're talking about. We're not going to really know until probably April. Where are the costs? What is the experience of this population? Are the managed care plans able to control the costs, right? So I was just talking to the LCB team about this. It's really challenging, and I want to be very honest about where we are as a state. And so that is what you're seeing in some of the budget materials in front of you. The other thing just to mention is that the federal pieces. So another important factor affecting our cost and our state share of the cost is that our federal funds, since we last sat here with you last session, have gone down about 2.42%. As you may recall, during the public health emergency, we got a 6% enhancement on our federal match, right? That was really nice. We had a lot of money and things were feeling pretty good, but that has since expired. And plus that expiration was phased out. What also happened since we sat here in front of you is that our economy got better. Our per capita income went up, which is great, but that means the feds don't have to cover as much. So that went down, right? So it's like, the inverse reaction here. But what's interesting about that is that's going to change. We never know where that's going to go. But if our economy continues to go up, that may change too. But at the end of the day, there is a limit. The feds can never go below, right now, under current federal law, below 50% of the share. So right now, we're at about 59%. So just to kind of give you a sense of that. Let's see if I've covered everything. Yep, that's it. Okay, next slide. Oh, and I did want to mention the federal rules here before we move on, just a real quick. We do have a lot of new federal requirements. It's yet to be seen what's going to happen to some of those. I do think some will stay in place, but some of our proposals relate to that, and they are costs for our program. So when we look at the projected Medicaid caseload, when we left last session, there were a lot of unknowns, like I mentioned, with the unwind. But with the support of Office of Analytics and the LCB, our legislatively approved caseload was projecting at about 846,000 people for June of 2025. However, we have seen that the caseload came in a little below that. And so for June of 2025, what we're projecting now is 793,000. With a slight, as you can see, slight increasing trend there in the orange over time. And then we look at our checkup population. So while some of these folks are coming off Medicaid, a lot of them are children, but they're moving into what we call our checkup population. And so they're still covered. They're just in this different funding stream and different program, which is I like to think of as essentially Medicaid, so it's not confusing to the people that we serve. But as you can see, our approved caseload here was projected at about 24,000 for June, but actually what we saw was much higher. And so we've come to IFC, and I think we have a proposal at IFC this week to really move money between the two accounts to make sure that we're moving that funding that we thought should be in Medicaid, but actually is in checkup. And the reason this is because what we've seen is a lot of families during PHE lost their jobs, and they had lower income, so they were on Medicaid. As they got a job, or they got a different job, or they got a raise, their income went up. So in Medicaid, we cover children at a higher income, so they stayed on the program under checkup. This is just a breakdown on this slide of our federal, what we call our FMAP percentage. So just so you can see there, we're at about 59% in state fiscal year 26, and it is expected to go down slightly in state fiscal year 27. There are a lot of unknowns at the federal level, but all I can say right now is that you can never go below 50 under the current statute under Title 19. I'm not going to spend too much time on this slide. I know Administrator Schmidt will be up later to talk a little bit about the Aging Services and Disability Services Division. But as you can see, our waiver caseload, our Medicaid member caseload went up slightly since last session. And some of those costs have been growing, as Director Whitley showed earlier. All right, so here's the pie, right? So one of probably your favorite chart is the budget. Our budget funding sources here, as you can see, and legislatively approved for state fiscal year 24 and 25, we had an approved $15.8 million. Of that, 60% was federally funded, and that had to do with, like I mentioned earlier, our average FMAP. 16% of that was general fund. And other, which is, as you can see, is about $3.8 million there. That includes things like our county share. The counties are required under state law to pick up a portion of the share. It also includes our drug rebates that we were anticipating, and it also includes our provider tax revenue to help support the program. So when we look at the pie for 26-27, you can see the general fund's gone down a little bit, and then the other chart's gone up quite a bit. And as you can see, the feds have gone down, like we mentioned, that 2%. The other there in front of you, that 27%, represents a much higher amount of drug rebates that we are collecting, as well as some of the efforts that we're going to talk about in a second, as well as our provider tax program has brought in significant amount of revenue. So that's helped offset the state general fund expenditures for the program. All right, so let's dive into priorities. So the governor's budget really is focused on Medicaid investments in certain areas. The first one is to improve access to care. I think we all know that we lack adequate access, and like Director Whitley mentioned earlier, you can have health insurance and coverage, but if you can't get in to see a doctor or provider, what's the point, right? So this is an area we have to focus on, and also we are federally required to ensure adequate access. We also have investments in here that are primarily funded with the private hospital tax revenue that I mentioned to really strengthen our state's community behavioral health care system. We also have efforts in the budget this session to maximize prescription drug rebates. I'm excited to sit here and say that we still have adult dental coverage in this governor's budget, and very proud that it has come forward. I think this is a huge need. The mouth is part of the body, I think we all know, and these costs that we're not addressing by having adequate dental is costing our budget. We are also looking at increasing access to Medicaid for the uninsured and eligible with some different efforts in the eligibility system through the exchange. And our other priority is really strengthening Medicaid program operations. So our first enhancement here is to address our healthcare workforce gaps. It's E262. The budget requests new revenue from increased prescription drug rebates that we are expecting to generate in state fiscal year 26 and 27 from the implementation of a single prescription drug list. This funding we want to use in state fiscal year 27 to match with federal dollars so we can actually support providers who are participating in graduate medical education by helping do new reimbursement methodologies that offset indirect medical education costs as well as direct medical education costs. This is achieved, like I mentioned, through new efforts with CMS. We have been in discussions with CMS about what other states are doing in this space, and there is an appetite to really help states leverage federal Medicaid dollars to help with workforce. We do this by really creating new reimbursement methods to these providers, so like a bonus payment, additional rate or additional funds through their rate to support them if they are training new providers. Another thing I want to mention is that we're wanting to look at more than just the physician workforce. We need to look at all of the other areas we know we need. So this is a new effort, and we're looking at just that increased prescription drug rebate funding to fund it. The last item here on the slide is funded with state general fund. It is improving access to what we call our NEMT benefit, which is our transportation benefit. And we're requesting new funds to really improve access to this benefit and really look at a more accountable and transparent model. For those of you that don't know, we contract with a vendor to do this. It's MTM right now, but we really think we can create a better contracting and purchasing strategy, if I may say that again, with these vendors to get a better deal for the state, but also hold them more accountable and ensure access statewide. The next couple slides, or next two slides, are really items that are, like I mentioned, are going to be funded through that private hospital tax to support and strengthen our state's mental health care system. We are asking for increased funding to strengthen mobile crisis first on our list here, and really looking at a tiered reimbursement system to support different provider levels. I'm learning as I go on with mobile crisis, but there's different types of mobile crisis systems, and they all meet different standards or practices, and some meet more standards than others. And how do we pay accordingly, but also incentivize others to grow and improve their practices over time? So mobile crisis is a big priority. It also aligns with the DOJ efforts. There are a lot of requirements in the DOJ settlement agreement around ensuring access to mobile crisis and crisis stabilization. Assertive community treatment providers and teams, we are asking for more funding to create a better bundled payment, if you will, for these providers to really increase access to these services statewide. Other states have a lot of ACT teams, and they're really impactful and helpful, especially in our rural communities, ensuring that people get the services they need, intensive services in the community. And so we're hoping that this investment will help expand access. You may recall we do have community paramedicine in our Medicaid program, but we barely have any participation in this area. Other states have really found community paramedicine to be helpful not only in medication management, but with behavioral health. And so we really want to do rate reform and increase reimbursement to build out this service line in Nevada. The last one here on this slide is some of you may have heard of the BCCP program. It's really our behavioral health complex needs add-on for our skilled nursing facilities. Often individuals are stuck in our hospital system and they have nowhere to go. And sometimes they should be in a skilled nursing facility, but they have behavioral health challenges. And so if a skilled nursing facility takes on that individual, they often need more funding to be able to meet the needs, right, and the staffing level. So this is really adding more money to that program to help get people out of the inpatient setting and into the right level of care and supporting our providers in doing that, but it's doing that with a quality add-on. So one of the things we've been very intentional about is if we're going to put more money into a system where there is money, a lot of money, is how do we do that with quality? And so we want to create a quality incentive payment program that rewards our providers who are doing this and our skilled nursing facilities who are partnering with our hospitals and looking at quality metrics to really be monitoring these efforts. This slide here walks through other efforts. Partial hospitalization program, we're looking at rate increases. These are identified in our quadrennial rate review as needing rate increases to really be more on par with other states. Same with day treatment. First episode psychosis program would be a new benefit. We know it has a lot of, it's a best practice nationwide, and it will be really helpful in addressing some of the needs in our community. So we're asking for funding or approval to use the tax revenue to support standing up this benefit. We're also looking at increasing inpatient psychiatric and detox service rates in acute settings and our freestanding psychiatric hospitals. And then on this next slide here, we're going to talk about what I mentioned earlier is our single preferred drug list. So this is that first step in getting to really maximizing drug rebates and getting a better deal on pharmacy. One of the fastest areas of costs, or growth in costs in our budget and our program is pharmacy. As we look at all the new drugs coming down the pipe, while having these drugs is really important to the recipients we serve, the costs are also really hard for us as a state to manage. And so I think as we move forward in all these efforts, it's really important that we look at things like single preferred drug list and other efforts to control and maximize rebates. So we are requesting funding for the staff that we need to support our pharmacy team and our pharmacists, in addition to vendor costs, to really implement a single preferred drug list across all of our Medicaid programs, which includes managed care. It provides for, if we do this, it will provide for administrative ease for our providers, patients, and pharmacies. It'll help us maximize rebates by selecting drugs with the lowest cost or the maximum rebate potential. It also allows for more transparency in our program around rebates and fewer disruptions for patients when they switch between managed care plans and the fee-for-service program. Whoops, did I skip one? There. So as I mentioned earlier, we're very excited to say that we are asking for funding to add adult dental coverage. I would just say that we asked Mercer, we were trying to figure out how do we add adult dental. We know it's causing costs in our program. We were hoping maybe we could add it in managed care in the form of what we call in lieu of, which have been free to the state. But the option with that is that it would be optional to managed care plans. And what we know is if we're going to see the real savings that we expect from adult dental, we have to mandate it that it's covered by all managed care plans. So when we looked at it, we did the cost analysis for preventative, periodontal, and diagnostic services. That's what we're asking for here today. Senator Neal had a bill last session that covered restorative and other services. CMS denied us adding that coverage without adding these services first. So once we get these stood up, we can go back to the table and ask for those other services to be stood up. So we'll have a full benefit for adult dental. One of the amendments that we'll talk about here in a second is to delay this just by a year. And that does obviously free up a little funding for state fiscal year 26, but it also is important because we're going to need a year to stand this up with our, everything takes forever in Medicaid, and I'll admit sometimes, but it will take us some time to get this stood up. So that allows us that time without wasting the funding in the budget. But we do believe that by covering this, it's going to reduce the high cost of emergency care, inpatient care, and also has long-term improvements in chronic disease like diabetes and heart disease. I think this is the last slide before the opportunities. Okay, so this last piece here is really focused on increasing access to Medicaid and for the uninsured. The governor recommends that Nevada leverage the exchange platform for individuals to allow them to complete their Medicaid eligibility determination with real-time enrollment through our exchange, like other individuals who are enrolling in health insurance. We know that nearly half of our uninsured are estimated to be likely eligible for Medicaid. We're hopeful that this will help remove any barriers in the current system that are maybe unintended stigma or other barriers in the process. And help individuals get enrolled in coverage. It will also allow people who are eligible for our managed care plans, which is going to be about 85% of our population, and on January 1, 2026, it allows them to actually shop for their plan. Today, they just look at a list and have no idea what that plan is and who's covered unless they go dig it up online. This would allow them to shop and compare like anyone else who's picking a health plan. And so we're very excited about that piece. And just to note that we would be eligible for 90% federal funds to stand it up ongoing, and then 75% after that for federal matching funds for the piece in the platform that we would need with the exchange. All right, so opportunities and challenges. One of the things that we, obviously struggle for is just sufficient training for our staff and because we have a complex program. One thing that is in our budget is funding for a training officer as well as more out-of-state travel. We have a limited out-of-state travel, and we would like to be able to send more of our staff to the national conferences where they can learn about what other states are doing, especially as we all move forward with healthcare costs growing, and what can we do better in Nevada to meet the needs but also do it in an affordable way. We also have our new federal requirements that I mentioned earlier. I mentioned the cyber attack and all the ransomware risks. That's a continued challenge. Continued growth in our healthcare costs, especially our pharmacy spend. We have provider work shortages in almost every space in healthcare in Nevada. We have our U.S. Department of Justice U.S. DOJ settlement agreement. It is an opportunity and a challenge. It's a major project, and we are working hard to get that lifted with our sister agencies and stakeholders. And obviously, an opportunity and a challenge is our new agency reorganization. I did not, I should have added on here just the federal unknowns and kind of what they have in store for our state. I will tell you that we obviously are thinking about those and thinking about how we would address them. This slide here is just a snapshot of our budget account summaries. As you can see, we have lots of counts in Nevada Medicaid, and you can see each one, how they total up there to $18.5 billion over the next biennium. And then I'm going to do this, and then I'll dive into the budget amendment real quick for folks. But I wanted to really break out our position summary. We are asking for new positions, but some are just related to Medicaid, and that's on that bottom line. So our base right now is about 349 staff. We are asking about 16 new FTEs to support mandates, including that cyber attack and all of the things around IT security I mentioned earlier. We are asking in our enhancement units for additional 21 and a half FTEs for a total of 387 at Medicaid. The other two items here, I mentioned earlier, we are looking at ways to leverage new federal resources for the new agency, and we're doing that through our same budget account for Medicaid. And so 10 of those would be an enhancement unit for new positions, and 13 are transfers from other agencies that are coming into Medicaid's budget. So they're not necessarily new, but they're new to this budget, if that makes sense. But the 10 FTEs are new for the new agency. So that gives us a total of 410, but does not include ACQC, Public Employee Benefit Program, or the exchange, because they have separate accounts in the new agency. I'll do this real quick, and then we'll walk through the amendment, and then we'll stand for questions. So we have 3 policy bills and BDRs in front of you. This session, we have AB 36, which is really clarifying state law and the timeline for providers for appeals. Right now, we do have it in our policy, but we do, according to our our Deputy Attorney General, it really would be helpful to have it clarified in state law. So that bill is really focused on ensuring we all know what our timeline is for appeals with providers. AB 42 is really increasing simplification in how we implement state and federal mandates, especially when they benefit our program. So if they're adding a new benefit, increasing a rate, we have a shorter timeline to get moving. Right now, we can't submit anything until we go through almost like a 60-day to 90-day process with all the public posting and public hearings. So if something is a state or federal mandate and has gone through this process and has been heard, we're asking that we're able to move like most other states and move quickly to get those implemented. And it also helps us reduce the time that we're seeing with implementation. The last bill here is Senate Bill 9. This has to do with federal compliance. It really clarifies law regarding third-party payments under federal law with respect to prior authorization and ensuring that we get paid even if a health plan, the third-party payer's prior authorization procedures are different than ours. So there, I can provide more on that if you have questions, or obviously at the bill hearing. So for the bill, for the budget amendment, I just want to do a quick overview, and I'm going to try to keep it high level. I apologize, we don't have a slide on it today. But we are the budget amendment will be about $130 million in state general fund revenue. It's exactly it's $130.7 million. So this is coming from several adjustments in our budget to help find new revenue. We are removing in state fiscal year 2026 from E262, removing the first $10 million for the GME and rebate efforts that we're wanting to do. That gives us time anyways to stand that up, and so we're asking that funding. We only need that funding in state fiscal year 2027, so that frees up $10 million in state general fund revenue in 3243. The second item is we had a cost and a savings all in one, if you will. The first is really that UMC last session was approved higher FMAP claiming, which means we give them a portion of our federal funds that we get back. And it's a much higher claiming than we did before. And so originally that was not reflected in our budget, so we did an adjustment to fix that and pay for it. But we also, in that process, found that some of our federal match and county share was off, so we did some adjustments there that ended up with a savings. And Lynette, I'm going to look at you for a minute. Is it $8 million savings?
Yes, that is correct.
Thank
8
you.
million.
Thank you. Sorry. And then for the account for one thing we did not account for in our budget was some of the tails costs from state managed care. And so when we looked at that, we realized that we also didn't account for some of the savings from statewide managed care. So when we put those two together, we came up with about $41 million in savings. And this is primarily due to the fact that when you move individuals out of the fee-for-service program into a managed system, they have a lower per member per month. And so that's about $41 million savings. When Chief Ryan Cherry sat in front of you talking about growth, he was and savings, that's what he was talking about. Over time, that savings grows because the trend for our fee-for-service population is quite high. And so by putting adults, children, and parents in the rural areas, that 75,000 into managed care, we're reducing that trend. So it's actually a growth in savings for the general fund over time. In fact, the tails in the next year is about $100 million. The next item is an adjustment, like I mentioned earlier, in CAT 15 and CAT 17 to the county share, and it's a savings of about $37.5 million each year to the state general fund. And then the next item is really ensuring that the single preferred drug list, we're bringing in new revenue, that revenue is adequately captured in 3243 for an additional $11.9 million in revenue. The last item here is really one thing that we also wanted to make sure that's reflected is not just that we're bringing in new revenue for the single preferred drug list, but also that we're seeing a trend in prescription drugs that's much higher than we were projecting. And that's about $18.2 million each state fiscal year for a total of $36.5 million. So that should get you to a total of $130.7 million in budget. Hope that made sense. I stand for questions. Thank you.
Thank you. That was a lot of numbers, and I know you don't have a slide for it, but if you could send that over to staff so they could share that information with us, that would be great.
Madam Chair, Stacey Weeks for the record. Yes, we sent this on Friday, but happy to follow up.
Thank you so much. Members, Senator Neal.
Thank you, Madam Chair. So I'm going to start with this. So in the major enhancements where you discussed, I'm just going to group them together. The improved access to non-emergency, the mobile crisis, assertive community treatment, behavioral health, and first episode psychosis and inpatient psychiatric detox. Broad question, how do all of those fit into the homelessness wraparound plan, right? So interagency council, they had, the plan's been updated several times, but currently in the plan, the idea is to leverage the existing resources, right? So we have this Campus for Hope piece, and then we have everything else that's going on. But I want to know how these investments kind of fit into the larger goal. Do we expect that to be mitigated by these investments? Because, I mean, clearly there's a need, but these seem to directly relate to some of the mental health impacts to allow folks to be serviced, potentially transported, et cetera, et cetera.
Madam Chair, Stacey Weeks for the record. So as services come online at the Campus for Hope, if they meet all of our requirements, they could bill Medicaid. I think that would be the goal. And so, yes, they would be helping offset some of those costs, but I'm not sure I'm not sure if that answers your question, but the goal would be, like, for example, the housing supports and services that we're standing up, those would be available and to be billed at Medicaid if they meet all of the federal requirements.
Yeah, thank you for that. Because I asked because you know that if you house them, you then have to deal with the mental health issue, right? So you can house, but you have to stabilize. And so it's not one before the other, it's the combination. And so, you know, as we are doing this investment, right, there needs to be an alignment around the activity and decision points.
Madam Chair, Stacey Weeks for the record, just to add to your point there, yes, now I'm tracking better what I think you were asking. Most of the service, that my understanding, that are going to be offered at the Campus for Hope are already eligible for billing Medicaid. And many of these, if they want to be offering, for example, first episode psychosis, NEMT is already covered, but first episode psychosis is a new benefit. So if they wanted to offer that benefit, they could, and they could bill for it. The goal is to make the transportation benefit more readily accessible and accountable for individuals using it. And a lot of the rate increases are to really support the growth of these services statewide.
Thank you for that, Madam Chair. Different question. So on the community paramedicine, you have a midwife grouping or midwife type. Are doulas a part of that provider type, or are they excluded?
Madam Chair, Stacey Weeks for the record. I'll have to follow up with you on that. I think they might be excluded, but I can double check.
Yeah, because it seems like they should fit into this category, right? It may be something to think about. And then just final big ticket question, because you mentioned staff provider shortages, and I want to know, are the not staff provider shortages, we're talking about medical providers. Are they being impacted by credentialing and the preferences of insurers to work with groups rather than single providers?
Madam Chair, Stacey Weeks for the record. I think you're getting at consolidation of healthcare at the provider level. I will say that does impact healthcare. That's one of the reasons the new Nevada Healthcare Authority and other states like Washington and Oregon did that, because they were trying to tackle that consolidation issue. But right now in Medicaid, it's not our biggest issue. I think the workforce challenge is bigger than that. It's just that there aren't actually bodies to provide the services.
Thank you, Madam Chair.
Thank you. Senator Titus?
Thank you, Madam Chair, and thank you, Director Weeks, for this explanation. And I know it's a lot, but you're probably the best person I've ever seen kind of whittle it down and explain it, even though I have so many questions that it will break down during our subcommittee hearings. But I have a couple now. So on page 18, you talk about the non-emergent transport. It's been an issue for us in the rural areas and certainly in the urban areas for decades, getting that, and it was going to require almost NRS changes to allow some of these services to come in, provide patient transportation to the needed services. And it's not, again, not just in the rural areas, but in urban areas too, getting these patients to their appointments, getting them to their specialists, and then waiting. And it seems like you might be able to authorize and reimburse for that, but that doesn't mean it's going to happen. And so has there been progress in more companies, law changes, those kind of things for this? Because this is great that you're going to pay for it, but doesn't mean it's going to happen.
Madam Chair, Stacey Weeks for the record. So the goal of this is to get a vendor on board to help us look at better contracting. So we are putting in the rural areas, part of our procurement is to say, we have asked the managed care plans to provide the benefit. Because right now, currently, the MTM program is not sufficient. It has not been in that area, and I know they have tried, but we're hopeful to see if there are going to be more opportunities there. There have been conversations about state law changes, and would love to talk more if you're interested in some of those, but this is really looking at a contracting model to try to avoid some of those hurdles and figure out, can we get around those issues and actually do it differently, and to provide those services and reward providers for meeting the rural needs.
So thank you for that. And follow up, Madam Chair, if I might. So back on page 8, you talked about, and along the same vein, about the rural managed care. And as you know, I had big pushback on that. But I have to tell you, as past director within the last year of our long-term care hospital in Yerington, I had more insurance companies reach out to me than my entire career. And believe me, I've been a doc for 43 years now, and I've had more insurance companies reach out to me regarding managed care in this rural setting than I didn't even know they existed. So certainly there was a change in attitude, and I'm happy to hear that you're going to whittle it down. And one of the questions I have for them was this transportation and this access to care. And what are you mandating that these managed care organizations provide to the state? And it's good to hear that one of the things you're mandating is this transportation, that they're going to have to do this lift. But that doesn't mean it's actually going to happen. I continue to see them promising the moon, but at the end of the day, there's still no providers. And so are you addressing that? You mentioned you're going to have 2 managed care as an option, but are they, you said they're going to have to bring in this, these transportation system, and you're looking at this very closely before you award these contracts?
Madam Chair, Stacey Weeks for the record. So I'm not sitting on the evaluation committee, so I can't speak to that, but I do know that was part of the review of all the proposals. Part of that was transportation. We will be, one of the things that we'd like to do more of is more dashboards around our health plans and looking at quality rankings. And one of the things I really want to focus on, transportation. So like, who is doing it well and why, and then we leverage those things. The other thing that we have in our managed care program that we don't have in fee-for-service is we are requiring them to invest over, I think it's 3.5% in the next procurement. It's more than it was before, back into their community. And one of the options was to actually buy transportation vehicles or other things to support those communities and meet those needs, especially in our rural areas. I remember at one hospital we heard that they just needed a vehicle, or they had the driver, but they didn't have the vehicle, and then they had the vehicle, and then the driver passed away, and it was just like they could never get all the pieces at the same time. And so, what can the managed care plan do to invest in that community so they have all those pieces?
All right, thank you for that. And then I guess the final question I have, at least for now, when you talked about the FMAP on page 11 and it went down by 2.4%, is that from the top of the additional 6% that it was? So we're actually looking at it still above at 4%? Where's the math in that? And that's on page 11.
Madam Chair, Stacey Weeks for the record. So before what we call FICRA, which was the enhanced FMAP, it was closer to 62% for Nevada, and that was during the PHE when our economic situation was lower, so we were eligible for a greater amount. So if you look at slide 14, it shows you like when you add in that enhanced FMAP where it was at. We started actually phasing it out over time. As you can see, that 6% went down a little bit, and that is why we're now at the 59%. But it has fully phased out at this time. I think last time we sat here, we thought it would be a little, like about 1% higher or 2% higher. It's just that because of the economic changes, it has actually, we have less in federal funding than we were projecting.
But you said it would never go below 50% still, is correct?
Madam Chair, yes.
So we're still above it at 59%?
Madam Chair, Stacey Weeks for the record, yes.
Okay, very good. Thanks for clarification, and thank you, Madam Chair.
Thank you. Senator Buck?
Thank you, Madam Chair. I had a question about school or Medicaid reimbursement for schools. I guess what is the main top 3 reasons that schools are not billing? How does a school reimbursement work?
Madam Chair, Stacey Weeks for the record. So what we heard from schools were there were 3 things. The first one really was everything's too complex. I mean, when you looked at our manual, it was really, even I had a hard time understanding it, right? And so there's that. And then 2, we often heard that we don't have a billing, someone on our staff who does billing, right? We're busy. We're teachers, we're staff. We don't have time to be billing and keeping medical records and all the things that you have to do to actually bill and document services. Because we do audits, and then we get audited too from the federal government. So there's a lot that goes into billing Medicaid. And then the third thing was just staffing. Especially a lot of our schools have a hard time even getting a nurse. And so that was the other piece, is ensuring that they had qualified professionals that they could bill for. That's why we're adding school psychologists and other school level providers to the billing list for schools to bill.
If I may, Chair. I think that it sounds like one would solve the other if they were able to do that. I was wondering also, are there any charter schools, public charter schools, that are able to get Medicaid reimbursement?
Madam Chair, Stacey Weeks for the record. Yes, we clarified in our manual in our recent policy update that public charter schools are qualified and can bill for Medicaid covered services.
Thank you.
Assemblymember Hafen.
Thank you, Madam Chair, and thank you, Mrs. Weeks. It's good to see you. I did have a question on the $8 million in UMC savings. Is that future savings, or is that something that needs to be billed back to the county or UMC?
Madam Chair, Stacey Weeks for the record. There's not a savings to UMC. We actually just needed to pay their bill as part of our budget. The savings comes from the difference in the federal FMAP and state share that were not correctly projected in the budget. So UMC is held whole and gets extra money, if that makes sense.
Clear as mud. Thank you.
Assemblymember Brown Bay.
Thank you, Chair. Thank you, Administrator Weeks. Thanks for the presentation. This is a lot of very complicated math. And you noted in your presentation that you have over $18 billion worth of funding. We've heard over the course of the last week with regard to some of the complexities, right? You've noted in your presentation this morning that your team has gone back and found a couple of miscalculations, right? This is a lot of math. So I'm curious to know, when we asked the governor's team last week the same question, how many people are on your team on fiscal staff that are just really working on the nuts and bolts and the numbers to how do we get funding? How big is your fiscal team?
Madam Chair, Stacey Weeks for the record. So while we were preparing our budget, one of our best, Lynette Aaron, was actually on maternity leave. And we were down one of our ASOs. We have several other budget analysts, but they're new, and Medicaid takes time to learn. So it primarily was myself and Jennifer Krupp it felt like most of the budget process. But we have recently built up our team, and I'm very excited to say that I think especially our newest hire, Ashley Penny, is going to be a great asset to our team, but it really is a complicated budget that we have to train and teach people.
Thank you. Members, any other questions? Assemblymember O'Neill.
Thank you, Chair. Oh, excuse me. Ms. Weeks, regarding the rural non-emergency transportation, will they be allowed to, or will paramedics be reimbursed for the non-emergency transportation, or other local public connected providers? Here in Carson, it's just basically the fire department doing both emergency and non-emergencies, and I know it's the same way out in several of the rural areas.
Madam Chair, Stacey Weeks for the record. Yes, that is the goal. We're also looking at what they call deadhead miles, where you don't have someone in the car with you. That's what you're getting at? Yes, I thought so. And so we're adding coverage for that and going to seek federal approval because that's a big barrier in our rural areas. So that's something we're looking to make sure is covered.
Thank you. Thank you, Chair, for the time.
Thank you. All right, seeing no other questions from members, I thank you so much for the high-level overview. It was very informative. I appreciate the work that you do, and we look forward to this continued conversation as we move into the session. So with that, members, we will move on to the next item on our agenda. I know I said at the top of the meeting that we would take lunch around noon. We will take lunch after the next presentation from the Division of Welfare and Supportive Services. Good. It's still morning. Good morning.
Good morning, Madam Chair and Committee. For the record, my name is Robert Thompson. I'm the Administrator of the Division of Welfare and Supportive Services. I have with me today Deputy Administrator Kelly Cantrell, Deputy Administrator Lisa Swearingen, Deputy Administrator Marlene Whalen, and we also have with us in the audience our Agency Manager Brooke Yarborough and our Chief Financial Officer Crystal Bousquet, in case the questions get too difficult for us. Next slide. Our first slide to talk about is our mission and vision statement. Our mission has not changed. Our mission is always to be a safety net for Nevada with a vision of providing the most excellent customer services we can. But we really like to talk for a minute about who our customers are. Traditionally, we talk about our customers as being Nevadans that come in and apply for assistance, whether that be food stamps, Medicaid, cash assistance, energy assistance, child support, child care. But our customers are more than that. Our customers are you. Our customers are Nevadans who are paying taxes but not applying for assistance because we need to make sure that money is spent wisely. And we have a very close relationship with retailers and our community partners, and we consider them our customers. We have a strong history of being Nevada's safety net. I have had the pleasure of working with the Welfare Division since 1996. I began here as a caseworker. I have worked here, and this is the only division I've worked for. And we have faced many crises. We were here during Hurricane Katrina when we had people from Louisiana coming in, and Deputy Administrator Kelly Cantrell was an online caseworker meeting with those individuals. We worked here during 9/11. We worked here during the 2008 housing bubble, and most recently during COVID. During COVID, we were more than a safety net for just the Welfare Division and Social Services. We crossed departments for the first time in our history. Director Whitley worked with the Director of Employment Training Rehabilitation, and we provided staff to process over 500,000 unemployment claims. We work really hard to be the safety net for Nevada. We know that if we weren't here, children go to bed without food. That's simple. We are simply a safety net. But what's not simple is how we do that completely with the whole picture of what we do for Nevada's economy. Our operating budget is large. We're going to come today and ask for a large allocation of general fund to support this large division. But we are primarily 1/4 funded for general fund to run our operations. But what that budget does not represent is the food stamps that we issue. The food stamps are not part of our budget. And our food stamps that we issue prior to COVID, we were issuing about $58 million in the year prior to COVID in food stamp program. We were issuing $48 million a month to 220,000 families. That was the norm then. We went through the public health emergency. The caseloads changed. Additional federal funding came in. We have since unwound all of those specialized programs, and we are now in the new norm. And in the new norm, we are issuing approximately $92 million a month in food stamps to 275,000 households, or $1.1 billion in food stamps per year that are not part of this budget. When we take into account the food stamp budgets, food stamp benefit that we'll be issuing over the next biennium, we're projecting to be issuing $2.2 billion in federal funds back into Nevada's economy through the pockets of eligible Nevadans, through to the retailers, to the truck driver that brings the lettuce in, to the cattle rancher who might not even realize that we're also working for him. And then we take into account the federal dollars that come in to support our administrative costs, the salaries, the rents, and all of that that's infused. The welfare division is responsible to bring in an estimate of $2.8 billion into Nevada's economy from federal funds, and that is not all reflective in this budget. That means the average welfare employee, each one of us, the deputies at this table, me, our caseworkers who administer the benefits, we anticipate each individual employee bringing in $1.1 million in federal funds into Nevada's economy over the biennium. So when we talk about our budgets and we talk about our requests, I never want to forget that it's a bigger picture than just our administrative costs. Next slide, please. The next slide is, that's also my longest slide. I'm not going to take up a lot of your time today. I just really get going on that piece of it. The next slide is a shot of our organizational chart. It's not everything we do, 2,400 and something employees. Our organizational chart is like 200 pages long or something. This is one snapshot. Next slide, please. On the next slide, we start talking about our summary of agency operations, and the first piece of what we talk about is our program eligibility and policy. Policy and eligibility is everything. It's our meat and potatoes. It's what we do to get the benefits out to the families. We work under 4 government entities. We work under Food and Nutrition Services for the SNAP, also called the Food Stamp Program. We work under the Administration of Children and Families for TANF. We work under the Center of Medicaid and Medicare Services, contracted under the Division of Healthcare Finance and Policy for Medicaid. And of course, we work for Nevada under Nevada revised statutes. When it comes to eligibility and policy, we don't necessarily control everything that we do or make those decisions. We're a compliance-based agency. The federal government gives us our guidelines. Nevada gives us our guidelines. There are thousands of pages of regulations that we combine into these policy manuals so that our staff can release the benefits. And I was trying to think of a really good example of one of those things to talk about in those thousands of pages of regulations. In the food stamp program, there is a regulation called Able-Bodied Adults Without Dependents, ABODs, and it is a time restrictive program or regulation that says people without children who are able-bodied can only receive food stamps for a specific amount of time, and it's very complicated math because the federal government came up with it. But in Nevada, in the 2017 legislative session, a law was passed in Nevada that we are required to ask for a waiver every 2 years to be flexible and not put those requirements in place. So of course we do that. And that's going on this week. We'll be putting through the waiver, and it's tied to the unemployment rate in Nevada, and we believe that's going to be approved. But that's one example in thousands of pages of regulation of what we work on, that we're a compliance-based organization. We're here to implement what you choose for us to implement and what the federal government tells us to implement. Those rules and regulations are not necessarily something we're deciding at an agency level. The next piece of what I want to talk about was our program outreach. In program outreach, when I was a caseworker, the only way that you could access our benefits was to come into an office, fill out a 22 32 or 26 or 35-page application, whatever it was in those days, and go through an interview. And we've streamlined since then. We are now out into the community, also a brainchild of Director Whitley's, and I was a supervisor at that time. And we are out in the community in hospitals and mental health facilities and homeless centers and even in the jails to connect with those eligible Nevadans to make sure they're levying the benefits that we can get to them, always with that overarching goal of, are we reaching every eligible Nevadan to bring those benefits into Nevada? Currently, we are serving approximately 200 non-traditional sites out in the community, but we have about another 100 sites that are on a wait list wanting us to come out there. We do plan on expanding the outreach program, but as Administrator Weeks talked about, even though we've done fantastic work in hiring, we are still stabilizing our workforce, and we have a lot of new staff, and we would not necessarily put new staff out into the community until we're sure what they're doing. We're sure that they know what they're doing. The next piece that I'd like to talk about is employment and training. And Director Whitley touched on that it's our job to move all Nevadans that we can out of poverty to reduce their dependency on social services. And we do that through an employment and training program. When we present our slides and we present our caseloads, one of the caseloads that people get hung up on is our welfare caseload. And we see in the welfare caseload, it stays very static, it stays very flat, and there's about 4,500 Nevadans receiving 4,500 adults in Nevada receiving welfare cash assistance. But they're not the same adults every month on that chart year after year. They transition through. The average, last time I looked at the statistics, the average adult only stays on assistance in Nevada for, it's something like 14 months. We work with those families. We engage them in employment and training. We engage them in workforce development. We move them on, but new families come on. New families face barriers, and often younger families. So as you're looking at our caseload and see that it's staying flat, it's not necessarily the same people that are on that caseload. It's a constant revolving door. Next slide, please. The next area of the agency we talk about is program oversight. Program oversight is our investigation and recovery department. We have a hearings department. We have quality control. We have quality assurance. We have quality reviews, case reviews, training, and training academies, and that we consider all of that program oversight. It's important to make sure that we're doing the job not just timely, but correctly and accurately. I think Administrator Weeks talked about how the federal government comes in and audits them. They also come in and audit us, and if we are not accurate in the casework that we do, we face fines. And we want to be accurate in the casework that we do. The next area that I like to talk about is child support and child care licensing. We break those out separately because they are not programs. We are enforcement over those areas. Child support is it's child support. It's where we help with the court orders and collect child support to move into the hands of the custodial parents from the non-custodial parents. Child care licensing, it is our job to make sure all child care centers are safe and up to code. And child care licensing is part of our child care program. It's a subset of the child care program, which I talked about in the first bullet point. The child care program is going through some changes right now. We are primarily funded federally with the child care program. The TANF block grant funds child care, and there's a mandatory match that funds child care. During the COVID event, the child care program received additional funds that more than doubled the norm. And we were working as hard and as fast as we could to put that money out into the community to serve the families to make sure that they could get back to work. Those funds have since expired, and we are having to move back into the new norm, which will cause that caseload to revert back to how it worked before COVID, keeping in mind that the costs are not the same as before COVID. The funding levels are the same, but the costs aren't. Salaries are higher, rent is higher, inflation has caused everything, increased the cost of everything. So we are having to be creative in that program and run it differently. We have heard complaints from some of you about the child care program and there being delays in payments. We are moving the child care program. There are two primary contractors within the child care program. We are have made the decision not to continue with one of those contractors and to move the payments in-house. And we will have direct oversight. Not only does that eliminate duplication of efforts and eliminate some administrative cost to stretch those dollars further, it puts it on us to make sure those dollar amounts get out immediately. And we have those plans put in place to bring that all in-house, to shorten the time frames that the providers are receiving their benefits, and stretch the dollars for the families so that we can serve as many families as possible. In budget account 3230 is the TANF program. We did increase the TANF program to the maximum allowed by federal regulation. So there are additional dollars in the TANF program, from the TANF program, put into the child care program. And while not all of that is necessarily a budget item, some of you have reached out to us and we wanted to know that you had been heard, and we are addressing those issues in child care diligently. The last bullet point of that slide is our administrative services, and that is our fiscal services, human resources, and information technology. All of those employees are put in place, and all of us are here to serve program to make sure those benefits get out. Next slide, please. Our accomplishments. The first accomplishment is my favorite accomplishment. This is my 4th legislative session, and my first legislative session as deputy administrator. I had to come forward in front of you and tell you that we were not meeting the work participation rates in our TANF program. In the TANF welfare program, for adults to be able to receive TANF assistance, the state is required to have all adults receiving TANF assistance working in countable activities. 50% of them must be meeting a benchmark. If there are 2 parents in the household, we are required to have 90% of those households meeting the benchmark. We weren't necessarily doing that several years ago, and we had to put corrective action in place, and I testified in front of you that we were facing financial penalties. We put corrective action in place. We started meeting those benchmarks. The penalties were waived. The vast majority of those penalties were waived, and we started meeting the benchmarks for the 50% piece. We did not think we were ever going to meet the 90% piece for the 2 parents in the household. Nevada had never done it before. When welfare went into effect in 1995, that's when these rules went into place, Nevada had not met that benchmark, and we have been notified by the federal government recently that we met the benchmark for both criteria for the entire TANF population, which shows our workforce development, employment, and training is working, and we are moving those families into countable activities. The second piece that I wanted to talk about was our SNAP eligibility accuracy. Like I said, I've been here since 1996. I have been around when Nevada was not doing great in eligibility accuracy, and I think there was a time that in those last 28 years when we were actually one of the lowest in the nation, if not the lowest in the nation for a minute in eligibility accuracy. We are currently 13th in the nation and 3rd in the Western region. And we were recognized at one point by the federal government as being the 3rd most improved state in the nation. And I thought that was important to point out. Our vacancy rates, I'm going to shout out to Deputy Wayland, who is over HR, for the work that they did doing what we called warp speed hiring. In November of 23, our vacancy rate hovered at 21%. But because of the cost of living increases that you approved and the governor's order that we did not have to evaluate for minimum qualifications for grade 29 below, half of our agency is grade 29 below, and I didn't have the barriers that some of my peers had regarding hiring clinicians and that. We hire customer service staff. We were able to go into warp speed hiring, and we are at an estimated 6% vacancy rate today. That brings some work with it when we have 50% of our staff being new, and it takes almost a year to bring them up to speed to train. So the deputies have their work cut out for them, but I know that we can do it. The summer EBT program is our last accomplished that we're going to talk about. We did implement summer EBT for the summer of 2024. We served over 310,000 children, and we rolled out over $37 million in benefits. Next slide, please. The next slide is our goals. Our goals are not as lofty in the next biennium as they were in the last biennium. We've gone through a lot of crisis. We've gone through a lot of unwinding. We've gone through a lot of hiring. And at this time, we want to stabilize. We want to continue meeting those work participation rate goals, but we do want to increase access to education and training to reduce dependency on social services, and we will continue with our robust workforce development team. We want to increase our outreach presence in the community, and we will increase our outreach presence in the community once we have our workforce stabilized. They're struggling right now with keeping caught up because we have such a new workforce. It takes almost a full year for our caseworkers to become fully adept to the work that they do. The first 3 months that they work with us, they don't produce any casework. It is full training in a college-style classroom. So the first 3 months, we get nothing, absolutely nothing. The next 2 months, we actually consider them negative. They come out into the workforce, and because the work that they do is slower and has to be re-reviewed by a second person, they end up being a negative to our production. So it's about their 6th to 7th month when we start consider them productive, but even then we only consider them about 50%. And it's about their 11th month when they're passing probation that we can fully consider them full caseworkers. Prior to the COVID event, 14% of our caseworkers had less than 1 year. After our warp speed hiring, we are at 26.6% of our caseworkers have less than 1 year today, which is a huge amount of our staff that we are having to duplicate work to make sure their work's accurate. And sometimes we expect our caseworkers to process 6, 8, sometimes 10 tasks a day, depending on the type of work that they're doing on. Some of the new caseworkers can only do 1 or 2 because they're going through thousands of pages of regulation trying to implement all of that. We want to expand our investigations and recovery team. We are seeing a rise in crime and fraud. We're seeing a rise in customers' benefits getting stolen and people attempting to apply with fraudulent identification. AI is not working for us in that area, but we are having to identify that, and actually sometimes we will show AI a picture of something was made by AI to figure out that it was AI, to be able to deny those applications and then address the crime that's taking place. And we want to continue what we're doing with the vacancy rates. We cannot stop the philosophies that we put in place. We changed up our entire philosophies with our hiring teams that have been in place for decades, and we can't go backwards. We have to continue with our eligibility accuracy, which is a challenge for us when we have so many new staff, and the timeliness and the policy and procedures and everything that requires oversight. So our goals are just to maintain and continue with the successes that we've been doing. Next slide, please. The next slide, 2 of our highest budget priorities. One we heard about earlier today is to rebrand the Division of Welfare and Supportive Services to the Division of Social Services to eliminate the stigma of welfare. Traditional welfare is a very small piece of what we do. I talked about the the SNAP food stamps, Medicaid eligibility, energy assistance, child care, child support. I feel like I'm missing one, and they're going to be mad at me when they watch the video. But the welfare is 17% of what we do overall, and tying that word welfare that has such a stigma to it into everything that we do, the governor's budget does recommend that rebranding. And we are requesting funding to continue moving forward with the summer EBT program to be able to issue those benefits for the future summers. Next slide, please. Our major enhancements, the first major enhancement is the summer EBT program, where we will be issuing $40 per month per child for the 3 summer months for children that are income eligible. They would have to meet income criteria if they were eligible for free or reduced lunch the prior school year. So that's our number one request. The second request is for an income verification system that is a mandatory request. This income verification system is not new. The income verification system we have been using for years, but it was paid for by the Center of Medicaid and Medicare Services 100%. Medicaid and Medicare Services, while requiring us still to continue using an income verification system, will now only cover it at 75%, so we have to pay the difference. You heard in public testimony today regarding temporary assistance for needy families, and the recommended budget does expand our services and temporary assistance for needy families using opioid-funded dollars. The family preservation and support services would be done through subawards to support children who were removed through the court systems and need supports for family members that are raising those children. In the Kin Care program is similar to that program, but it expands the welfare TANF program as we know today. The welfare program has a non-needy caretaker program currently in place that provides assistance to non-parent relative caretakers, grandmothers, usually grandparents, aunts, uncles, can be adult siblings, that receive a welfare grant each month to raise those children. However, if the non-parent caregiver is age 62 and above and has guardianship, there's additional funds that are provided. The welfare program does not have the funding to remove that age limit of 62 and it open up to everyone, but using this funding, if the children were removed from the parents due to opioid use, we could remove that age limit. And if it's a sibling or a younger grandparent, because most grandparents aren't 62 years old anymore, they're raising the grandchildren at much younger ages. So that is the ask for budget account 3230. Next slide, please. Our next slide is our TANF projections. The TANF projections went to an all-time low during the COVID event. That was a nationwide thing that happened, and in Nevada. We saw that coincide with the stimulus checks that were going out to families. The TANF caseload started dropping nationwide, and as would be expected, when there's a labor shortage and we're able to find employment for people that aren't necessarily the highest functioning people that struggle finding jobs on their own, the TANF caseload will remain flatlined. Keeping in mind, as I said before, when the families are receiving TANF and those adults are receiving TANF, it's a revolving door. It is not the same adults that are receiving TANF year after year. Next slide, please. The next slide is our Medicaid projections. Our Medicaid projections, as I indicated, we contract to determine Medicaid eligibility outcomes for the Division of Healthcare Finance and Policy. These projections are based on their projections. Next slide, please. The SNAP projections are, I'm going to pause for a minute and talk about this caseload because I think this is very interesting information. The SNAP caseload is projected to pretty much flatline. It grows a little and it drops a little during the next biennium projections. However, I want to point out something in this caseload. Prior to the COVID event, we were receiving approximately 37 applications per month in the SNAP program and approving 87% of them. Now we are receiving approximately 43,000 applications a month, but we are only approving 82% of them. More people are coming in to apply and less people are eligible. More people are requesting assistance, which makes sense when cost of living is higher, food prices are higher, and people are struggling to get by. However, wages are also higher. And the income levels for these programs are set by the federal government. And generally speaking, and it's always general because all the computations are very complicated, but generally speaking, the benefit level or the income level to receive the food stamp benefit is 130% of the federal poverty. So while we are receiving more applications than normal, we're denying a higher ratio of them. And that creates a significant amount of work for us. It is easier to say yes than it is to say no. The more we deny applications, it creates conferences, it creates hearings. Every negative action we take comes with a hearing opportunity to file for hearing, and people do file for hearing. And people will reapply. They will reapply because they heard their neighbors say, I was eligible, so you should be too, when the regulations are thousands of pages long, so which two families that may appear similar to them, when we start digging in, they're not similar because different incomes counted a different way and different household sizes are counted differently. So we end up telling people no, and they reapply. And they reapply for us to tell them no again and again. We do meet with them. We do try to explain. We do warm handoffs to the food banks and other resources, but additional applications that correlates to not approved cases with a flatlined caseload can actually result in the need for more staff, which can be very frustrating. And I just wanted to point that out. Our next slide is we call it the bubble slide. This snapshot is a couple months old because it takes a while to put together. It's a manual computation. It is a representation of our customers in our big three programs, SNAP, Medicaid, and TANF assistance, who receive more than one program. 55% of our recipients receive 2 or more programs. And as you can see from the slide, almost nobody receives TANF assistance by itself. There's 110 families there. Those are usually children who are receiving their insurance from their grandparents. Sometimes grandparents can put the children on if they're guardians, and they receive that. SNAP recipients, those would normally be working individuals or veterans will sometimes have their own insurance. But our recipients usually come in to receive more than one program, and we offer integrated services with an integrated customer service philosophy. On the next slide, is a snapshot chart of our budget request showing 58% of our request is federal funds, 23% is general fund, and 19% is other. Other can be things like fees, and on the back of our power bill, there'll be a small little amount for taxes that comes over to the Energy Assistance Program, and that can be something that's in other. On the next slide is a snapshot of all of our budget accounts, just showing it broken out from general fund, federal fund, other, and the total amounts. On the next slide is our position summary. We're coming into legislative session with 2,452 staff. We are anticipating a need for additional 36 staff in caseload. The caseload is rising slightly. Not a huge spike this legislative session is projected, and we are requesting some enhancements. Those enhancements are primarily in investigations and recovery and HR. And on our last slide, we do have one bill draft request. It's a pretty simple bill draft request. The IRS, we have access to IRS information in our computer systems, and the IRS is now requiring that we do fingerprinting background checks on all of our employees every 5 years. NRS does not align with that requirement, so we are putting forth a bill draft request to realign that Nevada revised statutes to allow us to do the fingerprinting every 5 years. And with that, we will open it for any questions.
Thank you so much. I know we have a few questions. We're going to start with Senator Titus.
Thank you, Madam Chair. And again, thank you for that pretty, even though high level, pretty intense presentation. I appreciate it. On page 9, you mentioned that you're mandated to check and verify income levels from the federal, at the federal level. Do they mandate that you check residency? I mean, how long do they have to be Nevadans before they can apply? How long do they have to be here? And I bring this up because I worry about the unfortunate situation in Southern California right now where we know people are being displaced. And as a healthcare provider, I've already been warned from, or a heads up from our medical board that, hey, people may be coming in, they need their prescriptions filled, et cetera, because of this huge amount of displaced folks. How long would it take for somebody that has just come to Nevada to be able to get services?
Robert Thompson, for the record, Madam Chair, through you to the committee. The first day. The regulations require that the applicant have an intent to reside in Nevada, and as long as they indicate that they intend to stay here for at least the full month, which is the benefits that we issued, there would be no issue with us approving the benefit.
So the benefits are done on a monthly basis then, is that correct? And they don't have to reapply every month, do they?
No, Robert Thompson, for the record, when we approve, different programs have different regulations. Food stamp benefits are approved in normally at 6 months. Medicaid is approved ongoing with us doing annual reviews. TANF as assistance is approved ongoing doing annual reviews. So they do not reapply every month, no. The majority of our customers reapply once a year. But even then, some of that is done through automated systems that do not require that they fill out new applications.
So follow up, if I might, Madam Chair. So if these folks then have come, they apply day one, they qualify, how do we know there's not duplication if they leave the state of Nevada? I mean, it's one of the issues that we had with our Medicaid during the COVID, where people moved, they weren't here any longer, and we just didn't keep up with, you know, they lost eligibility, and it's been quite the mess trying to keep track of these folks. Is there some cross references, like say when they go back to California, if they do indeed and they apply there, then they automatically drop off from our rolls?
So Robert Thompson, for the record, they would not automatically drop off from our rolls unless they told us they were leaving Nevada. But normally what happens is when applicants reapply in their own state, all of the states are in the practice of calling one another. So they call us, we call them. California and Nevada have a strong relationship because so many of our applicants cross back and forth. And then as soon as we know somebody is receiving benefits or applying for benefits in another state, we do shut their cases down in Nevada.
And I just have to follow up on what you just said about they don't really call us, do they? Isn't there some computer system that automatically pops up? And I can't imagine we would have personnel making phone calls.
Robert Thompson, for the record, there is not a computer system at this time that cross-references the states to be able to do that back and forth. The federal government at this time is putting in a system in. We have been requesting this system since 1996. I can remember one of my first requests from the federal government was that type of system. There is not an automated one at this time, but at this time it is a manual process. The number of our customers that do just call and tell us so that they can get their notices, you would be surprised at how many do tell us they want that notice in their hand because they know when they get back to their own state, if they don't have their notice, it slows down their approvals. So people that are used to the social services system tell us right up front.
All right, thank you for that. Thank you, Madam Chair, for the questions.
You're welcome. Senator Buck?
Thank you so much, Chair. I wanted to say congratulations. Thank you so much for helping so much with the daycare provider situation. I know that we quite literally, Ms. Moscow and myself, had constituents show up on our doorstep wanting reimbursement. They hadn't been reimbursed since September of last year. They were owed over $180,000, and I know that wasn't the state's fault, but it was this third-party vendor. And I wanted to give a congratulations, thank you to Brooke Yarborough from your team. And my question is there a better way to track resources and prevent this from happening again? Because it seems quite daunting for our providers that we rely on, and they get an IOU saying that they will be paid by the state inevitably through a third party, but is there a way to prevent this from happening again?
Madam Chair, through you to the committee, I am not going to steal Deputy Swearingen's thunder. I'm going to let her. She has been living childcare with Agency Manager Brooke Yarborough, who's in the audience, so I'm going to let Lisa Swearingen fill you in on the child care updates.
Good afternoon. Lisa Swearingen, Deputy Administrator for the division. So Brooke Yarborough, who's one of our new agency managers, came up with a project. So we are going to be building we're going to be running a pilot project, and we're going to be looking at pulling in eligibility to the state. This will streamline this process where we will be doing what we do best, eligibility determinations. We will be able to streamline that process for these individuals that has been taking anywhere from 30, 45, sometimes 60 days to get these applications approved. Streamline that down and get that processed within a timely timeframe. And then by doing that, we're also going to be processing those payments in-house. And so right now, some of those payments, as you know, are not going out timely. We're looking to have those payments, once we get them set up, released to the families. I think we were looking at 14 days. So it's exciting. We see that coming. It's going to be a lot of work, but we have a lot of faith in the fact that what we're doing, she's had some amazing ideas. We've been working with the vendors, and we're recruiting staff right now to bring them in to take on and train to do that eligibility piece.
Senator Neal?
Thank you, Madam Chair. So I just wanted to go back to slide 13. You had recipients by program. How much of that is associated with the project you guys took on with No Wrong Door? Because I see a lot of crossover, but I also see that the 44.2 million will be removed from the No Wrong Door project, which I thought was set up to help, number one, clients or customers receive services.
Okay. For the record, Lisa Swearingen, Deputy Administrator. The No Wrong Door project is still underway. We are looking to kick that off. I want to say it's February 3rd. We've been working with the other agencies, Aging and Disability, DCFS, as well as Department of PBH. We've been working with them collaboratively to make sure that that No Wrong Door process will work for every agency, and what that looks like. We have kind of struggled a little bit, mainly because we are requiring a guest mode feature for people to sign in. But once we have that up and running, that's not reflected here because we haven't actually gone live yet. Once it goes live, I'm also looking at offering this up to other agencies and county partners so that they can then access that process as well.
Thank you for that. So what is the cost for what you're doing and the collaboration? And so the removal of the 44.2 million does not impact the Talk to me about what's in that budget, right? So if you're going to take 44 million away, what's left?
So I'm confused about the 44 million. I'm sorry, Lisa Swearingen for the
So,
record.
under the Welfare Administration, there's a recommendation to remove 44.2 million from the 25-27 biennium. This was ARPA money, so I'm assuming that some of that money was used to get you guys to the live position. So, break this down,
Okay.
help me understand.
Okay, so Lisa Swearingen for the record. We received 12.5 million for ARPA funding to put on the No Wrong Door project. Originally, when this went live or is going live, we came to an understanding that it was going to actually be a cost associated for the other agencies to look at that and be able to help fund their pieces of that. The agency decided to cover that ourselves, and so we are not, I believe, asking for money for that. We're going to go ahead and just cover that with my own IT staff. And then we received 48.5, I think, for the mainframe modernization. And that we've already implemented phase 1, and we are actively working on phase 2. And both of those projects are on track to be finalized before June of '26.
Madam Chair, can I have a follow-up? So for the IT staff that you're using internally, what's the cost for that?
For the record, Lisa Swearingen, we just cost allocated across. It's no different to that. That's their normal job, is to do system updates. And so we have staff that are assigned to the agency to work IT and work those systems. And so they just cost allocate it out to whatever program they're working on.
Okay. Second question. So can you break down the removal of the 500K on the 25-27 biennium that was associated with the study on the causes and effect of youth homelessness that was commissioned during 23-25? Did the study not happen? Are we not doing the study? What's going on?
Robert Thompson for the record. The study went forward. The study was paid. The line item that you're looking at was a transfer of funds from one year to the next, and I would have to have the chief financial officer come up to explain that in depth.
So in short, that was like extra money you guys buffered in, and now it's rolling?
Crystal Busquet for the record. Yes, so we're bringing it in. It's in the current biennium. Any funding we do not expend, we will be carrying forward to next biennium. But I believe it's going to be spent this year.
So let me get this right. Okay, so there will or will not be a removal of 500K over the 25-27 biennium that happened to have been COVID dollars.
Crystal Busquet for the record. That's correct. It's just a line item adjustment. The funding will be spent.
Okay, the math is just getting real weird. So is there going to be, I'm just saying, like, is there an update that you're going to provide that shows, like, what's real and what's not real?
Madam Chair, through you to Senator Neal, if we could put that in writing back to you to explain it out. We had a discussion in depth about this. The study did move forward, and those were line items. I had the exact same question that you did. We did not bring that explanation with us, but we can get it back to you.
So while we're putting stuff in writing, can I ask for another piece, because I think this may have the same response. So there was a recommendation to remove 43.5 million over the 25-27 biennium, and this was money that was ARPA that was going to pay for or incentivize construction of new and expansion of existing childcare facilities. So is that deal happening or not happening? Did it occur and we're not aware?
Robert Thompson, for the record, the money that was allocated to the child care communities is being spent as promised. The line items in the budget are confusing, and we will get it in writing to you in a manner that makes sense.
Okay, thank you. Thank you, Madam Chair.
Thank you. And Senator Neal, just to put a little more clarity on those questions that you were asking, I've asked staff to chime in on that.
Thank you, Madam Chair. For the record, Sarah Kaufman, Fiscal Analysis Division. Just to provide some clarification, last session, we had some of the ARPA money actually built into the budget, so you could see it in year 1, year 2. What we noticed in the governor's recommended budget is that they're just taking that money and suggesting that it be balanced forward, so you may not see it in the budget. The committee could provide direction to fiscal staff as we're moving forward into the budget review to actually put that money into the budget, but then that would take out that mechanism of balancing it forward to year 1 and year 2, and it would actually provide a budget for the next 2 years for the remainder of the spending of that particular money.
I hope that helped. Any other questions? Senator Stone.
Thank you for the presentation. On your slide 5, you talk about fraud in programs and recovery. Can you talk about what the magnitude of fraud is that you've been experiencing and what the impact of AI has been, and what kind of success have you had in recovery?
Robert Thompson, for the record, we have seen an increase in skimming and cloning of criminal activity, creating fake accounts and taking the benefits away from our customers. When it comes to the actual statistics, Deputy Wayland is over our investigation and recovery department, and she has some of those statistics with her.
Hey, thank you.
Hello, Marnie Whalen, for the record. So historically, we put some data together, and we have seen increasing trends. We had an increase in about 6,000 of our referrals that we received from FY23 to 24, and halfway we were at 10,500 through FY24, and we were at a little over 4,500 at the end of FY23. Already year to date for this fiscal year, we have 7,277 referrals. And a lot of that is through the skimming and cloning. Just people are, so it's a lot of extra. And so part of our request for the additional INR staff is to address that increase and to put some additional resources towards a lot of the fraud analytics that are out there to determine kind of what avenues they're coming from.
So if I can just follow up, what is the magnitude in dollars that we're talking about?
So I know that when we did the skimming and cloning, like the replacement benefits that we had in place, through that program, we had replaced close to $5 million in benefits in over like a 1.5 year period. I don't have that data, so if you want more specifics on what we're recovering, because we do issue like overpayments and that kind of stuff, we can get that back to you.
Robert Thompson, for the record, clarifying that those $5 million were federal benefits and we are a pass-through agency. That was not Nevada General Fund dollars.
Thank you for that. I appreciate that. And with this new sophistication that's out there with AI, how do you plan on getting ahead of it and minimizing the fraud if possible? I don't know if there's any innovative AI that we can use to combat the AI abuses that we're experiencing.
Robert Thompson, for the record, we are having those conversations too, and we're meeting with other states to determine how they're doing it. Right now, we are requesting additional staff to be able to address these issues. It is likely that next legislative session we'll be asking for funding for AI itself.
Thank you, Madam Chair. Thank you for answering the questions.
Thank you. Members, any other questions? All right, not seeing any. Thank you so much for the budget overview presentation, and we look forward to seeing you with a more deeper, in-depth conversation as we move through the legislative session. Members, that brings us to our lunch. It is 12:35-ish. Plan to be back here in your seats no later than 1:35. And lunch will be served downstairs in the Assembly caucus room. For everyone that's here in the room, unfortunately, we are having some IT issues. So it's going to take about 10 to 15 minutes to get those fixed. As soon as have it fixed, we'll be able to start again. I apologize.
Hello, hello. Okay. Good morning. This is a sound check. Thank you. All right. This is Zoom 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Over to you, Zoom.
Thank you, Austin. Mic check. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Passing it to Cindy.
Thank you. And sound check 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Excuse me. Passing it to Vegas. How are we sounding?
You guys both sound good on my end. Mic check 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. How are we sounding?
You all sound beautiful and wonderful. Can we get a screen share real quick? And that looks great. Awesome. I'm going to do one more count for streams. 1, 2. We'll hold for a minute. All right, and that's the nod. Thank you so much.
All right, good afternoon, everyone. I hope that you had a healthy and delicious tasting lunch. We will bring the committee meeting back to order, and we will invite to the testimony table the Division of Public and Behavioral Health.
Good afternoon, Chairs Monroe Moreno and Dondera Loop. Thank you so much for the opportunity to present to you today. My name is Cody Finney, and I serve as the Administrator for the Division of Public and Behavioral Health. I'm joined today by Julia Peak, the Deputy Administrator of Community Services, Drew Cross, our statewide Forensic Program Director, and Andrea Rivers, the Deputy Administrator of Fiscal Services. We have a very high-level presentation for you. It was my intention to go through these slides fairly quickly and leave you plenty of time. If you prefer something else, let me know. Okay.
Fairly quickly will be good.
Got it. All right. On slides 2 and 3, we're highlighting our mission, vision, and purpose. In very briefly, we work to make everyone in Nevada healthier, happier, their life longer and safer. And that really does bring us to work every day. So I encourage you to read through those core values that we worked very hard on as part of our accreditation efforts. On slide 4, we've got our current organizational chart, and you can see our leadership team and the oversight of this various sections. Slide 5, we've got highlights of our operational units. As you can see, the division is very broad, and currently we have programs that provide services, programs that administer grants to groups in the community to provide services, and programs that regulate private industry. So a wide array of things that we're doing. We have impact at micro and macro levels. All right. Moving right on to our agency priorities. I'm sorry, this seems to only catch me sometimes. On slide 6, we've highlighted the top priorities. First, the critical need for forensic mental health services. We've made efforts in the interim to address both the length of time that people are waiting and the number of people that are waiting to be admitted to services to restore them to competency. We've had some very significant success there, and some of our efforts are aimed at continuing several of those initiatives. Secondly, we've made great strides in the implementation of 988 and the crisis stabilization system, and we'll continue that work into the next biennium. And last, but certainly not least, the governor's budget includes the continuation of investment in public health that was made last session in SB 118. We continue to work with our partners to ensure that all of the health authorities across the state are able to serve our constituents with an efficient and effective manner. One of the common efforts we've got there is accreditation and reaccreditation through the Public Health Accreditation Board. All right, continued accomplishments. Workforce. Our vacancy rate had been as high as 26%, and we're down to about 16% overall. We've allocated resources to a statewide recruiter position and developed a recruitment strategies manual that allowed us to focus those hiring efforts. We've developed a website to assist the navigation of possible health-related jobs in Nevada for the public. That's nevadahealthforce.org. And this site highlights career paths, scholarships, and training opportunities for individuals in those fields. As I mentioned, the wait for admission to forensic mental health services had expanded during the pandemic, and we will talk about some of the multi-purpose or multi-pronged approach that we've used to address that, to reduce those waits. We've also successfully submitted our application to that Public Health Accreditation Board, also called FAB. They will visit us to assess that application in the next 6 months or so. I want to point out that this has been a massive effort for the agency, including the development of a statewide needs assessment, statewide health improvement plan, a strategic plan, and a performance improvement plan for the agency. In that effort, we submitted over 200 documents to that board for review. So we're very proud of the effort that many people made in getting that application done and very eager to see that accreditation completed. Lastly, DPBH became one of only a few states that received advanced recognition as an age-friendly public health system. So that demonstrates our success in supporting all Nevadans throughout their lifespan with focus on healthy aging. For our budget priorities, we continue to work on the implementation of that crisis stabilization system. We've executed the contract with Carillon that's the basis of the call center, an additional call center to the one that already exists in Nevada, and the hub for dispatching mobile crisis services across the state. A coalition has been started to bring together for the intricate detail level collaboration, the various providers that are working on this system overall. The call centers is expected, the additional call center, there is one in the north, there will be an additional one in the south. That additional one is expected to be online this summer. And through some ARPA funding, we have partners that are opening crisis stabilization centers in both Reno and Las Vegas, and Carson Tahoe does currently have an operating crisis stabilization center. All right, on public health, slide 9, we have 2 priorities in public health that will enhance and streamline services for our residents and businesses. This includes the transfer of the environmental health regulation of food establishments, shellfish distributors, and bottled water to the Nevada Department of Agriculture, and the transfer of the Bureau of Healthcare Quality and Compliance to the new Nevada Health Authority. We go on to highlight some of the efforts with public health that align with the governor's priority. Again, our continued focus on workforce, we've had some great success there. And through federal grants, we're working to modernize and increase the interoperability of various information systems that will allow more timely and efficient data analysis for the benefit of the health of Nevadans. Slide 11 shows the breakout of the funding sources overall for the division and demonstrates a very modest 2% increase. Slide 12 demonstrates the various budget accounts that go with that very broad array of operations that we have, and the funding sources that are allocated to each budget account. On slide 13, we have the summary of position changes. This illustrates some realignment of positions and results in a net increase of about 17 FTE. The increase is primarily related to an increase in forensic mental health services. These positions are those that are funded by any funding stream. So general fund, federal funds, all of our funding streams are represented there. On slide 14, we have a chart showing the number of people served in the safety net mental health services. Of course, the vast majority of mental health services are provided by private providers in the community, much of it funded by Medicaid, but we're here to serve those who don't have a payer source that makes those services accessible, and of course, that forensic population. On slide 15, we have the changes, enhancements, and maintenance units that are related specifically to caseload. These are adjustments to align us with previously approved legislative caseloads in mental health and immunization. On number 16, we've got the enhancements specifically for forensic mental health. These are the initiatives that we're seeking to continue, specifically to address that wait list that we've been able to improve, but expect that that demand will continue to grow as it has nationwide. So we've got staffing and operations for an additional 21 beds at the forensic facility in Las Vegas. We've got skilled nursing services that we were able to stand up with ARPA funds. These are for long-term mental health patients that have become aged and infirm and really require a level of care that psychiatric hospitals are not designed to provide. And we've been able to purchase those services in the community for this small group of patients. We've got an opportunity for restoration before proceeding to long-term commitments. NRS 178.461 allows for a commitment for up to 10 years. We'd like to make sure that we take the opportunity to restore an individual to competency before we move to that step. And we've got an update to the competency evaluation protocol that would bring Nevada in line with national standards. Here we highlight some federally funded enhancements to our Bureau of Behavioral Health, Wellness, and Prevention. This would allow us to improve the operations of that bureau and certifications that they're responsible for. That's more of a regulatory function with the private providers in the community. This slide also lists the transfers of the environmental health program and healthcare quality and compliance that I mentioned earlier. Lastly, on 18 and 19, we have the list of bill draft requests. The purpose of those I've mentioned previously. We're happy to answer any questions that you all may want to go over.
Thank you so much, and I know we do have a few questions. We're going to start with Senator Taylor.
Thank you, Chair. And thank you so much for the presentation. Just one question. On slide 14, you looked at the number of people you serve, the facility populations. I noticed in some cases there was a reduction, which is surprising because we know there's a huge need from a behavioral health standpoint. Can you share why that might be the case?
Thank you so much for the question, Senator Taylor. Through the chairs to you, Cody Finney for the record. Yes, some of those reductions may be related to that increased provision of services in the private sector. This is just the safety net services that we're providing for folks who don't have another payer source. There's also been a lot of volatility in some of the numbers we've seen since the pandemic, but one very firm thing that we've seen is we've been doing some, particularly in our northern hospital, we've been doing some capital improvements to the building, maintenance to the building, and so we've had a few of those units rotating to have some of that work done, so we don't have patients on them.
Thank you. May I follow up, Chair, please? Thank you. So there is, because earlier we heard some instances where people are waitlisted because they're really in need of the services. So that has not happened, especially with the capacity reduction for this capital period.
So, Cody Finney, for the record, thank you, Senator Taylor, through the chairs to you. So we could get into some very detailed pieces about that. There are people waiting for the forensic facilities. The numbers of people waiting for civil services is a bit more variable. Were you concerned about a particular area?
No, just overall.
Overall.
Because I know the service is in very high demand, so the reduction surprised me. Thank you so much. Thank you, Chair.
You're welcome. Senator Titus?
Thank you, Madam Chair. On page 14, the facility populations, that's kind of ongoing. People come and go. What's the actual bed capacity?
Thank you so much for the question. Cody Finney for the record, Senator Titus, through the chairs to you. The bed capacity for Lake let me ask our statewide forensic director to go through those specific numbers for the forensic side.
Good afternoon. Drew Cross for the record. And so for our two facilities, Lakes Crossing is licensed for 86 beds. Stein Forensic Facility is currently at 153, the statewide total 239.
So I know, and thank you for that, Madam Chair, if I might continue. I know that it's kind of, again, an evolving situation where patients are referred to your facility basically through law enforcement, and then they're perhaps stay there for a while, or they get evaluated and then released back to the law enforcement. So what's the average time that somebody spends in those forensic facilities?
Good afternoon. Drew Cross for the record. Currently, the wait time until admission is 74 days, and treatment is approximately 80 days.
So when, and correct me if I'm wrong, I mean, when I was in medical school, I did my rotation, my psychiatric rotation at Lakes Crossing, so I'm very aware of the facility. I'm just wondering about the process, and we'll get into this in the subcommittee, I'm sure, but it's just, so you have 74-day wait period before a jurisdiction could refer somebody to your facility. You don't get any direct hospital referrals, do you? That's usually law enforcement to these forensic facilities?
Drew Cross for the record. Madam Chair, through you. The process is people are committed from the courts. They will stay in the detention center until they're admitted to the forensic facility. So that 74 days is specific to that. It's a dynamic number. It's changing all the time, but currently, as of today, that's where it sits. So 74 days from that commitment until admission to the inpatient forensic setting.
Right, so we, unfortunately, through the jurisdictions, we'll have folks that need mental health evaluation, and even more important, perhaps mental health treatment, sitting in facilities, law enforcement, jails, et cetera, or maybe in a hospital, not being treated for the average time is 74 days before they get referred for evaluation and treatment?
Drew Cross for the record. Madam Chair, through you. The treatment itself is a timely process. One thing that we are doing is we are utilizing staff, especially trained clinicians, to go into the jail. We call it the jail liaison, who actually has contact with these individuals on the wait list. This opens them up to diversion and various other avenues when appropriate. These are typically individuals with low-level charges who are nonviolent, who could potentially be diverted, which of course helps move the list along so the more acute individuals can make it to the inpatient setting.
All right, thank you for that, because it's encouraging to know that you have a process that you potentially somebody needs more acute intervention, and that you do have that process to go and intervene if needed and move them along. So thank you for that. Thank you, Madam Chair, for the question.
Thank you. And although some individuals may remain in some of the local municipalities, detention facilities, a number of those facilities do have medical staff and some psychiatric staff that can have interaction with those individuals while they're waiting to get to placement with the state. Is that correct?
Madam Chair, that is correct. Drew Cross for the record. And we're in constant collaboration with our county partners. We meet with, for instance, Clark County. We have frequent communication with them about our population, Washoe County, and we're making an increased effort to make sure we have that same contact with our rural counties so we can do what we can do while they await inpatient admission.
Thank you so much for that. Speaker Yeager.
Thank you so much, Madam Chair, and thank you for being here. You know, I'm glad to hear that we're still trying to tackle the issue of forensic beds, especially for those justice involved. So my question was, is the state still under the, I don't know, I guess it was a contempt order that the state was being fined so much money every day for folks who have been deemed incompetent but are waiting for treatment? Is that still ongoing? And if you could just kind of give us an update on where we're at with that and whether we think what we're trying to do here through this budgeting process is going to hopefully eliminate that from continuing to be assessed against the state.
Thank you. Chairs, through you to Speaker Yeager, Cody Finney for the record. We are, at times, continuing to be fined by specific courts for specific individuals. that are awaiting services. Historically, there was a consent decree. We are not currently under a consent decree. But we do, as I've said, I'm very fond of our multi-pronged approach that we implemented to try to address this and try to make sure that Nevada didn't suffer the consequences that some other states have suffered. So we've been able to get most of those prongs recommended, and we're very excited that the governor recommended also the construction of a new facility that's desperately needed. And we do think that all of this would make an enormous difference and keep us from having some of those concerns that other states have had.
Thank you. Members, any other questions? I am not seeing any. Thank you. You guys got off easier. After lunch, everyone's tummy's full. Thank you so much for the presentation. We look forward to seeing you as we dive into the legislative session for more in-depth conversations. And with that, we will go to the next item on our agenda for today, and that is the Division of Child and Family Services. Good afternoon.
Good afternoon, Madam Chair. For the record, Marla McDade Williams. I serve as the administrator for the Division of Child and Family Services. And with me today is Kelsey McCann Navarro, who is our ASO 4. I do have in the audience, both here and in Las Vegas, I have Dr. Jacqueline Wade, who is the Deputy Administrator for Clinical and Residential Services. She is in Las Vegas. I have Sharon Anderson, the Deputy of Juvenile Justice Services. She is here in the audience. Betsy Crumrine, Deputy Administrator for Child Welfare, also here in the audience. And then back down to Las Vegas, I have Lorianne Molina Lovell, who just started as our Deputy Administrator for Administrative and Support Services last week. So she is brand new to our division. And I have also back up here in Carson City, Kyra Morgan, who is our Medical Epidemiologist. And if I can figure out how to start this slide presentation. There we go, slideshow. And then we advance through there, right? Okay, thank you. Thank you. So, as you can see, our division mission is that together in genuine partnership with families and communities provide support and services to assist Nevada's children and families in reaching their full human potential. We recognize that Nevada's families are our future and that families thrive when they live in safe, permanent settings, experience a sense of sustainable emotional and physical well-being, and receive support to consistently make positive choices for the family and common good. Here is a representation of our organization chart. You can see that we have the 4 units plus the medical epidemiologist in the division. We have over 900 employees throughout all of these various units. Here is a summary slide of our primary division operations. You can see that in juvenile justice services, we have youth alternative placement, juvenile correctional care. You can see the list on down to Prison Rape Elimination Act compliance, Juvenile Justice Oversight Commission, and then we also have grant administration that we run out of juvenile justice. In children's mental health, we have inpatient treatment services as well as residential care, acute residential treatment center, early childhood services, outpatient treatment. We have intensive care coordination, crisis support services. We also are able to do training out of this unit. And then we have the Victims of Crime program. In child welfare services, we have child protective services, intensive family services, foster care licensing and placements. We manage the child abuse and neglect registry. We do eligibility determinations for federal programs for youth, manage the interstate compact for the placement of children, and we do services to foster youth, transitioning to adulthood, as well as adoption placement. And then finally, administrative support, the standard operations, personnel, payroll, fiscal, budgeting, grant administration, grants management, compliance oversight. In general, the division serves as a safety net, and it is essential for us to work with the Division of Healthcare Financing and Policy to determine where we need to step in and provide services. So with the Department of Justice settlement agreement, although the Division of Healthcare Financing and Policy is responsible for implementation, at the point that maybe they're not able to stand up a service, I think it would be our responsibility to step in and figure out how we can assist in standing up a service to ensure that we're all successful in meeting the DOJ agreement. But right now, we don't have any legal responsibility over that, so I'm thankful that Stacy, Administrator Weeks, is managing that process. I did want to say that as it relates to crisis services, we also will be working closely with the Division of Public and Behavioral Health on the 988 system as they stand that up. We do currently do some crisis response in Southern Nevada for children. 988, it is envisioned to be the call line, and then teams get dispatched, and we're hoping that we're able to continue to work with them to be one of those entities that dispatches teams out. The hope is that the network for mobile crisis responders is much broader out into the future, but again, that's a service that we would be able to step up and provide if needed. In terms of accomplishments, we are always very proud of being able to implement Positive Behavioral Interventions and Supports Program, or PBIS, and some of you this year earned the Diamond Level of Achievement Award for their successful implementation. Some of you is our highest level juvenile justice correctional facility, so it is really exciting that they are able to step up and implement something to this level. We also had a number of American Rescue Act plan projects. We did certification for youth peer support specialists, and again, we will continue to work closely with Medicaid as that gets carried out, but we were able to help develop the baseline for that. We also had funding for nurse apprenticeship programs, and then developed a network for intensive home-based wraparound services through ARPA funding. For grants, we were able to expand the Safe Babies Court into Carson City and Clark County, as well as build on the program that we have in Washoe County. We also have a $12 million 5-year system of care grant. And right now that is focusing on, again, provider training and building the provider capacity throughout the state, with the intent, again, that, as we stand up the DOJ, that these training services help Medicaid meet that responsibility. And then we also, again, intensive home family services. I did want to kind of do a shout out to our rural child welfare, we have responsibility called an agency improvement plan under foster care. And one of their goals is to ensure that children that we bring into the system are screened for early periodic screening, diagnosis, and treatment through Medicaid, EPSDT. And I just think the recognition by that group of staff of how important it is to get kids access to that service will be instrumental in the care that we are able to get to youth in foster care. Moving on to our budgeted funding sources, you can see that 51% of our budget is from state general fund dollars, 38% from federal funds, and 11% from other funds. A total of $768 million. For our major enhancements, we are proposing an intake assessment and placement center that would fund the development and implementation of a center that would assist youth who are committed to the state. It would ensure that they undergo clinical screening and assessments to determine the most suitable placement for those youth as they come into the system. Currently, while they wait for the completion of screenings, assessments, and transfers to the state facilities, they are in county detention, and they are not benefiting from the streamlined process that would transition them from the county to state care. And so by standing up this center, the intention is that we're able to do all of the work that needs to be done in screening them and start their programming sooner rather than later. It should alleviate some of the burden on the counties that are continuing to hold these youth while waiting for all of that other work to be done. One of the other things that you don't really think about, but it's time, right? And it's ensuring that you can actually gain access to the kids more than any intentional delay in trying to get them screened. So by having them in our custody earlier, that will no longer be a barrier. The next major enhancement is for child welfare, and it is the extended young adult support services proposal. In 2008, Congress passed the Foster Connections to Success and Increasing Adoption Act, which extended foster care up to age 21 for youth in the system. It allows us as a state agency to receive federal Title IV funds and share the cost of foster care, adoption assistance, and kinship guardianship for these youth. There was a legislative mandate to implement what we call extended foster care last biennium. However, through the budgeting process, it was determined that we really weren't quite ready to go. So another bill, Senate Bill 80, was adopted. It extended the time frame for implementation, and all of us child welfare jurisdictions have been working extensively on ensuring that we are ready to go. The budget that has been proposed for this includes costs for all the jurisdictions. We have some accompanying bill draft request language that needs to come forward, as well as some regulatory changes. We have gotten all of our federal approvals and are ready to go as soon as the budget is actually approved for this. And the implementation date in the legislation is July 1st, 2025, so right around the corner. We do have the next number of slides are all caseload. I won't really go through those, but they are they're there for you by jurisdiction. So starting with Washoe County Human Services Agency, the non-recurring adoption subsidy caseload, the family foster care caseload, and then the advanced foster care caseload, and then finally this specialized foster care caseload and the court jurisdiction caseload. Wow. Then there's KIN-GAP caseload as well for Washoe County, and then similar slides for Clark County, and you can see those as we go through. That will take us all the way through to, and then we have rural child welfare starting, I believe, at slide 23. And once we get to slide 30, just wanted to briefly go over the facility and service populations that we have at the Division of Child and Family Services. So under children's mental health, we have Desert Willow Treatment Center. So this is a licensed 54-bed psychiatric hospital that provides mental health treatment to children throughout the state. 24 of those beds are residential treatment facility beds. And then we have acute beds, and then we have pediatric beds as well in that facility. And it is currently under construction. So although it says 54 beds, we have 44 beds, and until we can get the final construction done, those additional 10 beds will not be able to come online. Our juvenile justice facilities, we have 3, and we deliver programming and services to youth between the ages of 12 to 18 at Summit View Youth Center, which is essentially our maximum security center for youth. It has a capacity of 48 beds, and it serves high school age males between 14 and 19 years of age. Caliente Youth Center, which is about 150 some miles from Las Vegas, has a capacity of 80 beds in 5 separate housing units. It serves males and females ages 12 to 18. And then Nevada Youth Training Center in Elko, which is also a staff secure facility, has 7 separate housing units, capacity for 64 youth, serving both males and females 12 to 18 years of age. Slide 31 is our biennium budget account summary. And then the next slide is our position summary. So you can see we added our vacancy rates for fiscal year 24 and compared to fiscal year 25. Very happy that we continue to make progress in filling the positions that we have. There are some outliers in here, but for the most part, we've made a lot of progress in filling positions. I did want to say that in our youth parole services, the process for hiring, actually youth parole and in our juvenile justice services, the process for hiring is really, really lengthy. I was on a call the other day. We went through the whole interview process, selected someone to hire at NYTC, and 5 months later, the packet was approved and that person had another job, right? They're not going to sit around and wait as we try to work through these processes. And a lot of it is simply the background checks, which are required, but that is a real barrier for us being able to maintain some of our hiring in those programs. We are requesting 56 netting 56 new positions in this budget, and they are primarily as a result of the new assessment center and the extended foster care proposal. We have 2 policy bill drafts, AB 7, which relates to the Juvenile Justice Oversight Commission and cleaning that up and making additional changes to ensure that it lines up with our federal requirements. And then Senate Bill 4, which relates to who can serve as a witness to consent to adoption. Currently, it's limited to social workers, and in our rural areas, we have a real struggle hiring social workers, and so it extends the time for adoptions to happen. So the legislation will add the ability for caseworkers to serve as in that role. So it's hoped to alleviate any added time to adoptions. And then, of course, we have the budget BDR related to the extended foster care program. And then another one on the Children's Trust Disbursement Fund to fund the cost of care, the cost for care. We are proposing eliminating that statutory requirement and allowing those youth to retain the funds that come forward for them. And that concludes my presentation, and happy to take questions.
Thank you so much. We do have a few questions. We're going to start with Assemblymember Hadidi.
Thank you, Madam Chair. And I just have a few questions relating to the budget and relating to the children that we have out of state. I know I had emailed the division a few weeks back, but there were still a few questions I had. When we had emailed, you had mentioned that there were still 70 children placed out of state, and I had requested more information regarding gender and ages. And when I was looking at the ages of the children who are currently placed out of state, I noticed that a lot of them were getting ready to age out. So we had many 16 and 17-year-olds. And so my question was, whose responsibility is it to pay for the children to come back to Nevada once they turn 18? Or what happens to the children? I'm assuming that's an expense the state takes on, but I wanted to be clear. I did not want to assume.
Thank you. For the record, Marla McDade Williams, Madam Chair, if I may respond to Assemblywoman Hadigi. I mean, as kids age out, they age out, right? And some of these kids are going to be in the child welfare system. So if they came back at 16 or 17, the child welfare system would still be responsible. They would be under that jurisdictional oversight. If they're someone in the juvenile justice system, then we would have to bring them back into the juvenile justice system, and be able to place them in one of our facilities. For private pay, they're going back to their parents. And depending on whether or not there are any other, if they've completed their treatment and they don't need additional treatment, then you're really looking for supports to be able to provide to them out in the community so that they can be successful when they come back to Nevada. It's a challenge if they didn't successfully complete their programming and they were rejected from the facility and having to come back, then we are at the same place that we are now of trying to find a suitable placement for them. Depending on the jurisdiction that has custody of those youth, is the one that is responsible for trying to find another placement for them.
I think my question was more along the lines of what happens if they are in the responsibility of the state and then they turn 18 when they are out of state. What happens to the youth then?
For the record, Marla McDade Williams, once they're an adult and they are able to make their own decisions, we can assist up to a point of trying to identify services for them and working with sister divisions and the counties to line up and get them access to whatever resources that might be available for them. But once they are adults, they really are out of our purview. And we would assist, but we don't have a legal obligation at that point to manage them.
I guess I just have one last question. When I was looking at the numbers, almost 25% of those 70 youth who are out of state are probably turning 18 within the next, I would say, year to 2 years. And so when they're 18, if they are in Missouri, then the state just leaves them in Missouri. The state has no responsibility in paying for their travel back to Nevada. And that's basically like, I just want to know what happens to them. If they turn 18 and they are in Missouri and they are in care of the state, then are they just on their own in Missouri, or is it the state's responsibility to make sure that they are returned back to Nevada?
Thank you, Madam Chair. No, they are still under custody of whoever made that placement, unless it's a family member. But if we would pay for them to come back to Nevada, and you know, some of these are under court jurisdiction, so the court would have to agree to us to release them. But generally, we are bringing them back and paying for them to come back to Nevada.
Assemblymember Bacchus.
Thank you so much, Madam Chair. Thank you for the presentation. My quick question for you is on touching on our juvenile justice facilities. I think last year, like with Caliente and Nevada Youth Training Center, both of them weren't really filled to their full occupancy. So I was curious, between the 3 different centers, what is the max occupancy, and where we are at with how many youth are in each facility?
Thank you, Madam Chair. For the record, Marla McDade Williams. I am going to have Deputy Sharon Anderson come up and kind of give you some of the specifics. I can tell you generally we are staffing them to about half, and that has to do with being able to hire positions. But Deputy Anderson.
Good morning, or afternoon, I'm sorry. Sharon Anderson for the record. Can you repeat the question?
Yeah, absolutely. And it may have been answered because it was very similar to this last session. I was curious where we are at with occupancy of our different youth facilities. And I remember when we were looking at Caliente and as well as Elko's Nevada Youth Training Center, it seemed like they were both at half last session. And so I was just kind of trying to figure out where we are with how many youths can go to these 3 different centers and how many are actually there.
All right, thank you for the question. To you, Chair, through you. The facilities are operating at staff capacity, and they actually do a lot of overtime to be able to manage more youth than they are actually staffed at. And so, yes, the numbers are lower than what their budgeted capacities are, but we do provide the services for the youth with the staff that we do have there, if that makes sense.
Thank you, Madam Chair. For the record, Marla McDade Williams. So, for example, Summit View has a capacity of 96. We have a budgeted capacity of 48 there. We may not have kids up to that full budgeted capacity because of staffing issues and necessary ratios for the Prison Rape and Elimination Act ratios. So depending on that and what we can manage in overtime, we can get you the current numbers of what our current staffing, or what our current number of youth that we have at each of these facilities today. And it will all be based on the staff that we are able to have hired at the time.
That would be great if Madam Chair would permit that.
That would be perfect. Senator Titus.
Thank you, Madam Chair, and thank you again for a presentation, watching out for our Nevada youth. I noticed on page 30, we talk about the facilities and the service populations for the different youth in different locations. And one of the things I don't see on here is the China Springs youth group, and I drive by that every day, and I know that it's something we've talked about every session that I've been here, and I know that the chair has been very involved with that. Is that now in a capacity where it is self-supporting, or through the judgeship and the state's not involved with that?
Madam Chair, if I may respond to Senator Titus, we have proposed in our budget funding for China Springs. So China Springs, there's 3 facilities.
Sharon Anderson, for the record. There's China Spring, there's Aurora Pine, and then there's also the Spring Mountain Youth Camp in Clark County.
And of those, we've only allocated funding for China Springs.
And we'll see that when we break down this
Yes.
budget later? Okay, all right, just wanted to make sure we have a conversation. Thank you.
Thank you, Senator Tice. That was going to be my question, so thank you. Chair Dondero-Loop.
Thank you very much, Madam Chair. I have a couple questions. So when you talk about the facility populations, and you say we have 96 beds, but we only have a capacity of 48 beds, can you talk about that a little bit? Like, why do you only have the capacity? Is it because you don't have staff to service those people or those citizens, or why is it you only have 48 beds?
Thank you, Madam Chair. For the record, Marla McDade Williams. It's just primarily what we were budgeted at. That is the limit, is the budget. If we were asked to expand and use all of the beds, so some of you, for example, we are going to use those beds for the assessment center that we are proposing, but in the other facilities, if we were to expand and use all the beds, we would have to be able to staff them up. And right now, we can't staff up to the numbers that we have.
Okay, and then a follow-up for that is the facilities that were housed on the, in Las Vegas, on the Charleston Jones campus, the Ross and Neal, that area. Those facilities there, is anybody in those facilities now, or are they all empty?
For the record, Marla McDade Williams. So we have building 12 and building 13, I believe, that are still currently occupied. As a result of the interim finance committee action at the last interim finance committee, we have subgranted to Clark County because those buildings were leased to Clark County. And so Clark County is working with those providers in those facilities to find a relocation for the current youth that are there. Now, they are still there, and as has been committed to, nobody will be moved from the facility until there is a location to move them to.
Follow-up, Madam Chair. So does that mean the youth that are there, does that include the young ladies that were shipped out of state, or does that only include, who does that include?
For the record, Marla McDade Williams. So one of those facilities was leased to Silver State, was leased to Clark County, and Clark County had a contract with Silver State, and that was primarily for boys with autism. So in the allocation that was given to Clark County, they will expand services. Currently, there were no girls' facilities that we managed. There was a proposal to do it, but as a result of the changes, but Clark County, through the allocation that we gave them, has committed to ensuring that they expand services and not just replace the services that are being lost. So where the goal was to ensure that they served both male and female populations that had that IDD need, that developmental disability need, they have committed to ensuring that they work with their provider to ensure that coverage.
So when will we see the, I guess, the full circle of that, so that we have the girls back in this state and the boys as well being serviced, so that we have female and male populations being serviced?
The subgrant, for the record, Marla McDade Williams, the subgrant that we issued to Clark County goes through December 2026. So the hope is that prior to December 2026, they have a placement. That includes girls and boys.
So just to understand, so those girls are out of state, so they could be out of state a whole nother year?
For the record, Marlon.
I know your hope, I'm sorry to interrupt you. I know your hope is that they'll be back, but is it conceivable that they will be out of the state for a whole nother year?
For the record, Marla McDade Williams, I mean, generally, youth are not placed out of state for that length of time, right? Because they're trying to complete programming, and we're trying to get them to the point where we can bring them back and assimilate them back into the community. Clark County, through its child welfare system, has to ensure that they can meet the needs of the youth. So they may or may not be out of state. We didn't have I didn't have 6 identified girls to put in. We were setting it up so when someone needed it, there would be the ability for us to place them there. So we were always in the same challenge that we have, which is just trying to ensure that we can meet their needs in state first, and then if we can't, looking for an out-of-state placement. Some people, as you know, we discussed before, will stay at Child Haven until they can get some other community level of care that could meet their need, manage their behaviors. But it is just a struggle that we face every day in this system of trying to ensure that we are able to place youth appropriately. So again, no 6 specific girls identified, but we were setting up a system that would allow us to place them, and we knew that they could benefit from that placement. But right now they're being cared for either in Child Haven or in a specialized foster home or in some other psychiatric residential treatment facility. But again, it is all about identifying their needs, moving them through a program to try to get them to a point to get them back into a step-down level of need, and then eventually back into the community.
Okay, thank you. I'll think about this and get back to you offline if I have more questions. Thank you.
Thank you, Chairwoman. We're going to go to Senator Neal.
Thank you, Madam Chair. I'm following this conversation, and I'm super confused because are we talking about the same set of autistic girls that we had on the record at the IFC meeting that said that they are the highest need and the highest to serve? And now what I'm hearing you say is that there was a program in place or a contemplation of a program in place to try to get them to a point where they could lower the threshold of care, but they are the highest need and really would probably always need care. Yeah, I'll stop there and then I'm going to go back.
For the record, Marla McDade Williams. When we look at Silver State and the boys that they had there, these were the boys with very challenging issues. Silver State is able to bring them in, give them skills, help them manage their behaviors, not with the intent that they stay there forever. Now, we do have other systems where, yes, people probably will be, we heard earlier in public testimony, right? Certain individuals who need a permanent living situation once they turn into adults. But right now with kids, we generally aren't looking for permanent institutional care for kids. We're looking for temporary institutional care to help everybody, to help them learn how to control their behaviors through the ability that these providers have to foster that. And again, we'd never have a goal with anybody of keeping them permanently institutionalized. It just isn't part of the system. It's always temporary, trying to get them to manage behaviors so that they can step down to a different level of care where they can still be successful, go to school, do what they need to do. That's always the goal with every youth that comes into custody into any of these institutional settings.
So, follow-up, Chair. So, in the jurisdiction question that Assemblywoman Hodeggy was talking about, you're saying that the county has decided that they are going to step up and take the girls. So, if they have aged out, jurisdiction becomes the county when? Because if you don't have a formalized agreement, right? And I don't really know how this works, if like power of attorney is then created and then the transfer happens. What happens if they age out and you don't have the agreement in place for the county to have jurisdiction over the girls?
Madam Chair, I think I'm going to ask Dr. Jacqueline Wade to come up. She has actual more experience in the actual care of the youth. But individuals will age out of the child welfare system at 18. And every jurisdiction is trying to ensure that we aren't just releasing someone to the street, that there is a plan in place that can help them meet their needs as they become adults. We won't have a written agreement with anybody after someone is 18, but we will always strive to ensure that they are safe as they can be. And but once they become adults, they get to make their own decisions. We do have systems in place to help certain adults, and you will hear that next in the next presentation. But Dr. Wade, if you can kind of talk about how that transition to adulthood happens for youth.
Madam Chair, before she talks about that, can I add if she's the expert?
Go ahead.
So can Dr. Wade, can you also answer, is it a common practice that if they've aged out and they have the fee-for-service Medicaid, that we are keeping a diagnosis on a child that may be in county jurisdiction, and we know that that assessment may not be accurate, but we're doing it because we want to keep the child on insurance?
Good afternoon, Chair, committee members, Dr. Jacqueline Wade for the record. If a youth is currently in state custody and they turn 18, that team typically follows them and work with continuity of care to transition them to adult services. So if we're talking about someone who's autistic, we would tap into Desert Regional Center to get services for them. Now, regarding the diagnosis, we know a diagnosis of autism, sometimes it is, the prognosis is that they keep that diagnosis, but certainly don't want to have a child with a diagnosis that is not the proper diagnosis. But they do work with their team to transfer to make sure that they have continuity of care to adult services. I hope that answers.
It does, but the nuance part, let's take autism out. Let's take just, trauma, PTSD, and some other diagnoses. At the county level, do they go and reassess and give the child a new diagnosis when they age out? Or do they keep them with the diagnoses so that they can keep their medical care, knowing that the diagnosis might have changed, but because we are operating on heart, we're not changing the diagnosis even though we know it's different?
Dr. Jacqueline Wade for the record. Thank you for the question. If a child has a diagnosis or someone is aging out, if there's any indicator that the diagnosis should be changed, because we don't want to do any harm, nor do we want to label a child with a diagnosis that's not appropriate, the county, I would think, would reassess that child or that young adult to make sure that they're getting to the right services that they need. I don't believe that we are not going to change a diagnosis to fit the individual.
Thank you for that, because I was asking because I'd heard multiple times, and then I asked some federally qualified healthcare centers that the diagnoses was not changing, and that because we want to keep them on their current medical care, that we are not reassessing, and we're actually keeping the diagnoses, and we're not checking to see if it's different, and then we're releasing them. And I don't know what the internal conversations are, how they release them, or does the child know you're actually not suffering from PTSD or whatever. I'm just using that as an example. But because we want to make sure that they have medical care, there isn't an actual reassessment, that they come in under an assessment, they keep that assessment, and then the county may not do another assessment before they leave. So an assessment could be, the same at 12, at 18. And I started digging into this because I went and got data on diagnoses, and I started trying to figure out the complexities, because there were children that were keeping 2 and 3 diagnoses, and I was like, why are they have this diagnoses at 7 and then still have the same diagnoses at 15, and there's no mitigation? And I do have data that I collected in the summer, early summer.
Dr. Jacqueline Wade, for the record, we would do harm if we're not assessing based on presentation of the individual. We want to have adults go to the right door and the right place and receive the right treatment. If we depend on a diagnosis from age 7 with someone who's 18 or 20, we would not be doing justice to that individual. Thank you.
Thank you, Madam Chair. Dr. Wade, I want to meet you. I want to share this data with you. We need to have a deep dive.
Thank you. I look forward to it.
Assemblymember Anderson.
Thank you, Chair, and thank you for the presentation today. My question is actually in a different area. It comes from slide 8, in particular, the extended young adult support services, and as it relates to Title IV-E funds. Has there been any discussion as to whether or not this will be changing based upon some of the federal guidelines that are also being discussed to change? And if so, how will that impact our children that are getting help from these services?
Thank you, Madam Chair. For the record, Marla McDade Williams. We have not had any of those discussions yet, but we will ensure that we have answers for you the next time we meet.
Thank you so much, because I know that this provides some very important services for some of our more rural areas. And then a secondary question, if I may. When I'm taking a look at the caseload projections under the Child Welfare Services, as well as some of the background information that was provided to us, it appears that Washoe County is basically flat when it comes to getting additional money. But Clark County, with good reason because of the larger population, is getting a slight increase. And then the rural area is getting also a slight increase. Is that correct, or am I reading that information incorrectly?
Thank you, Madam Chair. For the record, Marla McDade Williams. I am not an expert on the trends, but I am assured that the trends reflect the data that we have.
So it appears then that Clark County is, in fact, growing with the county child welfare need, and the rural county is growing a little bit as well, but the Washoe County is basically staying flat, for lack of a better term.
Yeah, and we can, again, give you more information about really what that really looks like.
That'd be great. Thank you so much. Thank you, Chair.
Thank you. And our final question in this area will go to Senator Nguyen.
Thank you. I just have a question because I didn't see any increases or anything to address this. I know for those of us legislators that have had the opportunity to kind of tour Child Haven down in Clark County, we've seen a lot of children that are in that facility that really have high needs, high like acuity issues, and they have been rejected or ejected from facilities such as Desert Willow Treatment Center. And it's my understanding that those treatment facilities or centers either have staffing issues or the acuity is too high. But I feel like we're taking them out of a situation that's not 100%, that's maybe 80%, and then putting them into a place that's like able to control this at like 10%. So what is the state looking at doing to like close those gaps so we don't have these high needs, high risk, like behavioral children with high needs in Child Haven as opposed to maybe not the best fit in a place like Desert Willow, but a better fit than Child Haven?
Thank you, Madam Chair. For the record, Marla McDade Williams, through you to Senator Wynn. We have made a lot of programming changes at Desert Willow. We generally, and I would have to defer to Dr. Wade, but I'm not aware of us kicking anybody out because of behaviors, because we are the last placement that they can consider. We have changed our programming to ensure that we can meet the highest needs kids, including kids in the juvenile justice system, so that we aren't sending those kids out of state and making them, somebody else's problem. Where the issue becomes is the private sector facilities. They can reject kids, and they do reject kids. And we are limited by the number of beds that we have. So for most of the summer, we were at max capacity in our residential treatment beds that we had. We couldn't physically take any more kids. I have a waiting list right now, I believe, of 7 kids. But we are not generally rejecting kids because of behaviors. We are trying to ensure that we can bring in the services that they need to treat them. Child Haven, is, you're absolutely correct. They're not capable. They're not a treatment facility. They can't manage kids. But we can only take so many kids. We have pediatric beds. I don't have full capacity in our pediatric beds. If we need to be looking at different programming to take pediatric kids from there, then I will be looking at that because we've made a lot of those changes over the last year to ensure that we can meet those needs. But again, our only real limit is the number of beds that we have. But the private sector, they don't have any obligation to keep anybody.
Thank you. I'm aware of that. I was just wondering if I didn't see any increases to like accommodate that. I know like in Clark County, last I checked, I think they had 8 people that were awaiting placement in facilities because of these wait lists and because of this interaction with the private sector that is rejecting or ejecting people. Was that ever a consideration in finding a way to increase the capabilities of the state at state-sponsored like centers?
I can only speak to Desert Willow at this point. Given everything else, that's Marla McDade Williams, for the record. We had facilities. We are having to reprogram those facilities that we had. Right now, the facilities that we do have, the inpatient, we have the psychiatric residential treatment facility in Reno, which we call PRTF North, and we have Desert Willow. As far as I know, PRTF North is full. And if we need to change, again, if I need to figure out a different way to manage the kids that I have in the pediatric unit so we can staff it up to youth 12 to 17, then I am willing to do that. And if we need to, we would hold someone to a contract to say you have to keep these kids, right? And we would have to pay for that contract. I mean, those are things that I'm willing to consider and, try to work through and see if we can establish that system. I haven't been asked to do that, but I'm willing to have those discussions. I can't be the taker of everybody, though, because we do have limited capacity.
No, thank you.
Thank you so much for the questions. And that was our last question on this subject. Thank you so much for the high-level overview. I anticipate a very detailed and long conversations during the legislative session on this. And that ends the conversation for the Division on Child and Family Services, and we'll move on to our last presentation of the day, which is Aging and Disability Services Division. Good afternoon.
Good afternoon, Madam Chair and members of the committee. My name is Dina Schmidt, and I serve as the administrator for the Division of Aging and Disability Services. I'm here today with Jessica Adams to my right, Ellen Crecelius, as well as Ricky Robb. And in the audience, I also have our agency manager, Jeff Duncan, our agency manager, Kim Adams, who oversees our quality assurance, and Carrie Embry, who oversees our adult protective and Office of Consumer Health Assistance. It's late in the day. I'm the last one. Luckily, I'm also the fastest talker, so we should get through this fairly quickly and get on. So we'll just jump right in on page 2. Our mission and vision, I will just highlight that this is a new mission statement for us. We have been through a recent project to rebrand our organization. More information to come on that, but this is a new mission and vision for us. On to page 3 is our organizational chart. You'll see that we have a variety of services across all of our units. And then on to page 4 is the summary of our operations, which is really the same information, but a little bit more detail about some of those programs within our Office of Community Living. Page 5 is our accomplishments. This is one area we'd like to take a minute to highlight some of the things we've accomplished over the last 2 years. Through the use of American Rescue Plan funds, we did contract with Change Innovation Agency to conduct business process reengineering. Some of you may recall the Division of Welfare and Supportive Services went through this process several years ago and incredibly improved their ability to determine eligibility. So in this project, a couple areas just to highlight. In our Developmental Services Regional Center, we often get urgent cases where people need urgent placement. Those were averaging 66 days for us to for intake, and now we're at 10 business days for processing those urgent cases. We also had our developmental services service request system. Used to take 26 hours, it's now 4 hours to approve those services. So we just wanted to kind of highlight that we've been able to, in our Office of Community Living, our intake and eligibility, we have a phone system that people call. In November of 23, 594 phone calls were received, and we answered 80% of those live. In November of the next year, of 24, we received 1,391 calls and answered 97% live. So this process was incredibly helpful to our agency and really gave us the ability to look at what we do and how we do it differently. So we're very proud of the improvements we've seen there. As you all know, we also implemented a new rate structure to support the developmental services system. This was funded last session, but it included an entire change of the rate structure. The way we pay for services changed as well as the rates changed. So that included quite a bit of collaboration with our partners over at Medicaid to make data system changes on our side, on the Medicaid side, in their MMIS system. And so that was implemented in July of this year. We were able to get those new rates in place and up and running. We also had 22 ARPA projects, which totaled over $46 million. A couple of those highlighted projects were working with the Ackerman Center on increasing the ability to diagnose kids with autism. There were 979 children received diagnosis, as well as 2,578 individuals who received additional services. In our senior nutrition services, we also served an additional 1,589 adults. One of the ones that I personally love is that in our residential facilities for groups, we added over 195 new community beds for older adults and people with disabilities. So we funded group homes that were existing to add on or expand beds, and so far we've had over 195 new beds come online. Moving on to slide 6. This is our budget by funding source. You may notice here a couple things. One, there's a federal reduction from one year to the next. That is primarily the reduction in ARPA-related COVID funds. And you'll also see an increase in state general fund. Just so to be clear, that is not directly related to the reduction in ARPA funds. It is related to mostly our caseload growth and rate increases. And just also to keep in mind, the other category for us does include Medicaid funds. Those are in the other category here, not under federal, just to be clear. Moving on to page 7, our major enhancements. We are super excited to finally work on getting a standardized assessment for developmental services. This system would create a non-biased assessment of an individual's needs, support service planning, would be consistent in predictability and cost. So it would really help us in our budgets to be able to project forward the needs for people and how much it's actually going to cost us, because we'll have that data up front in an unbiased manner. We also have a request for 2 epidemiologists to help us analyze trends, really, as Director Whitley mentioned, right, cause and consequence of health disease, particularly concerning opioid uses and how it's impacting outcomes of newborn children, developing children, and our older adult populations. This is an area we really haven't focused on, that we really need to focus on in order to start to look at what's creating the additional costs and how do we reduce our costs going forward. We also have a request for additional supervisory positions at our intermediate care facility. If any of you have ever visited that facility, it's individual homes. And right now we have supervisors who are supervising more than one home, and that is very difficult. Their supervision ratio is sometimes up to 1 to 20 or more. So what we're asking for is just additional supervisor positions so that we can have 1 supervisor per home. The next one is the transition of early intervention services to a fee-for-service model. What this is really reversing our current processes. Currently, we pay a capitated rate, and then they bill Medicaid, and we chase that money down. We're really just switching the process to them billing Medicaid and private insurance first, and then us paying the difference. And then lastly is the transfer of Part C to Aging and Disability Services. Moving on to page 8, major issues. Our caseload growth is one major issue that you all need to be aware. We'll go through our caseload projections here in a moment, but according to the Elders Count 2023, Nevada's adult population growth is going to continue to increase over the next 25 years. So this is just the beginning. We've talked about this for the last 2 sessions, that our population is continuing to get older, and those leading to greater demand on the services that we do provide, which is also reflected in major issue number 2, which is a supplemental funding request for this current fiscal year. So we have 4 supplemental requests across 4 different budget accounts for just under $20 million, but those are driven by rate increases as well as caseload growth and the reduction in federal revenue, which you heard a lot about in other presentations today. So starting on slide 9, we'll get into some of our programs. For those of you that aren't as familiar with these, I'll just give a quick background on some of them. First one is Adult Protective Services. They are committed to protecting and supporting vulnerable adults by investigating reports of abuse, neglect, self-neglect, exploitation, isolation, and abandonment. The mission of Adult Protective Services is really to further prevent maltreatment while safeguarding civil liberties. We assist individuals 18 to 59, vulnerable adults, as well as 60 and older. We ensure the safety and well-being of every person served with protective interventions. We often work closely with law enforcement. We are not law enforcement. We don't have law enforcement authorities in this program, but we do work closely with them and refer back and forth when there's illegal activity in a case. And moving on to slide 10, our long-term care ombuds program. This program ensures the residents of long-term care facilities receive the highest quality of care and support. Our ombudsmen advocate for those living in nursing homes and other residential facilities. They address complaints, conduct investigations, and try to help resolve issues. They also conduct visits to care centers where they speak with the residents, provide information about available services, and offer guidance. They do play a crucial role in enhancing the well-being of long-term care residents across the state. This caseload, as you can see, continues to be on an upward trend. The next program on slide 11 is our Autism Treatment Assistance Program. This program is dedicated to ensuring that all families, regardless of their financial situation, have access to essential treatments and therapies. We provide funding for families with children under 20 who have current autism diagnosis and lack insurance coverage, covering critical services like applied behavioral analysis and speech therapy. Our program not only removes the barriers to these vital resources, but also provides service coordination to ensure families receive comprehensive services needed to thrive. As you can see, this caseload also is consistently growing over time. On slide 12, early intervention services. These are essential supports at no cost to families, offering specialized instruction, audiology, physical therapy, occupational therapy, speech therapy, and vision services. Our goal here is to assist infants and children from birth to age 3 to reach their full potential through information and education, helpful resources, and family support. This program plays a crucial role in child's development, helping them develop, learn, and manage their emotions in a positive way. Staff provides special instruction, which supports parents in working with their child to gain skills, strength, and learning. And then we contract with specialists to provide clinical services such as occupational therapy, speech therapy, and physical therapy. The state is a comprehensive provider, and we also serve children in the child welfare system as well as medically fragile children. We also in Nevada have 5 community providers that also provide comprehensive services. Insurance billing has been a challenge for many providers due to the lack of a data system and small businesses having the capacity for administrative burden. Over the last 2 years, we have implemented a data system, and so all providers are able to use that system to bill insurances as well as the state. Moving on to slide 13, Office of Consumer Health Assistance empowers Nevadans to navigate their healthcare rights and responsibilities with confidence. We assist consumers with injured workers' claims, understanding their health insurance plans, and worker compensation policy. We offer essential information on eligibility requirements, appeals rights, quality of care complaints, and medical billing concerns. This is the first time that we have been able to establish a caseload for the Office of Consumer Health Assistance. We're really excited. They transitioned, if you recall, a few years ago from the director's office to our agency. And we did implement a data system, so we actually have more than a year's data now that we were able to use to establish a caseload for them. Moving on to slide 14, the caseload for our waiver for the frail elderly. This program connects individuals with in-home services such as home-delivered meals, house cleaning, assistance with bathing, grooming, cooking, and shopping. Services are determined by a licensed social worker who conducts an assessment and then assists the individual in connecting with these services. The actual direct services are provided by Medicaid-enrolled providers. And just so people get a sense, I'd like to just, an example of our frail elderly waiver. We had a 77-year-old woman who was admitted to the hospital for failure to thrive after losing her spouse. She didn't want to go to a nursing home, and so we were contacted in the frail elderly waiver. We assessed her needs and her goals, and our social worker met with her, and we were able to connect her to home-delivered meals, a personal emergency response system, personal care services, homemaker, and respite. She was fortunate enough to have a friend that was willing to be her paid caregiver, and then she later decided she really was missing socialization, and so we did connect her to adult daycare services where she is thriving and loving the environment. She loves the music and the activities, and so that's just a sense of what happens in a real life of what those services mean. Moving on to slide 14. This is our community service options program for the elderly. This program is a state general funded program completely, provides the exact same services I just described in the frail elderly waiver. It's a state general funded program that helps those folks that are just above the Medicaid limit while they're spending down their funds and to become Medicaid eligible. Moving on to slide 16. Waiver for individuals with physical disabilities. These are also in-home services to individuals with physical disabilities where the state is also a case manager and refers to Medicaid providers for those direct services. Of note in this caseload, there is also now a private case manager provider, but that private case manager only provides services in Southern Nevada. Moving to slide 17, this is the personal assistance program. Again, projecting an upward trend in personal assistance. Our wait list as well as caseload projections are both going up. And this is also a state general funded only program that mirrors the physical disability waiver. Almost there. Moving on to slide 18 is our caseload for desert regional centers. This is our developmental service programs offer a wide range of support through our 3 regional centers, ensuring people of all ages receive the services they need. We provide family support with respite care, counseling, in-home training, and financial assistance. Our employment and vocational training programs help individuals build skills and find meaningful work. Our residential support programs support individuals to gain independence while thriving in their own homes and communities. By coordinating these services, Developmental Services is dedicated to helping individuals and their families live fulfilling and independent lives. In this program, state staff provide case management, connecting individuals with those services, and the direct services are provided by contracted community providers. Last session, as I mentioned earlier, we did approve the rate increase and the rate structure change. And this session, you will see later when we get into the detailed presentations, a request to sustain those increases to allow our providers to continue to grow capacity and meet the continued demand in this program. So Desert Regional was on that page. The next page is Sierra Regional. You can see the same thing, continued demand. And again, on Rural Regional Center on slide 20. Moving on to slide 21, Family Preservation Program. This program provides a $486 monthly stipend to families who are caring for an individual with severe and profound intellectual or developmental disabilities in their own home. And on slide 22, we have the Office of Community Living, our Community Living Services. There's no caseload here, but I always want to make sure that we don't skip over this group. This is a program that is basically our federal grants and state funding that accounts for about $28 million of annual services that are provided to support older adults and people with disabilities, as well as their caregivers with their long-term support service needs. This is a program where we're also seeing an incredible increase in demand with a very uncertain federal funding future. And the list here you see are some of the services that are provided and grant funded in that program. Slide 23 is our facility population. We operate 1 intermediate care facility for adults with intellectual and developmental disabilities. We are currently licensed for up to 48 beds. We currently have 1 home that's under construction, and so we currently have 40 individuals residing in that facility. Slide 24 is our budget account summary. You can see a significant increase in the state general fund over this biennium on this slide. And again, rate increases, reduced FMAP are the reasons for those, and caseload growth. Moving to slide 25 is our position summary. You can see we're now over 1,600 employees. I think when I first started this position, we were just under 800. So we have continued to grow year over year to meet the growing demands in the community. So the majority of the increase you'll see here on the state staff is all related to caseload growth. So when the caseload goes up, we need more staff. And last but not least, we have 2 bill draft requests this year. AB 6 establishes the fetal alcohol spectrum disorder treatment assistance program within our division. Last session, we had a pilot program, and this just makes that, gives us the ability, enabling language for us as funding is available to provide those services and enhance those services across the state. And secondly is SB 8. This bill is just a cleanup bit language that aligns the definition across all of our programs. We're proposing changing the term related conditions to developmental disabilities. We had done that in a different chapter historically, and this one is just super simple, just cleaning it up in one section. And I know that was really fast, so I'm happy to answer any questions.
Sounds good. And thank you for the presentation. We do have a few questions. We're going to start with Assemblymember Brown-May.
Thank you, Chair. Thank you so much for this presentation. First, I would just like to note for the record, out of an abundance of caution, that my employer of record is a certified provider within the state that works directly with this division. I do not benefit personally by that, but I think it's important that we disclose. My question, Betty's Village, we heard about this morning, right? That is within Assembly District 42. Those residents are my constituents. And so my question is, how does this current budget that you're presenting respond to the concerns that were identified in public comment this morning?
Dina Schmidt for the record. So a couple things. I'll stick with just the fiscal portion of that right now. As you know, like as we've mentioned, right, we are in a current budget shortfall. Those rate increases from the last session we have had to freeze our current service and enrollment in services. So everybody can enroll and get case management, but we have wait lists for services within developmental services. In this budget, you will see an increase in requested services, $41 million in new money to address that demand. So our anticipation is if we get the supplemental, we'll be able to lift that freeze in this current fiscal year. But in our budget, you will see there's some e-decision units there that maintain the rate increase so that we can open services back up. And so there should be no impact. That would be the goal.
Thank you for that clarification. As you heard those families, I'm sure, first thing this morning, talking about their concerns for being at risk, for moving out of their residence into group homes and some of the situations that they experience with regard to group homes. Am I able to interpret that there's some level of assurance in this budget that the state will continue to consider services at that level, or is that an additional conversation for another budget meeting?
Jessica Adams, Deputy Administrator for the record. I think when you're talking about services like Betty's Village, we have, from what I saw, 44 people currently open to DRC living at Betty's Village. The vast majority of those people are living with very minimal services. They're getting some intermittent SLA services, getting help when they need it. We have a very small number of people living there that are living in one-bedroom apartments with 24-hour services. That service is very expensive. It's 3 to 4 times the cost of somebody living in those group services. These supplementals that we have put in and the budget that we had put in would not be cutting any of those services. It would be keeping those going. But we still have those conversations on an individual basis to see if that is in fact the best place for that person to be living.
Thank you for that clarification. Thank you, Chair. I have another question about early intervention, but I will let my colleagues go first.
Okay, we'll come back to you. Senator Nguyen?
Thank you, and maybe I will ask the same question that my colleague was going to ask. I have some questions regarding the E266 budget cuts to community providers. I know that last session we made some significant increases to help those community providers. I think we bumped it up to about $759 or somewhere around there. And it appears that in the governor's proposed budget that this is cut by approximately $12 million annually. And so obviously that's pretty significant. So I'm wondering if you can talk about what those cuts mean for those community providers that provide those early intervention service programming and the families that it supports.
Dina Schmidt for the record. So one of the things that we, obviously there's always a limited amount of resources, right? And so we were having budget discussions and it was identified that in the early intervention program, the way we currently pay is we pay up front, and then providers are required to bill Medicaid or private insurance, and then we have to recoup that payment. What you see here is just, and so that's why our budget was as high as it was, is because we use state general fund to do that. That is actually against the Medicaid payment rules, as well as the Office for Special Instruction. So we identified that we are out of compliance with those two, even though the two rules conflict with each other, we're out of compliance. And so what we did was look at what would it look like if we billed first and then supplemented second, right? So the state does pay a supplemental payment for non-billable services such as special instruction and some administration and oversight. Because these services are provided under the Part C grant, the Part C has a certain set of requirements that providers must do. And so we supplement and pay for those required services that are not billable, currently billable. So what you see here is an assumption. The reduction is the assumption that they will now get that money from Medicaid or private insurance when they bill first, and then we will continue to pay that additional funding up. So that $795 was always intended to be reduced. Our provider agreement was modified a few years back. And if you think about it this way, we've done this with every other provider. We went through this years ago with the Autism Treatment Assistance Program when we used to fund general fund and we made them start billing. We went through it, I believe, when I was at the director's office with SAPTA. SAPTA providers were required to start billing instead of the state paying those funds up front. So this is really just changing that model where they are required to bill first and then we reimburse for the non-billable services.
May I follow up, Chair? It's my understanding that the total caseload is approximately 4,000, and that's roughly split evenly between like the community providers and the state facilitated services. And within that, I mean, the community provider rate, like you said, we had increased it last legislative session to about 700. I have the number here, and I know I've been instructed for our staff that I should be very clear on the numbers. It's my understanding the number is approximately $794.88. Did I say that correctly? With the approximately in front of it. And the state facilitated services rate is approximately $1,080.05. Is my understanding correct on that?
Dina Schmidt, for the record, you are correct.
I guess my concern with moving into this new payment model is not that it's not necessarily the best practices and it's not something that we should try to shift, obviously, what would be about $24 million in general funds over into this other payment model. But what kind of involvement do we have with those community providers about implementing this new payment model? I mean, if those community providers leave the program, that means the state is picking up that 50% of that caseload. And so what would the overall fiscal impact be to the state if those community providers decided that they did not want to bill in the new payment model and like leave?
Dina Schmidt, for the record. So the intention is not to have anybody leave the system. Obviously, we removed the 50-50 split in the, 2 sessions ago for that reason, to allow for our community providers to increase their capacity and to serve more children, with the goal of the state reducing the number of kids the state serves. I would say the fiscal impact would be due to lack of billing, right? Right now, the community providers are billing 6% of what's allowable. They're receiving 6% of the payments that are allowable. So we can't continue to supplement that when every other provider type across the state is required to bill Medicaid or private insurance. So there's no intent to do harm here. It's really a matter of just switching that model and figuring out what the difference is that's non-billable so that we're supplementing them. We totally agree and understand there are non-billable services that they must provide, and we intend to reimburse them for those. But we also have an obligation fiscally to make sure that we are maximizing federal funds that are available to the state. And so this is really, like I say, just a reversal. We are here to help these providers. Our team has been on numerous calls with the providers. We met with them as soon as we identified the compliance issue to try to give them a little bit of a heads up, but of course, the budgeting process is confidential at a certain point, and we were unable to give them detailed information. But we are meeting with them on a regular basis. Our fiscal team has been meeting with them, providing online training, technical assistance, everything we can do. So there's no intent to do harm here. The intent is to work together to figure out how to make this process more viable for both sides. And yeah, I'll have Ricky add a little bit there.
Good afternoon, Ricky Robb, Deputy, what am I? Sorry, Deputy Administrator for Aging and Disability Services. Just wanted to make sure you guys were awake. I think the main thing that we want to make sure everyone understands is the last thing we want to do is to lose providers. And that is the conversation I had with them this Friday and 2 Fridays before that. They are part of the system, and they are the makeup of the system as well. This should not be a state program, state-only run program. I think the biggest concern that we have today is that we're out of compliance on 2 levels, Medicaid billing as well as the Office of Special Education's payer of last resort. So the fact that we're out of compliance on both of those items is a challenge. We also know that you guys are going to ask us about maintenance of effort. What does that look like? That's something that we've already notified OSEP, and we will continue those conversations. But I think at this point, we also have to really look at how are we doing this? Are we being good stewards of our state dollars? And I'll be honest with you, today, we're not. And I don't want to come back to this body in 2 years when they say, Ricky, you have an audit. Not only on the state providers, but on the community providers. Who's going to pay that back? And I know those community providers are going to look to us, but I want to make sure that we're doing this right the first time. We know that we have compliance issues. How do we get there? This was our best ditch effort to get there in a manner that doesn't do harm, but I know they're nervous, and I want to acknowledge that. And I want to be, as the last 7 years, this has been our goal, is to flip this. We have created a comprehensive billing and data system for them to bill directly with the state at the same time so that we could support them. That went live December 1st of 2023. My most recent data is just under 6% that we're seeing their billing. We are going to update that because we've been pushing on them a lot lately. I believe it's increased, so that's a good sign. But just wanted to make sure you guys know this is not to do harm. This is to support our system. If we don't, this current model is not going to continue. And not only are we going to do harm to the providers, but to my special babies. And that's the last thing we want to do. So we are here to work with this body as well as the system and OSEP to ensure that we find the right way to do this for these children and families.
Thank you. Majority Leader, do you have a question? Okay. Senator Titus.
Thank you, and thank you for the presentation. I know these are difficult discussions. As a medical provider, when I bill an insurance company, and then if insurance company will pay so much, and then even as a patient, then I will get a bill if my insurance doesn't pay. Then I have to pay the difference. In this particular realm, when the providers bill the state and the state, or so you want them to bill the insurance company first. And so when the insurance company says, yeah, you billed me for $900, but I'm only going to pay you $200, it's my understanding that that provider then cannot go back to that family and ask them to pay. Is that correct?
Ricky Robb for the record. Yes, that is correct.
So where does a provider, how is a provider made whole? And why would they continue then in this model and see these patients?
Ricky Robb for the record. Currently, that $794.88 makes them whole. But because to ensure that we are compliant with the Medicaid rules, and they cannot accept something additional, the challenge is we have to figure that out for the private providers because Medicaid is Medicaid. That is payment in full, correct? And then we do have that supplemental that we have proposed, which is currently $199. But we also have some information that could take it up to $287 based on a previous rate study. So we can talk about that as we navigate the next meetings that we'll be having together. But that is a conversation we need to have because if they have a high deductible or, that family, it's going to be billed, but then the deductible is on the family, correct? And so currently, that's how every other deductible payment is created for all of us who have private insurance. So that is a conversation that we need to continue to determine, is there a model that we could utilize? In ATAP and the Autism Treatment Assistance Program, we do have an insurance assistance program. But we also have to make sure we do our due diligence to make sure that we're not, ABA is very different than speech, occupational.
Right, and I know if I might follow up with that, Madam Chair, because in some of the billing process, it might be months, 6 months before I'm reimbursed, and so I'm carrying that. So there's some sort of process that the providers need to be reimbursed in a timely manner so they continue to be willing to see these kids and that we don't lose any providers, as you said you don't want to do. Does the state community providers bill private insurance, or are they only seeing the kiddos that don't have insurance?
Ricky Robb, for the record, no, we are, we bill Medicaid, we build all services, so whether it's fee-for-service, MCOs, as well as private insurance. I can give you statistics on that today based on what's submitted and what's entered. And the community providers do the same. So as a comprehensive provider, we must, based on OSEP guidelines, must provide the exact same services, whether that's teacher or visually impaired, speech, OT, we have to provide the exact same thing, audiology, dietitian, and they have to bill the same way, private or Medicaid.
Thanks for that clarification. Thank you, Madam Chair, for the questions.
Thank you. Assemblyman Haven.
Thank you, Madam Chair. And thank you guys for the presentation. I just wanted to touch on the private providers. You said that only 6% of them or could you clarify the 6% a little bit more? I just want to understand, are 94% of them just not billing their time? And then if that's the case, why is the state paying for it if they're not actually billing their time?
Ricky Robb, for the record. Thank you for that question. So my apologies on the 6%. So currently, what they are billing about 6%. So they might be submitting it, but then they might get a denial. Some are stopping at that denial, so they never get to the reimbursement piece of it. Currently, we're supplanting State General Fund for that difference. We need them to bill from providing the service to entering it into the system all the way through any denial, because it could just be an error. And then that is their payment in full if it's Medicaid. So it's not 6% of the providers, it's 6% of what is billable and reimbursable is what we're seeing in the system.
Follow up, Madam Chair. Thank you. So the 6% is Medicaid?
Ricky Robb, for the record. It could be Medicaid and or private, any type of insurance.
In the event that Medicaid gets rejected, is there a way that, since the state runs Medicaid, that we could help assist to streamline this process so that the reimbursement from Medicaid is, I think Dr. Titus said it could take some time. Can we expedite it? Is there a way to help make it so it's more appetizing for the private provider to, bill and then hopefully collect faster through Medicaid?
Dina Schmidt, for the record, so thank you for that question. We have been working and in touch with our Medicaid partners. Administrator Weeks has been very clear with us that and her team has been on these meetings with our community providers to hear their concerns. So they are working on a couple of things. One is designating these providers as essential providers, which helps with the enrollment in managed care organizations. They are looking at the rates because clearly some of these services must be provided in Part C, they must be provided in a home setting versus a clinical setting, and so the rate doesn't account for that. So we are working with Medicaid on addressing those issues and concerns. So yes, we are all working together to make sure that the providers are able to get reimbursed on a timely manner and in full.
Thank you. Thank you, Madam Chair.
Thank you. Members, any other questions? Not seeing any. All right, thank you so much for the presentation. Again, another subject matter I know we'll go very deep into as we get through this legislative session. So thank you for being here with us this afternoon. And members, that brings us up to the last item on our agenda, which is our second opportunity for public comment. If you are watching and would like to call in for public comment, the number is 888-475-4499. Today's meeting ID, again, is 835-3765-6197, and then please press pound. We will start here in Carson City, then go to Las Vegas, and then to the phone lines. Please remember that you only have 2 minutes for public comment. And we'll go ahead and start here.
Thank you, Madam Chair and members. My name is Benjamin Challinor. That's BenjaminChallinor, and I am the Nevada Director of Public Policy for the Alzheimer's Association. I'm here on behalf of the nearly 55,000 Nevadans living with Alzheimer's and dementia, and their 84,000 caregivers, providing 142 million hours of unpaid work that is valued at $2.6 billion, and that's just here in Nevada. In 2004, Nevada began the respite voucher program for those caring for a person living with dementia with an annual maximum of $1,000. These respite funds provide short-term relief for primary caregivers, giving them time to rest, focus on their own health, travel, visit family and friends. Respite assistance, we've seen, has one example is one caregiver was able to undergo surgery and receive treatment with the reassurance that their loved one was receiving safe and proper care at home. A lot has changed since 2004, but the annual maximum award amount of $1,000 has not. Increased cost of both in-home care and outside facilities such as adult daycare and overnight stay have reduced the effectiveness of the respite grant. In 2004, $1,000 could provide a caregiver of 56 hours of in-home care per year, 21 days of adult daycare, and 13 days of overnight care. In 2024, that same $1,000 provided 28 hours of in-home care per year, 12 days of adult daycare, and only 6 days of overnight care. The association's hope is that is for a modest increase of the amount that's awarded to ADSD for this respite grant, so that we could increase the respite, the maximum amount per year, while not reducing the families that we serve. So, thank you.
Thank you. Go ahead.
Good afternoon, Chair, members of the committee. My name is Emily Walton. I'm with a company called Wonder School. We work on childcare issues with states all over the country. And one thing that we see that leads to success is the state doing as much as they can to have the entire issue of childcare owned and centralized so that access to childcare is under one umbrella, not just the subsidy and the licensing piece and the other early education pieces, but the overall increase to access for the childcare. Nevada's childcare system is currently shared by DHHS and the Department of Education, and I know they do a wonderful job. And also, right now, it's not really anyone's job to increase the amount of overall childcare. Streamlining this can focus the allocation of resources. Like many other states we work in, and according to many studies, I know you just had 3 released in this state over the past 6 months, we know there's thousands of Nevadans who need access to childcare, but they make too much money to qualify for the subsidy. Recruiting more providers who are great at providing care, but they haven't necessarily ever owned a business before, will be an important aspect of getting more childcare into your system and getting those folks through the licensing process. Thank you.
Thank you. Seeing no one else here in Carson City, we'll go to Las Vegas. And you can go ahead.
Hi, it's Chrissy Costanza again. And I had 3 more points that I just wanted to make real fast. That the families do understand that 24-hour care is expensive in an ISLA, but I'd also like to point out that so is a nursing home. When a more involved individual has a medical issue, a 4-bedroom home in the community will admit them to a hospital and refuse to have them back. Next step for them is a nursing home. In addition, most homes in the community are not ADA compliant, and the state does absorb those costs of modifying a rental home to make accommodations for individuals that are physically challenged. Betty's Village is turnkey and already ADA compliant. And finally, I just wanted to recap on the slides here, your mission, vision, and values, where Nevadans, regardless of age or ability, will enjoy a meaningful life led with dignity and self-determination. The mission is to empower individuals and their support system by providing resources for disabilities and aging, connecting Nevadans to services, and improving their quality of life. because you value respect, accountability, and inclusivity. And from what the families and the individuals that are living in these 1 and 2 bedroom ISLAs have seen thus far is completely contradictory to what you're presenting. Thank you.
Thank you. Not seeing anyone else at the table in Las Vegas from the view that we have now. BPS, do we have anyone joining us on the phone line that would like to make public comment?
Thank you, Chair. To provide public comment, please press *9 on your phone to take your place in the queue or raise hand in your Zoom window. Thank you. Hello. Caller, you're unmuted. Please proceed.
Thank you. My name is Tracy Manning, Manning. Again, I'm a crier. Excuse the tears. Just try to hear me through. My daughter, Caitlin, receives services through DRC. She uses a wheelchair due to her cerebral palsy from a bad birth, no fault of hers. Caitlin needs assistance with basic everyday functions of life, such as toileting, bathing, and preparing her food. Caitlin is another beautiful heart that lives in Betty's Village in a 1-bedroom apartment. We were told this could be her forever home, which gave her father and I peace of mind. We're not young parents. I'm 65 and Caitlin is 79, or Donald is 79. Thinking about Caitlin's care after we're gone is what keeps us up at night. Until seeing Betty's Village, Caitlin planned on living with us forever. Now Betty's Village is her home, and our house is her weekend retreat. DRC is now saying that people living in 1 or 2 bedroom units are not physically intended to be supported, and the goal is to evict them from their homes into 3 or 4 bedroom units. That is not what any of us were told when we moved our families into the 1-bedroom units at Betty's Village. And to change the game plan at this point and evict people from their 1-bedroom homes because of what seems to be poor physical planning seems unethical and cruel. You are now discriminating against the most vulnerable citizens of the state. Caitlin has blossomed into such a beautiful young woman. She is happy at Betty's Village and loves showing off her apartment to her friends and family. It reflects her personality, fun, bright, and happy. Caitlin and her friends deserve the ability to stay in their 1-bedroom apartments, which are their homes where they are safe and protected. Caitlin has no defense mechanism to protect herself. We feel it is unacceptable to force the most vulnerable into potentially dangerous situations. Thank you very much for listening.
Thank you. Next caller.
Caller, please press the audio button in your Zoom window to unmute. In the lower left-hand side, there is a microphone icon. Just press that icon to unmute.
Just making sure you can hear me.
I can hear you. Please proceed.
Thank you. My name is Jody Collins, Jodicollins. I made public comment at the beginning. Thank you for taking more comments at the end. I just had one observation and made me think of another question, which is Dana Schmidt from DRC mentioned that they are looking at each case individually for our children who are living in 1-bedroom, well, young adults who are living in 1-bedroom ISLAs at Betty's Village, and they are determining if it is the right placement for them. So I am wondering if some of those parents have already been called, which is my fear every day waiting for that call to come to me, is how are they determining if that is the right placement? And what does the criteria for that look like? And again, we are hoping that those who have already been placed there and who are thriving in this environment and who are happy and are giving these parents, like myself, peace of mind, that they continue to maybe grandfather those in if this cannot be a possibility in the future. Thank you for listening to our comments.
Thank you. Thank you. Next caller.
Caller, you're unmuted. Please proceed.
Good afternoon, Madam Chair and everybody on the committee. This is Anna Binder, so I'm going to apologize. I'm sick, but I did stay home. So in addition to what you've heard from constituents today about Betty's Village, this is affecting a lot of people. But I don't, and I'm sorry, I missed it if they didn't mention it earlier, but we were also told that DRC stopped processing referrals for services at the beginning of last year because of budget issues. And so they were able to maintain servicing like their existing people, but then everybody else got put on a wait list. And I don't know if that was discussed today either, but whatever discrepancy in their budget that they had in the last biennium, we need to make sure is resolved because we can't have families in the community waiting for services for over a year as well. Thank you.
Thank you. Next caller.
Chair, the line is open and working. There are no additional callers at this time.
Thank you so much. So with that, we will end public comment. Members, we will be back here tomorrow morning at 8:30, where we'll hear presentations from the judicial branch courts, the Department of Motor Vehicles, the Department of Taxation, and the State Department of Agriculture. I wish you all a safe drive home. The roads might still be a little icy, so be careful out there, and we will see you tomorrow morning. This meeting is adjourned.